Ms. Gomez, and Ms. Fincher, and O'Donovan Zavada. All right. So good afternoon, everyone. I hope you're all doing okay. I hope your date has been beautiful like mine. So anyway, good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. It's great to see you all. I'm the chairman, Jocelyn Peña-Melnick. This is our first session back in person since 2020. So I ask for your patience if we encounter any technical streaming issues. Please set your electronic devices to vibrate and don't hold conversations in the committee room while testimony is happening. That goes to all of us. Also, no food or drink allowed in the gallery because staff has to then clean it, and they work really hard already. So thank you for, being careful. Avoid throwing liquid in the trash as well. As a reminder, we're going to hear from the bill sponsor and the bill sponsors panel, followed by an all in-person witnesses. We call on people in the order they sign up. We will hear from favorable with amendment, and unfavorable. Then all virtual witnesses in the same manner, favorable with amendment, and unfavorable. The bill sponsor testimony is not limited, but please don't take more than 10 minutes. While all witnesses will have 2 minutes to provide testimony. A timer is displayed on the screen and a sound will be played once your time has expired. Please be respectful of that timer. Don't continue to talk for another 5 minutes. Please adhere to our usual committee rules. This is for our wonderful members of one question and one answer from the panel so that we don't end up here all night. Remember that a lot of the work is done in subcommittee, and you can also talk and ask people offline. Keep your question brief. Only one witness will be allowed to respond to one question. So the sponsor, please decide who's the best person to answer that question as well. Members and witnesses will have an opportunity to engage in further discussion, as I said, in subcommittees. Members of the public will be able to view this live stream on the Maryland General Assembly website and on YouTube. Today we will hear the bills in the following order, which is first A12, which is Delegate Rosenberg, and he's there already with his panel. Thank you, Delegate. And that's followed by House Bill 571, followed by 517, 813, 539, 357, 374, 382, 650, and the final bill of the day, 785. Delegate Rosenberg, good afternoon.
Good afternoon, Madam Chair and fellow members of the Health and Government Operations Committee. Last year at this time, we put great time and effort into the Abortion Care Access Act to make sure that whatever happened to Roe itself, that residents of Maryland would still be able to access reproductive health care, that they could still make their decision and there would be sufficient professional help provided for them. We're here today because what we did last year is now in jeopardy for residents of this state and for women who come to this state, whether it's from West Virginia or one of the dozen-plus states that, in the wake of the Dobbs decision by the Supreme Court overturning Roe, have to go elsewhere, can't get reproductive health care where they live, and have to come to a safe haven to get that care. And this bill provides the necessary protections, privacy protections, that for both the woman and the healthcare providers. Why is this needed, you might say? This is not a hypothetical. I have included with my testimony the relevant provision of the law of Texas that enables a private citizen, any private citizen, to bring a civil action for someone who is a resident of Texas but has received health care that violates the restrictive Texas statute. And the minimum payment, the minimum award is $10,000. So this is not about hypotheticals. This is about health care for the people whom we represent and for women from across the country who will be coming to Maryland because of the health care that we are so proud of that we can provide to receive their reproductive health care. You've heard already about the 10-year-old who had to flee her home state, Indiana, to go to Ohio to receive health care, to receive an abortion. The stories will continue, but it's our obligation to do as best as we can to protect women and healthcare providers who do what is perfectly legal in this state, was legal under Roe, was legal under Senate Bill 162, which is the bill that was passed by the legislature in 1991, approved by the voters, 62 to 38% on referendum the next year. Let me just highlight three aspects of this bill. If a Maryland resident, for whatever reason, needs, seeks, obtains reproductive health care out of state, they would be able to request that that information not be made available to anyone else. We take great pride as a state, as a country, in the modern provision of health care, but it means that if I go to the Rite Aid or the Walgreens up the street and get a prescription, that information is accessible. And that's the second provision of the law, that if you obtain, as a Maryland resident here in this state, mifepristone, pardon me if I, with my liberal arts background, if I didn't say it correctly, but I'm told I did okay. That, without your consent, is private because they're coming after you if you take that drug for medical abortion. Finally, for all practitioners in this state who provide care as specified in the bill of reproductive health care, and this is of great importance to nurses, but all healthcare practitioners, that information would not be accessible. It would be private under our Public Information Act. There would be an exception. So that is what this bill does. It continues the storied history in this state of being in the forefront of protecting a woman in her decision-making and in her health care when it comes to reproductive health care. And I would urge a favorable vote. Thank you.
Good afternoon, Madam Chair, members of the committee. My name is Robin Elliott, and I'm here today representing Planned Parenthood of Maryland. And really want to thank Delegate Rosenberg for his leadership today, but as well as for his leadership in 1991, being the floor leader that brought Question 6 to the voters to eventually be ratified in 1992. This bill really is a continuation of Maryland's work, and it pairs with another very important bill that is going to be heard in the Judiciary Committee next week, and that bill is House Bill 808, sponsored by Delegate Nicole Williams and HGO's own Delegate Terry Hill. And what that bill does is it essentially creates a shield around Maryland. So as states like Texas and Missouri seek to criminalize, sue, or take away the licenses of people within our state that our state creates a shield and does not share that information. This bill is part 2. As you all know, sitting on the Health Committee, our electronic health records are very connected around the country. So that means literally every day we are sending hundreds, if not thousands, of pieces of information about reproductive health care, including abortion data, to other states. It goes to the treating provider, but it could be easily subpoenaed in another state without a shielding law. The second thing I wanted to emphasize, as Delegate Rosenberg said, mifepristone, if it remains legal, there's a court case, will be dispensed by Walgreens and CVS. This is wonderful for access, but what it means is that the identity of abortion providers will soon be everywhere across our state and across our country, and this bill provides protections so that they can continue to provide abortions and that they can protect themselves and their families. Happy to answer any questions. I know we have other wonderful witnesses.
Thank you. Next, please.
Good afternoon, Madam Chair, members of the committee. My name is Jakia Johnson, and I'm here today on behalf of Maryland National Organization for Women. On June 24th, 2022, after nearly 50 years of precedence, the Supreme Court struck down Roe v. Wade. With that decision, trigger laws in at least 22 states immediately banned or severely limited abortion, and in some states like Texas, private citizens were given the authority to enforce these laws in exchange for cash, a move that Justice Sotomayor compared to Wild West-style bounty hunters. In Maryland, we're fortunate enough to be governed compassionately and autonomously. However, we still have a significant number of vulnerable people in our communities: college students. Students who attend college in Maryland but have primary residence in states with restrictive abortion laws are at risk of government access to and weaponization of their private health information. When a student visits their campus health center and reports a late period or needs to access services from an abortion care provider, those health records will be available to their home state physician, and in a state where the act of abortion is defined as a crime, those health records will be used to impose civil litigation. House Bill 812 will protect those sensitive health records so that what happens in Maryland stays in Maryland. When students can take care of their reproductive health needs without the fear of being accused of criminal activity, they're better suited to achieve their educational and professional goals. And for that reason, I urge a favorable report on House Bill 812. Thank you.
Thank you for being with us today. We have 3 virtual witnesses. We have Dr. Michelle Gomez, Dr. Danielle Fincher, and Christine O'Donovan Sabata. Will you be so kind and allow all 3 of them, please? Thank you. And for the committee, if you would just be patient, they'll come up in a second. Good afternoon. Why don't we start with Dr. Danielle Fincher?
Hi, Madam Chair and members of the committee. Thank you for hearing my testimony in support of HB 812 today. My name is Danielle Fincher. I'm a family medicine trained physician who is also an abortion provider in Maryland. I went to medical school to be an abortion provider. That was the reason I went and the training that I sought out. And with that, there are certain risks that I knowingly and willingly took on for me and my family. And there are other doctors who have the same training, but they are not willing to take on that risk. And as it stands now, people who, providers are put at risk for prescribing normal medications to their patients, and there are other people who have the training and the knowledge and the willingness to provide abortions, especially sending misoprostol and mifepristone to a regular pharmacy, but they're not willing to take on the risk. And so as it stands, prescribing mifepristone and misoprostol is dangerous for the doctor. And keeps us from taking care of our patients. So this bill, if we don't pass it, people who are already doing the work, like myself, it increases our risk and basically amplifies the target that's already on our backs. In addition, it'll discourage other providers from prescribing these medications to patients. So I really urge us to, for a favorable vote for House Bill 812, because one, it'll help protect us who are already doing this work. And in addition, it has the opportunity to increase access because there will be more providers willing to prescribe medication abortion to their own patients if they know that it's safe for them to do so. So thank you for hearing my testimony. I appreciate it. Thanks for your time.
Thank you for your time today. Let's do Dr. Gomez, followed by Dr. O'Donovan.
Madam Chair and members of the committee, thank you so much for having me here today. My name is Dr. Michelle Gomez, and I'm a family medicine physician and faculty with the University of California, San Francisco School of Medicine. I'm also proud to say that I grew up in the great state of Maryland, and I'm grateful for the excellent education I received in Montgomery County Public Schools. I've been providing and teaching both primary care and abortion care for 20 years, and I'm here today because I'm very concerned for my patients and my colleagues. Let me give you two examples from my own experience. I have patients who live in Texas who come to me in California for abortion care. One of my Texas patients continued to bleed after she returned to Texas, so she went to the emergency room. That day, I got a notification through my electronic medical record, EPIC, that the patient was seen in a Texas ED. I could see the whole visit. That was the first time it occurred to me that everyone who saw her in Texas could also see her entire visit with me. They knew she had had an abortion. She was referred to an OBGYN in Texas who could also see that she'd had an abortion. How many other people, nurses, social workers, billing people, etc., had access to that information? What if someone had said, I know her, and I saw her here in Texas that weekend, so I know she didn't leave the state. I bet she lied to that doctor and had someone in California mail those pills to her here in Texas. Under Texas law, I could be punished with life in prison and or a $100,000 fine just for helping a patient do what she felt was best for her own body and her family's future. Also under Texas law, anyone close to my patient who may have known that what she was doing could be sued for $10,000 and serve up to 5 years in prison for aiding and abetting her. So far, this hasn't happened, but it's only a matter of time until it happens to someone. I am now forced to use paper medical records for all of my out-of-state patients, which may put me in violation of other laws. One more example with more serious consequences. A colleague of mine in Tennessee saw a patient for an abortion. The patient went back to their home state of Kentucky and had a similar experience, bleeding that sent her to the ED and then to an OBGYN. A CPS case was opened on this patient, and she's now dealing with all the ramifications of being accused of being an unfit mother to her children. Please, I urge a favorable report. This is urgent. These are real human lives, and Maryland has a chance to be a model for the rest of the country. Thank you.
Thank you for your testimony today. We have Christine O'Donovan Savada.
Hi, just to clarify, I'm a patient, not a doctor. In the summer of 2018, because of a broken condom and a failure of emergency contraception, I got pregnant. At first, I didn't realize, and it took several weeks of violent nausea for me to realize that the emergency contraception had likely failed. When my pregnancy test came back positive, I felt a horrible pit in my stomach. I felt a total lack of control, like my body had been hijacked without my consent, and I knew immediately that I needed an abortion. Pennsylvania has a politically motivated and paternalistic 24-hour waiting period that requires people who have to travel far distances to get to a clinic to go 2 days in a row. And 87% of Pennsylvania counties do not have abortion clinics. So rather than drive twice to the nearest clinic, I decided to drive a little further, but just once, to Baltimore. When I arrived, the clinic staff were wonderful. They talked me through what I could expect, made sure I felt safe and comfortable with my decision, and it was a refuge. I also had an incredible network of friends that helped me both monetarily and emotionally, a job that supported me and provided time off, and a car that I could rely on for travel. But now, with the overturn of Roe, that pit in my stomach has returned. I know to the core of my being that if I had been in a place where I couldn't legally access abortion, I would have found a way to end my pregnancy at whatever risk to my life. I might not be alive today, but I would not have carried to term. 12 states have now banned abortion outright, and several have added criminal and civil penalties for patients like me, for clinic staff, and people like my friends who step up and help support abortion patients. Since the fall of Roe, I've been thinking constantly about the people that are facing the same decision that I did, with the same conviction I had, with fewer resources and more barriers than I had, making the same trip to Maryland for refuge, just like I did. They deserve every protection that this state can afford them. Electronic health records are a great idea. They make care easier and more accessible, but now 12 states see my experience as an illegal one. And I know that more states, like my home state of Pennsylvania, may follow. And I need to make sure that the record of my abortion care is controlled by me, first and foremost, and doesn't end up in the hands of someone who would seek action against me, my friends, or the providers who saved my life. I urge a favorable report on HB 812. Thank you for your time.
Thank you, and thank you for sharing your personal experience. The committee appreciates it. We're now going to open it up for questions. Are there any questions for the sponsor and his panel? We start with Delegate Gazzoni. My pleasure.
Because it seems like we're kind of charting new ground. Do you know, or could you tell me about any case law surrounding providers of medication abortions?
Yes, there are two case laws that are relevant. The first is related to the Public Information Act. And in that case, it went up to what was then the highest court, then called Court of Appeals. And what that court found is that the Department of Health was within its rights to redact information about individuals in surgical abortion facility licensure records that they released. And it was specifically because of the long history of violence against abortion providers. Then on mifepristone specifically, when mifepristone was first approved by the FDA back in the early 2000s, which is the subject of the court case in Texas, there was a public information request to the FDA for all the FDA employees who had worked on mifepristone. And the U.S. Court of Appeals found, I'm going to quote, "The FDA has fairly asserted abortion-related violence as a privacy interest for both the names and the addresses and persons associated with mifepristone," and then went on to say that there are websites that encourage readers to look for mifepristone's manufacturing locations and then kill or kidnap employees once found. I think there's ample evidence to show that that is the same for abortion providers. Thank you for the question.
I have next Delegate Hill, followed by Delegate Bagno.
Robin, let me ask you this question. I'm looking at the bill, and there's an implementation date that MHCC has. I think it's 2025. That seems a little far off. Do you have, is that, I mean, I can ask them when Ben comes up or whatever, but I'm a little curious, what do you take about that date?
Well, we do understand that probably if you passed this today and made an emergency legislation, that it might not be literally tomorrow, but they have known about this problem. We've known about Dobbs. We've known 24 other court cases were in the pipeline to overturn Roe v. Wade. This issue has been around for years. And as we have heard from our panel, and I get questions every day, providers and patients are terrified. And it's not an exaggeration. I do not use that word lightly. So 2025 seems very far away. I understand the technology to do this may actually be very close. So I would really like to find a way to create an implementation deadline that allows the vendors who do this to create sort of meaningful, workable solutions, but first and foremost to protect providers and patients.
Yes.
So I'm reading about, redacting information about the prescription and the people providing. One of the things providers do all the time is ask patients for their past surgical history, right? Tonsillectomy, whatever. VTOP, voluntary termination of pregnancy, is a surgical procedure. under this bill, I guess this for either of you, under this bill, would we expect patients to begin to lie so that it wouldn't be included in the record? Would we expect providers to stop asking about those particular procedures when they ask about a surgical history? Or would the surgical history be one of the things that would be redacted from a medical record that's being shared?
So the first part of the bill about kind of the broader medical record related to abortions and potentially other types of reproductive health care, because we don't know what's next. That part would allow that information to be shared to the treating providers in Maryland. The real issue is when it goes to, like I went to an urgent care in Texas on vacation. That urgent care provider would then have all of my medical information, including my abortion information. So we're really trying to keep that information within Maryland. I think that you raise a very good question. One of our providers here testified, and I see Dr. Gomez's hand raised, that what some providers are doing in states that are closer to Texas and a little kind of feeling this more or feeling this earlier is that they're converting to paper records, which just really feels going backwards after all the work we've done. And I think that part of this is the provider-patient relationship. It's so important that it is built on trust. And so the sense that we are trusting women and our providers to build that relationship in such a way that information is shared truthfully and listened to compassionately. And there's so many providers that I know are really, really good at that. And so that's what we want us protect and support those providers and patients.
Thank you. We have next Delegate Bagnall, followed by Delegate Taveras.
Thank you, Madam Chair. Ms. Elliott, one of your first statements stuck with me when you talked about providers and their families. For our new members, last year we actually had a public awareness campaign for workplace violence in healthcare settings. So it's an issue this committee is keenly aware of. Can you speak to the rate of violence to abortion providers?
Yes. So, and as many of you know, I also represent the Maryland Nurses Association, and the rates of violence against nurses is very high, particularly in emergency rooms. For abortion providers, they are specifically singled out because of what they do. There's an organization called the National Abortion Federation that keeps statistics, and in 2021, so this is before Dobbs, so I'm imagining it's gotten worse. The percentage increase from the prior year of stalking cases went up 600%. And then the rate of assaults have gone up 128%. Since the leak of the Dobbs decision, there have been Planned Parenthood affiliates either set on fire by arsonists or firebombed in 3 states, Wyoming, Michigan, and Illinois, states where I personally all have family. And so the thought that any of our family members or our friends are at risk is very chilling. It's very real. And we're anticipating it to get worse.
Delegate Taveras.
It seemed like Dr. Gomez wanted to say something, so I'll let her. I'm directing the question at her so she could.
What is your question?
Thank you. I just wanted
What
to
did you want to
respond.
say?
Okay.
Thank you. I just wanted to, if that's okay, respond to the earlier question about patients sharing their own past surgical history with other providers. A lot of people still think of an abortion, first trimester abortions make up 93% of all abortions, and an uncomplicated first trimester abortion is actually not a surgical procedure. There's no reason that they need to relay it to anyone else for ongoing medical care. It's a simple in-office procedure that takes about 5 minutes to perform, can be done under ibuprofen for pain control only, so it's really not relevant medical history. They can share it if they want to, but it's not medically important. Thank you.
And for the members, you need a question, okay? It's important. Delegate Morgan.
Madam Chair, the question's for the panel. There's been a lot in this committee talking about the violence against abortion clinics. And I just wanted to ask a quick question. There's been 2 very high-profiled violence cases against pro-life pregnancy centers, one in Oregon, and the most recent one, just in January, a firebombing of a pro-pregnancy center in New York. And I was just wondering if this bill had any matrix that would offer consumer protections for those that maybe went to a pro-life pregnancy center. Thank
But
you.
that would be a violation of existing law. So we have law to, it would be a so there's no need to enhance the penalty. It's there.
Sure.
Can you elaborate on that? It would be against the existing law. Is this falling under, if a woman went to a pro-life pregnancy center, would that fall under patient, I guess, privilege, or, you know?
Oh, you're talking about, I thought you were speaking to the violent act against the facility.
Or anything that would give
Well,
any consumer protections for.
Okay. I am not aware, I could stand corrected, but I'm not aware of any efforts by any individual to obtain that information and to then, you can't sue under the Texas law. You can't sue someone who went to a pro-life center for violation of the Texas law. So there isn't, I don't think there's a need to single out those individuals. If a criminal act is committed against an individual entering, I would assume our Access to Clinic Act would also protect them. So,
My pleasure. I have Delegate White.
Thank you, Madam Chair, and thank you, Delegate Rosenberg, for this bill, as well as your panel sharing with us. This question is for Robin, and could you expound upon, the real harm done to women because of personal health information? Can you expound upon that, please?
Yes, and I think thinking about Dr. Gomez's experience, in that case, there was not harm done, but we do have definitely examples of where it is. There was a case in Texas where an individual after SB 8 who could not obtain an abortion legally self-managed or self-induced an abortion. Went to the emergency room. The emergency room called law enforcement. Law enforcement arrested this 26-year-old who was, of course, in the midst of a medical incident. That's why she went to the ER. This district attorney charged her with murder. And then eventually, 3 days later, those charges were dropped. However, in that time period, in those 3 days, that story went viral. Her identity is known across the world, and she had multiple traumas, and on top of having to turn to a self-induced abortion, to being arrested, to being exposed to the world. There was another case, Delegate Rosenberg mentioned it, where there was a 10-year-old in Ohio just days after the 6-week abortion ban went into Ohio. The 10-year-old was pregnant because she was raped. She was just beyond 6 weeks. So in order to obtain an abortion, that 10-year-old had to be accompanied to Indiana. The physician in Indiana, where abortion was legal at that time, provided that care. And then the Attorney General held a press conference where he accused the physician of violating the law because he had tapped into information both in the news and looking at an abortion reporting record. That, we don't know what happened to the 10-year-old. I can't imagine the additional trauma that occurred. The Indiana physician had to raise money through a GoFundMe page because of the number of death threats she received to herself and her family. And she has since moved to another state where abortion is legal and she feels safer. So those are just two examples. We have 14 states that have banned abortion. We think about 24 will be banning abortion. So we are going to hear more and more examples like this.
My pleasure. Are there any other questions for this sponsor and his panel? Seeing none, thank you very much. And for those that are with us virtually, thank you for sharing your stories. We really appreciate you, okay? Next, we have Nicole Swinney, favorable with amendment. Good afternoon.
Good afternoon, Madam Chairwoman and members of the committee. My name is Nicole Sweeney. As its General Counsel and Chief Privacy Officer, I am speaking today on behalf of CRISP, Maryland's designated health information exchange and health data utility. CRISP was created in partnership with the state and was critical in Maryland's response to COVID. CRISP is committed to patient privacy and considers patient choice paramount. For the past decade, I have worked on legal issues intersecting data exchange and data privacy. On a comparable issue, I previously worked to help SANSA promulgate updated substance use disorder regulations to protect the data of stigmatized patients while also allowing their healthcare information to get where it needs to go. Based on my experience in health data privacy and interoperability, I know that, as written, this bill will have unintended and potentially life-threatening consequences for people with uteruses. The industry is not yet capable of what's called segmenting data. Put simply, we can't take a health record and delete or stop the exchange of individual lines of data. I know this because of my experience in SAMHSA. Those regulations require affirmative consent of a patient before certain substance use records are shared, just like this legislation envisions. Often, patients receive care in addition and separate from substance use in the same visit, but because we cannot segment the data, the entire record, I'm gonna say that again, the entire record is blocked. This bill would do the same thing for people with uteruses. If patients have anything related to reproductive health data in their record, the entire record will be blocked. While people may consent to release of data, we know from experience that consent is limited and misunderstood. People can either consent for their entire record to be shared or none of it, and this is not a very good choice. We do have the technology to segment these records if we know the codes of the sensitive procedures. We can filter out these data. Therefore, we ask that the committee amend the bill to specify certain code sets that should be filtered or protected when going out of the state. With this solution, consent could be limited to that code set without having patients' entire records blocked. We also ask that the commission make this code set flexible to allow things to be updated as sensitive codes or diagnoses change. In our submitted amendments, we suggest a commission be utilized to identify and update this code set. As a person with a uterus, I do not want to be in a situation where I'm traveling out of state, need care, and my clinician cannot get my record. With this bill, the way this bill is drafted, that scenario is not likely. We ask that the committee consider our comments to make this bill feasible and implementable while giving women the most flexibility with their privacy.
Thank you for your testimony. Are there any questions for this witness? Seeing none, thank you for being with us today. We have 3 virtual favorable. Actually, no, let's go to an unfavorable. We have Ms. Laura Bugley.
Good afternoon, Madam Chair, members of the committee. Good to be with you again. I'm Laura Bogley, Executive Director of Maryland Right to Life. And on behalf of our Board of Directors, we urge your unfavorable report on this bill. While this bill claims to protect women's privacy, the truth is it is an abortion shield law designed to protect abortion providers and abortion drug dealers at the expense of women's health. Abortionists have no problem redacting patient personal information when they're seeking Medicaid reimbursement through the state. And there's absolutely no reason why they cannot devise a system to protect patient privacy in order to provide important metrics to the state that you need to have to judge whether or not you are meeting the legitimate reproductive health needs of women in the state. But by approving this bill, you're going to be turning a blind eye to women who suffer from, as a result of a botched abortion or drug-induced abortion injuries. This bill hurts women by shielding the manufacturers and distributors of lethal abortion drugs, which are 4 times more dangerous than surgical abortion, through teleabortion and the unregulated proliferation of abortion drugs, including some from out of this country that are not approved or reviewed by the FDA. The abortion industry has itself exposed women to back alley-style abortions, where they bleed alone without medical supervision or assistance. We know from anecdotal information, these women are usually rejected by their abortionists and sent to ERs, where they are misdiagnosed oftentimes because they do not voluntarily give their abortion history, and they're often falsely reported as spontaneous miscarriages. So the number of complications due to chemical abortion pills are extremely underreported. For any of you who are new to this, just to explain the process, this is not normal. I know this bill and what you hear in this committee attempts to normalize these drugs, but mifepristone, which is the subject of current litigation, actually starves the baby of progesterone. This is a living baby with a heartbeat up to 10 weeks. And the second causes the woman to hemorrhage and bleed out her baby, and then they're being instructed to flush these babies down the toilet. This is not normal. This bill hurts women. I urge you to put patience before abortion politics and urge an unfavorable report. I'm happy to take questions.
Are there any questions for this witness? Seeing none, thank you for being with us.
Thank you.
My pleasure. We have 3 virtual witnesses. Will you be so kind and bring them up, please? Thank you. And for the committee and people waiting, we just need a little patience while they come up. Good afternoon. Will you please get started, Dr. Pana Lassi? If you could unmute yourself, that would be great. I love your background, by the way. It's very nice. Go ahead.
Can you hear me now?
Yes, I could hear you, and we can hear you, most importantly.
Okay, great. Thank you very much. I'm Dr. Pana Lassi. I'm a UCSF clinical professor, and I'm faculty at the Santa Rosa Family Medicine Residency Program. For almost 30 years, I have provided care and trained residents in cradle-to-grave, full-spectrum family medicine, including abortion. I volunteer on a hotline, and just the other night, I spoke with a desperate woman who lives in a state that has banned abortion and was raped. And so she is planning to drive 8.5 hours to Maryland. She is unaware that the electronic record of her abortion in Maryland could be transmitted by a health information exchange to providers in her state. If she did know, she would be terrified. I'm scared for these vulnerable patients and for providers as well by this huge hole in our privacy protections. I also work at a small abortion clinic in an abortion sanctuary state with many hostile states around it. We actually chose to use only paper charts, in large part due to the problem of electronic health records connecting with health information exchanges and passing this sensitive information across state lines. Using paper charts is incredibly sad because we had long hoped that the electronic health record would decrease duplication of effort and facilitate communication between doctors and hospitals. I was recently on a call with perinatologists at a tertiary care hospital who are also stymied by this problem because they get referrals for incredibly complex pregnant patients from around the country and need to coordinate care with their referring providers. So they don't want to go to paper charts. However, they too are aware that they can't keep electronic records private across state lines, and this puts doctors and patients at risk. Maryland legislature has an opportunity to lead the way to fixing this critical problem by ensuring that sensitive medical information does not cross state lines. I urge you to do it. Thanks so much.
Thank you for being with us. Next, please. is it Madison? Will you be so kind and unmute yourself? Did I pronounce your name correctly?
Yes, ma'am.
You can get started.
Alrighty. Good afternoon, Chairwoman and committee. Thank you. My name is Madison Anderson. I'm 22 and from Houston, Texas. In September of 21, I had just come out of a 2-year relationship, and I decided on September 15th to take a pregnancy test. I remember taking the first one, and the line had developed before even the control line. I called a sorority sister to bring me more because I was in disbelief. At one point, I had 5 positive pregnancy tests in front of me, and I knew abortion was more than likely the choice I was going to take. I called Planned Parenthood the next day to schedule my first appointment. While on the phone, a representative explained and informed me about SBA, which banned abortion after 6 weeks. The earliest they could bring me in was about a week later. After talking to a clinician, I estimated myself to be about 4.5 weeks along. To my surprise, I measured at 10.5. This meant that I could not get my abortion in Texas. The earliest that I could be seen was 2 weeks later at Jackson Women's Health Organization in Mississippi. The appointment required 2 separate visits by car and plane. By the time I had finally accessed the care that I knew I wanted, 3 weeks and 3 doctor's appointments had passed. I didn't know how they kept their records, but more and more providers are using electronic health records. If only one of those appointments kept a electronic health record, then there is a record that I was pregnant and I did not carry it to term. Texas has already put my support network at risk with SB8, and they have risked being sued by aiding and abetting me. I want to make sure that as many places as possible are safe for people like me seeking healthcare. Electronic health records are supposed to make healthcare easier to access, but knowing how my state feels about abortion, electronic health records put me at risk. The more control I have over my privacy, the safer it is for me, my family, and my providers. I urge a favorable report on HB 812. Thank you for your time.
Madison, thank you for sharing your story with the committee. We appreciate it, okay?
Thank you for listening.
You're most welcome. We have Kimberly Alexander. Is she on? She's not on? Okay. Are there any questions for these 2 witnesses? See none. You have a wonderful, blessed day, okay? Take care. This actually concludes the testimony on House Bill 812. Next, we have House Bill 571, Delegate Kipke, Overdose Response Program, Opioid, Overdose Reversal Drugs, Choice of Formulation and Dosage. And while Delegate Kipke gets to the table, I would like his panel, Amanda Lynn Reese to come up, Andrea Mansfield to come up, and Michelle Golden. And that is the panel for the, Kimberly Alexander, we finished the hearing already for the testimony. We did not see you there. So
I'm sorry, I was watching the testimony and had to switch screens. I apologize. Can I please speak?
Okay, I'm going to allow it. I'm going to probably make it difficult for the library. But Ms. Kimberly Alexander, who wants to give testimony on House Bill, it was House Bill 812 for the library. This is for House Bill 812. It is Kimberly Alexander giving testimony virtually. Although we are on House Bill 571, I'm going to pause that for a second, and this is for 812. You have 2 minutes, okay? Go ahead.
So much. Thank you so much, Madam Chair Peña-Melnick and members of the committee. My name is Kim Alexander, and I am from Garrett County. I'm here to testify on behalf of the Mountain Maryland Alliance for Reproductive Freedom. We're a nonpartisan grassroots organization committed to assuring and expanding reproductive health care in rural Mountain Maryland. In a pre-DOBS world, the sharing of information about patient receiving care in Maryland was unquestionably helpful to the patient and her doctors. Now, however, the sharing of reproductive health care across state lines has the potential to put healthcare workers and patients at risk for litigation, prosecution, and intimidation by those who oppose reproductive rights outside of Maryland. We have a particular interest in this bill because our neighboring state of West Virginia has banned abortion in almost all cases. And we know that many people from West Virginia and other states imposed DOBS
bans will likely seek reproductive health care and abortion in Maryland. Moreover, in Garrett County, our hospital is part of the West Virginia University healthcare system. A person receiving reproductive health care in our local hospital should not have to worry about whether their medical records will be available for possible legal action in West Virginia or other states with post-obs bans. Not included in this bill, we believe people who are seeking gender-affirming care should also have access to these protections. We believe that patients need and deserve the greatest confidence that if they seek reproductive health care in Maryland, information about their care will be private and protected. We urge the committee to support House Bill 812. Thank you. Thank you for letting me speak.
Are there any questions for Ms. Alexander? Seeing none, thank you very much for being with us. And this really concludes the bill hearing on House Bill 812. You have a blessed day. My pleasure. Let's go back to House Bill 571, and this is Delegate Kipke, and the title of this one is Overdose Response Program, Opioid Overdose Reversal Drugs, Choice of Formulation and Dosage. And he's here with his panel. Delegate Kipke, thanks for your patience. Will you be so kind and get started?
Thank you, Madam Chairman and members of committee. I'm happy to present House Bill 571. Over the last decade, particularly this committee has taken great strides in expanding access to treatment throughout our state in response to the opioid crisis that continues to plague every corner of Maryland. This bill is another tool in the toolbox to help in that fight. The bill requires the Department of Health to allow an entity provided with opioid reversal drugs, you think of them as naloxone, through an opioid response program to choose the formulation of dosage that they think is best for the population that they're working with. So it had been the case that, well, predominantly there's a 4 milligram dose of naloxone that exists, and that's sort of what you think of when you think of naloxone. But a year or two ago, the FDA approved an 8 milligram dose. And it's a very important tool, and there's experts here who will testify as to why that 8 milligram dose is essential. The bill simply allows choice, it doesn't require anybody to use it, and there are entities within the state of Maryland who are asking for it. For the returning members of the committee, you will recall last year we passed something known as the STOP Act, which expanded community-based naloxone distribution. You know, it's sort of the mindset that overdoses continue to happen despite everything that we've done over the last decade. And so, you know, an important stopgap is the opioid reversal drugs. However, further amendments to the bill specify that opioid overdose reversal drugs approved by the FDA for broader distribution through the Maryland Department of Health and Harm Reduction could be provided through the department, and that's the crux of the issue. Although the broader statewide standing order refers to all products currently approved by the FDA, a separate standing order has been issued specific to opioid response program distribution dated October 24th, 2022, to only allow for the 4 milligram dose. And you'll hear about the entities within the state and why they want the 8 milligram dose. In the fiscal note actually says there's not much of a cost implication to the state, but the secretary brings it up as an issue. The thing that I don't think is being taken into account is I'm probably not allowed to do it, but I bet if I asked you to raise your hands, you will have heard from people in your jurisdiction, from primarily paramedics, EMTs, that they have had to use multiple doses of the Narcan to help somebody recover. That's becoming more and more common, and it's because more and more people are being exposed to the far more dangerous substance, fentanyl. Our fight in the opioid crisis necessitates all resources be made available. I understand some medications may not be suited for certain populations that we're all trying to help, but as we continue to combat the crisis, we need to ensure that programs still have the options available to them to best serve the population that they're touching and trying to help. This bill seeks to achieve that goal and provide another tool in the toolbox to save the lives of Marylanders. Madam Chairman, members of the committee, I thank you for your time, and I urge you to give House Bill 571 a favorable report.
Thank you. Who will be next?
Great, thank you, Madam Chair. I'll go next. Thank you very much. Andrea Mansfield with Manis Canning and Associates, representing HGMA. HGMA is the company that does produce the 8 milligram nasal dose of naloxone, and really want to thank Delegate Kipke for sponsoring this bill. As Delegate Kipke mentioned, really this bill is about choice, and it's about providing access and ensuring all the medications, at least all the opioid response programs, know that they're available, know that they have access to them, to use them for the communities that they serve, and ensure that they're using the best medication for the community that they serve. As previously mentioned, this committee has done so much work in this area, and really dating back to the HOPE Act in 2017. The committee, you've always made sure that all the different types of medications, all FDA-approved medications, either the educational materials have been provided about them, or that they've been offered. House Bill 116 is a more recent example of this, with medicated assistant treatment being offered in the jails, and you ensure that all 3 forms were provided. And that's really what we're asking for here as well. We were really pleased that the broader standing order was changed, but with the opioid response programs, as Delegate Kipke mentioned, they're only able to use the 4 milligram nasal dose right now, according to the requirements that they must follow by the Department of Health. I know we have read the letter. I've also read the fiscal note, and there was an indication that other products can be accessed, but I will tell you from the work that we've been doing, the opioid response programs we've talked with, local health departments that we have talked with who have expressed an interest, they have not been able to gain access to this medication, nor has our client, nor do they have an arrangement with the purchasing entity to do so. So really, we're really urging that you look at this issue, ensure that all medications can be provided for this purpose, and we're really asking for your help to make sure that that's the case. And with that, I'll urge a favorable report on House Bill 571.
Thank you. Next, please.
Hello, Madam Chairperson and committee members. My name is Amanda Lynn Reese, and I am a harm reductionist from the state of Ohio. I am the program director of the largest distributor of naloxone. Ohio was the first state to allow access to all forms of naloxone in August of 2021. We did our best to learn about all the forms, concerns raised, and inform our community members and partners about what the options were available. In preparation for expanding access to all forms, we began surveying naloxone use in both our online orders and our community distribution programs. We learned how many doses were being used, the type of administration, and we were able to consider the circumstances of the overdose event in these instances. It continues to be clear that nasal delivery is the preferred method of administration overall. Nonetheless, a substantial minority of people preferred the intramuscular administration. This suggests that all forms of naloxone be continued to be available in our state. We promote total autonomy of choice to all forms of FDA-approved naloxone. After the availability of additional doses, we saw a gradual increase in orders for higher dose naloxone as it became known to our partners and those we serve. It's still premature to call this a trend, but increase continues at a consistent rate. We also learned most people use naloxone as per the directions. However, from our 2 surveys prior to the introduction of high-dose naloxone, we learned about a quarter of the online respondents and a third of the community distribution respondents reported using 3 or more doses to reverse an overdose, due primarily to the adulterated drug supply. It is not just those who intentionally use opioids experiencing opioid overdoses. Across the board, we have seen a decrease in cost for all forms of naloxone since the market has expanded. The price of naloxone has fallen by half in less than a year. Ohio plans to use these savings and regulatory changes to improve getting this life-saving drug to the people who need it most. In 2022, we distributed 42,000 naloxone kits at my organization. Less than a year ago, a 4 milligram Narcan was $75 to us. At current prices, the cost of 42 naloxone kits shipped by Harm Reduction Ohio is about $1.4 million, down from $2.7 million of our old prices. Finally, and most importantly, receiving naloxone of any form that the communities need it is a key tool to saving lives in your communities. Thank you.
Thank you. Do I have, actually, this is a sponsor panel. Let's open it up for questions. Are there any questions for the sponsor and his panel? I'm going to start first with Delegate Hill, followed by Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate Kipke, for the bill. Did you have a chance to read the Department of Health objection? They say that they will be required to honor requests for higher priced naloxone formulations and that they have a fixed budget, and so this presents problems for them. Do you have a response?
Well, I've thought about that a lot because I did reach out to the health secretary prior to the bill hearing, and the objection was they don't want to be told they have to do it. My opinion is most places aren't going to request this. It's, I think about corrections as someone's leaving corrections. We know that a lot of people return to their old drug habits at that old dosage level, and in an environment like this, it might be appropriate to give an 8 milligram for corrections. There's other environments too, but law enforcement, for them to carry it because they're using more than one dose of the 4 milligram as it is. So every time somebody uses 2, which I'm told is now quite common because of fentanyl, it's cheaper to use the 8 milligram. So all I'm saying is allow people to use what they believe is the most appropriate. And the department, if they were, and I did ask for a meeting, and I know they're busy, it's a new administration, and new people are being hired and all that, but I would be open to the idea of them having some parameters around who it's best for. But so far, there's been extensive effort to make this product available in Maryland, and with the prior administration and with this administration, and it's just falling on deaf ears, despite the fact that there's others who can answer the question, who is asking for it? I know places in Montgomery County have asked for it, Anne Arundel County, and they're continually told no. Also, the evidence shows every time you add an additional treatment, the cost for everybody, for all the products, goes down because of greater competition. The 4 milligram dose manufacturer wants to keep more of the share of the market, so they lower their price to compete. Nearly 20 states have done this, and in all of those states, the costs have come down.
Delegate Johnson.
Thank you, Madam Chair, and thank you for the bill. Can an 8 milligram dose of naloxone harm anyone?
Naloxone does not cause harm to anyone. If somebody has an opioid dependency, having your opioid receptors stop receiving opioids is going to cause discomfort. And the more your tolerance to opioids is, and the more dependent on them you are, the more that precipitated withdrawal can become a concern. That is going to be a certain percentage of the population. There is a population that is opioid naive. The adulterated supply of people who are stimulant users or recreational drug users that aren't opioid users have no risk of those withdrawal symptoms being experienced. But in my research in my organization, that was one of the reasons we did our due diligence to find out how many doses were being used and what the community feedback has been. We've had access to this medication since August of 2021, and we've had no reports of precipitated withdrawal in our community.
Any other? Seeing none, no other questions. I like Delegate Kipke, wherever this bill is assigned to, if you could please make sure to talk to the LA about inviting the Department of Health to the subcommittee, okay?
Thank you.
Thank you. May I please have Michelle Golden? Good afternoon.
Good afternoon, Madam Chairwoman and distinguished members of the committee. Hi, I'm Michelle. I'm Michelle Golden. I'm a private citizen. I'm not a medical healthcare expert or a legislator. I'm a caregiver. I've worked in Texas and in Ohio and now here in DC and Maryland. I'm here because I've lost many people to drug overdoses, people that if they had been given the second chance that naloxone provides, they would be pillars of their community today. I've been working a lot with, my first job was with a psychologist that provided care for people in recovery. And so I regularly saw people in recovery get well and have support. My next job in Ohio was as a patient advocate, helping people get access to prescriptions that they need. And I currently work as a nanny and caregiver for the elderly. My first experience was I lost 2 friends my senior year of high school to opioid overdoses. People that had full ride scholarships, and I saw them a week before they died, and there's no access in Texas. People don't know anything about naloxone. They don't have access to it. They don't know how to administer it. Conversely, in Ohio, there's a lot more information out there. There's a lot more access to it, and lives are being saved, and I've seen multiple people. There was 1 month where every week there was somebody else that was revived by this medication. Well, I think what's really important is that as many forms of naloxone as are available should be made available to people that need it. I feel if you have any opportunity to save lives, you have to take every opportunity. And right now there is more than one opportunity. And so I urge for a favorable decision on this. Thank you.
Thank you for coming and sharing you can stay seated for a minute, and sharing your experiences with the committee. Are there any questions for this witness? Seeing none, thank you again, okay? We appreciate you.
Thank you.
Our pleasure. So this actually concludes the bill hearing on House Bill 571. For the committee, we have House Bill 517, Delegate Solomon, Drug Manufacturers Drug Take Back Program, Take It Back Maryland Act. Good afternoon, Delegate. How are you?
I'm doing well, Madam Chair. How are you?
I'm doing great. Thank you for being with us today.
No, thank you. I actually think this is my first time before the committee with you as chair, which is an honor. And before I start, I have to say, your staff reflects your kindness. Just appreciate their willingness to work with members on hearings and share information. So I just wanted to make sure that I know how hard it is to be a staff member sometimes. I wanted to make sure they got some appreciation, and clearly the kindness radiates out from you. So I just wanted
thank you for saying that.
to say that. Well, members, for the record, Delegate Jared Solomon here to present House Bill 517, the Take It Back Maryland Act. And before I get into the issue, I will say, scrap the bill that's before you. We are working on a whole new process. We've spent a lot of time talking with manufacturers and various stakeholders. So I really wish we could have had the time to fix it before the bill drop deadline. So I'll just sort of caveat the rest of my testimony and the rest of the hearing on the bill with that piece. And I really do appreciate, spent a lot of time talking with the now vice chair and former vice chair on sort of different ideas and different models. And in a minute, I will share with sort of where we've wound up. But the genesis of this bill and the work that we've been doing comes from, I think, very well represented on what we just heard in the previous bill, and your committee probably knows it better than almost anybody in the General Assembly, the opioid crisis and the addiction crisis that we're facing, not only in the state of Maryland, but across the country, with almost 110,000 overdose deaths in 2021 alone. I can go through sort of the litany of things, but I think very quickly, we know how important drug take-back programs are that allow unused medicine to be disposed of properly. Obviously, the benefits for public health and to limit addiction is first and foremost, but it also benefits the environment. There's some testimony, and I'm not sure, we had some folks who were sick themselves, and I think everybody needs to be in 5 different places at once at this time of session. So I'm not sure everybody who's going to be able to be here either virtually or in person to testify, but there is written testimony submitted from environmental groups. There was recently a report the last few years that was published in Baltimore about various drugs that they were literally able to find in water sources in the state. So we know when you flush medicine down the toilet or you just dispose of it improperly, it's terrible for the environment, it's terrible for the Chesapeake Bay, and a whole host of other things. So that was the genesis for trying to figure out, do we need a more robust sort of new infrastructure of drug take-back programs in the state, or is what we have really working and maybe just needs to be tweaked and updated a little bit? And so ultimately, the bill as written went to sort of a producer responsibility model where the manufacturer of a product, whether, we've had lots of conversations about that as a General Assembly on things like paint or, plastics, whether the producer of that material has some sort of responsibility at the end of its life to make sure it's disposed of properly, and they share some of the burden and some of the responsibility for that it doesn't just fall on the consumer or the retailer that ultimately distributes it. And that was sort of the model overall. In conversations with manufacturers and a variety of different stakeholder groups, what we found is, give or take, there's about 85% of Maryland residents that live within 10, maybe 20 minutes of some sort of a take-back location, whether it's a drop box at a retail pharmacy or a local police or fire station that may have one, or a hospital. And what we were frankly told flat out by some of the manufacturer groups, some of which you will hear testifying today, was that we don't need a whole new system. What we really need is a vastly improved system of education around it. I think if you polled most Maryland residents, maybe they might know that we do something, but they certainly don't know the breadth and the diversity of options that are available, or even maybe where to find it. There are states around the country that have used the model that you see in the original bill, and we were tweaking that to begin with. And those are models where the entire cost of the take-back program falls entirely on the manufacturer, and it is the burden falls to the group of manufacturers to essentially create a robust take-back program that is fully funded by them. That is not what we're trying to do in Maryland. Although I will share with you a source of frustration. We kind of ran into a little bit of a brick wall in who would ultimately pay for it. And so the sponsor amendment that we are working on, or that is in the works, essentially, again, scraps the bill as you see it and moves us to a place where we would do three things. First and foremost, we would do a work group or a study, which I know we hate work groups, but it would essentially be a needs assessment. And it would ultimately be paid for by manufacturers. We're still working out the exact way that we would calculate how it would be paid. But probably something similar to the Prescription Drug Affordability Board, where every manufacturer in the state pays a very small amount and contributes to the general pot. But essentially, it would be a needs assessment to figure out, what do we have? Is it working? Does it need to be improved? Do our residents even know it really exists? Hire a consultant, maybe do some public polling data, figure out where the gaps are in rural and urban communities. Are they equitably distributed? So give us sort of a baseline of what we've got, and is it working? And that would be convened by the Maryland Department of Health and Maryland Department of the Environment, with representatives from manufacturers, from pharmacies and retailers, from public health agencies, from law enforcement, everybody that has a stake in this, from addiction groups, to make sure that we have a baseline of our systems in Maryland. More than likely, that would probably show us that we don't have enough education, or most of our residents don't know about it, or we need to improve that. So piece number two would be to fund a robust public education campaign. Many of you are probably familiar. The way that I have sort of thought through this is similar to what we did around the opioid crisis, what we did for the census. The Maryland Public Television Agency has essentially a state-run not-for-profit ad agency, and they've conducted a lot of the public education campaigns that the state has embarked on, and they've done a really amazing job. So it would be something sort of along those lines. Again, we don't know how much it would cost. We don't know what the extent would be. That's what we would find out in the needs assessment. And then lastly, we would create some sort of a very small ongoing fund that, again, would be paid for. The idea here would be through manufacturers, or we can figure out an equitable system where the cost is shared by everybody that's sort of involved in the ultimate pipeline of prescription drugs. But this fund would be for ongoing education campaigns. So obviously we do the first one, but maybe there needs to be a continual amount of education, through our healthcare facilities or whatnot, or through our pharmacies. And it would also fund some additional take-back programs that might need to be set up. If we discover that, there's a county in the state that really is lacking the infrastructure, or a community in the state that really needs more, this would be a fund that we could turn to pay for it. I think, honestly, if the only thing we were able to accomplish at the end of this session through this bill is a process to create this needs assessment, I think that would be a big win. But I will tell you, there are a couple of the manufacturer associations that were really great partners. AAM in particular, and you're going to hear from them, I think, virtually. Were great to work with. CHPA and their folks were actually really helpful and really proactive. Ultimately, at the end, they decided they're coming in unfavorable today, because anything that will charge them more, frankly, they said was kind of a non-starter for many of their association members. And I guess my frustration with that, and to share with you all, is you will see in a lot of the written testimony from the manufacturers that the cost for any of these programs should not be on them. That it's because residents don't understand how to take their medicine and they use it improperly, or providers and doctors are overly prescribing medicine and things like that. The problem with that argument is the system that we have right now in the state of Maryland, everybody has some sort of cost, or bears some sort of cost, except the manufacturers. So partially why we have such a robust take-back system right now is because the retailers have voluntarily chosen to put it in their pharmacies. So those costs are borne entirely by the retailers. In places where the fire departments and the police departments and our local governments or our state government have set up programs, that cost is borne entirely by the state or local government. So I guess I was particularly frustrated by the argument that manufacturers should have no cost here whatsoever, when the system we have in place right now, again, the money that is being spent to provide it is being spent by everybody other than the manufacturers in sort of the life cycle of prescription drugs. So at the end of the day, if we're ultimately able to get to a needs assessment that comes up with some sort of model where, maybe the retailers pay a small percent and manufacturers pay a small percent, and we're able to sort of fill in the gaps with some local funding as well in places where local governments want to step up, that would be totally fine. Again, the model that we are basing it off of is manufacturers, and this is not nearly as expensive, or my sponsor amendment or the scheme that we're working on would not be nearly as expensive as what is 5 or 6 states in the country, including New York, Maine, and a couple of other states that have, again, these types of programs where the entire cost of the program is entirely on the manufacturer, and the responsibility to make sure that they are working appropriately falls entirely to manufacturers. So with that, happy to take any questions, and again, really appreciate your committee's continued partnership and work on this issue.
Thank you. We have a few questions. We want to start first with Delegate Shalega, followed by Delegate Chisholm.
Thank you, Madam Chair. Thank you, Delegate Solomon, for being here. I have some great news for you. I'm online, and there is a program called Rally USA, R-A-L-I USA, about us. We are losing far too many Americans to drug overdoses, particularly opioid overdoses. It can only be addressed if we come together and share solutions that work. They have a few initiatives. The people in Rally are national sheriffs, pharma, young people. It's a myriad of folks, including the pharmaceutical companies that are involved in this. Safely use, safely store, safely dispose. So they have a whole program, and maybe I'm aware of this because when I first started on this committee, they had a trailer. I don't think you were elected yet. Were you here when they brought their trailer? We all got to look at that, and they brought us disposal bags. These disposal bags are readily available. So I think what you're looking for is here. But additionally, before I knew you were changing the bill, again, this was a fairly hot topic when I joined HGO. And in 5 minutes,
Delegate Shalega.
I'm almost done.
Okay, I'm waiting for the question.
There are this many organizations that already have drug take-back, including MDE, MDA, myoldmeds.com, 211 Maryland. So do you think that I'm happy to give you my list. I'll type it up so it's not all chicken scratchy. And maybe work with Rally and them, possibly find a solution for what you're looking for without a bill.
Yes. So first of all, I would love to see your list. I'm sure that you probably have something on there that I have missed. I know the My Old Meds. I know the 211. Again, if we can accomplish this without a bill, so be it. I am obviously cognizant of the fact that, we tend to shy away from creating work groups or big study groups or need analysis groups without objectively, as a member of the Appropriations Committee, we know that budgets are tight and staff resources at agencies are even tighter. And so, the purpose of this would be, again, to figure out, is that list that you have? Because, again, from the mouths of BABE, from the industry themselves, they said, we don't think the infrastructure is the problem. We think the problem is education. People don't know these exist. They aren't pointed to them enough. And again, the needs assessment may come back and say, you know what, let's do a public service campaign, and let's maybe make some tweaks to the drug labeling in pharmacies in Maryland, or insert a new flyer, and that's the end of it. But I think getting us to a baseline, given the importance of the crisis that we're facing, what probably could be at the cost of, I don't know, maybe a few $100,000 to robustly convene staff and a consultant to come together to understand, is what we're doing working, and is it enough? Are there gaps? I think that's a reasonable expectation on an industry, frankly, that is making billions of dollars off of these products.
And I'm going to volunteer Delegate Shalega to work with you on this. That'll be great. And thank you, Delegate Shalega, for taking the initiative to find those. Appreciate it. And I do remember those. Delegate Chisholm.
Thank you, Madam Chair. I'm going to withdraw my question. As long as Delegate Shalega is going to work with them, I feel confident that this will not need any further attention.
All right, thank you.
Thank you.
We trust each other here. Are there any other questions for this delegate? Seeing none, thank you so much for your time, okay? Appreciate you. We do have Davion Percy, Josh White, and Charisse Johnson. Favorable. why don't you get started?
I can start. Thank you, Madam Chairman, Madam Chairwoman, and members of the committee. My name is Josh White on behalf of the Pharmaceutical Researchers and Manufacturers of America. We want to thank Delegate Solomon for meeting with us on Tuesday to go over his outline of the bill. We can't speak to the amendment itself because we haven't had it, but we can agree that there is a proliferation of take-back programs and locations around Maryland. In addition, Marylanders can access dozens of websites within minutes to give easy-to-follow information about how to dispose of their medicines. Nationwide, this campaign is led by 380 companies that sponsor the Pharmaceutical Product Stewardship Work Group. That stewardship group conducts education programs through their Project and My Old Meds campaign that was discussed. And moreover, this campaign is amplified by education programs from Maryland Department of the Environment, Maryland Department of Health, the FDA, the DEA, and nearly every police department in the state. And today, you can do a simple search on Google to find all of this information out there, and as well as take-back events that happen twice a year in Maryland and across the country. And ever since Speaker Bush kicked off the program about 8 years ago, we have the legislature and many legislators here have participated in these programs, and they provided information to their constituents about where they can find that information. And social media toolkits to figure all that out. So we believe that with all these resources and all the programs that are already here, it really is quite unnecessary to create a redundant work group to create programs that already exist.
See if you can meet that. Go ahead. Same time. Actually, he came a second under. Who would like to take the challenge? Go ahead.
Thank you, Madam Chair. My name is Sharice Johnson. I'm Director of State Policy with Pharma. Thank you for having me today. For the reasons mentioned by my fellow panelist, Pharma believes this bill is unnecessary as the current system is working well. With MyOldMeds.com, an industry-funded program, nationally there are over 22,000 drop-off locations, with 12 locations within a 5-mile radius of the State House. For over 97% of Marylanders, there's a drop-off location within a 20-minute drive. Opportunities at pharmacies like CVS, Walgreens, Rite Aid, participating military bases, as well as police stations. At a total of 380 locations throughout Maryland alone. Accessibility is there, and education on these programs is alive and well. When drug drop-off in Maryland is typed into Google, there are over 66,000 results, with one of the first published coming from the Baltimore County Health Department, listing out drop-off locations at 10 police precincts, open 24 hours a day. The DEA holds 2 National Take Back Day events a year, with the next one scheduled to happen in Maryland on April 22nd. In addition to the several hundred drop-off and take-home options currently in Maryland, utilizing home disposal in the household trash is accessible to most, if not all. The Waste Management Department at the trash dumps are already well equipped to deal with the safe disposal of prescription drugs. This not only cuts down on emissions, but further emphasizes the fact that the current system is working and is indeed accessible. We believe drug take-back programs are important and believe there is an existing and widely accessible system in place, not only here in Maryland, but across the U.S. Pharma respectfully opposes HB 517 and asks the committee to make an unfavorable recommendation today. Thank you.
You did better than he. Go ahead.
Good afternoon, Madam Chair, members of the committee. For the record, Davion Percy with Percy Public Affairs, representing my client, the Consumer Healthcare Products Association. Mr. Gutierrez couldn't be here today. He fell ill this morning. Otherwise, he would be here testifying. He did submit written testimony to each of you, so feel free to refer to that. I'd like to thank Delegate Solomon for his transparency and his willingness to work with us and hear our concerns. His door has been open since day one, and we appreciate him for beginning to work with us. Unfortunately, at this time, we cannot support this particular bill. We just don't think that it's necessary here in the state of Maryland. The landscape for drug disposal has changed dramatically in recent years. There are more drug disposal locations and options for the American consumer than any time before, and Maryland is one of the most robust networks of of take-back options in the United States. In fact, voluntary take-back options available in Maryland for Maryland residents today, 88% of our residents can reach a location within 10 minutes, and 97% of our residents, as you heard from my co-panelists, can reach a location within 20 minutes. In total, Maryland features 380 locations available for residents to drop off their drugs. On top of that, the Drug Enforcement Administration holds drug take-back days 2 times a year, once in the fall and also in the spring. The next collection event is scheduled for April 22nd of this year, and last year they hosted about 105 collection sites all over Maryland. That's in addition to the 380 more permanent locations that are already located in Maryland that I spoke about earlier. CHPA has long been an advocate of responsible medicine use, safe storage, and proper medicine disposal. We work on this very issue with the CDC and other organizations. The bottom line is there are already ample opportunities for Maryland residents to dispose of their expired or unwanted medications. We appreciate Delegate Solomon's interest, and we urge an unfavorable report.
Are there any questions for this panel? Seeing Delegate Taveras.
Thank you. I have a quick question just because, I don't know, what are the barriers with regards to receiving drugs to be donated through, let's say, a Doctors Without Borders once received? Are there any concerns with the end results of where the drugs will go? Or I'm just trying to find out what are the blockades to receiving those drugs after being donated and being put to better purpose. Particularly in developing countries that are highly in need of expensive drugs that they wouldn't otherwise receive.
So I can try and take that. Unfortunately, I'd have to get back to you directly on the donation of drugs to organizations like you speak of. In particular, this particular take-back program would be for the unused or expired drugs. So for that, they would be properly disposed of rather than donated to another place.
It's just that some expired drugs are still good. It's just a label issue. That's what I've heard from some doctors, and they've used it. I'm just familiar of doctors that have worked to collect drugs to take them to the Dominican Republic and other parts of Haiti. So I'm just saying about these kinds of things are things that we've worked on with the Rotary Club. So I just thank you. I'd love to receive that.
Delegate Hill.
Thank you, Madam Chair, and thank you all. I appreciate that you're saying that we've got a very robust take-back program, and I'm aware of it in my community as well. That doesn't mean we can't do better. So do you know if the Department of Environment or any other group has any reports or information on whether we're seeing a decrease or an increase or any change at all in the amount of pharmaceutical levels we're seeing in our water from drugs being flushed? Do you know that we're actually making progress other than that we have a lot of programs?
Yeah, I think, number one, no, I don't know of any studies by the department. They may have them, but I think the problem is always going to be that most of the drugs that are found in the water system are actually passed through our bodies. So it's hard it might be difficult for them to distinguish if it comes from the body or it's because of something else. But also the FDA also does have a flush list of medicines that can be disposed of in the toilet. So I guess that would be an added difficulty to determine all of that. We probably can say that probably the best way to kind of answer that question too is like the amount of drugs that are actually being collected has been going up every year.
Any other questions? Seeing none, thank you for being with us today. We do have a virtual witness. Will you let her in, please? Two, actually. Let them both in. Thank you so much. Good afternoon. Will you get started? Introduce yourself.
Yes, Madam Chair and members of the committee, my name is Catherine Kirk Robbins. I'm one of the deputy directors at Maryland Healthcare for All. Thank you for the opportunity to testify in support of House Bill 517 today, and we are also in support of the sponsors' anticipated revisions. I'll keep this brief. You've heard that this is a good bill for public health as far as reducing potential pollutants in our environment and for limiting accidental ingestion or abuse. We'd also welcome the exploration of improving the use of pharmacy repositories as a tool in both safe disposal and ultimately improving prescription drug affordability. And we feel that the proposed work group in the anticipated amendments would be a good tool for doing so. We really want to thank Delegate Solomon for the work that he's done in determining what is actually needed to improve upon our existing take-back infrastructure, and feel that having a robust program that people are aware of and actually are using will be a really good benefit. We think it's a common sense way to keep our communities safer, and thank you for your consideration and urge a favorable report.
Thank you. Are there any witnesses for this? I'm sorry, are there any questions for this witness? Thank you. Thank you for being with us. Next, please. Can you get started?
Yep, is it
Thank
for
you.
me? Okay.
Yes,
My name
please.
is Ashley Van Meter. I am with the Association for Accessible Medicines. We are the nation's leading trade organization for generic and biosimilar medications and manufacturers. I would echo the comments from my counterparts for the brands at Pharma and also from CHIPA that we feel at this time there are existing programs that cover Maryland in such a way that it is very easy for consumers to get to safe disposal sites. And there are currently, they've also spoken to PPSWG and mild meds and those sorts of things that have a lot of substantial education materials out there for how to safely dispose of your medicines. And to the one question about the disposal in the water and such, I believe FDA has stuff on that on their website saying that there was not an increase in showing in, for example, the water or groundwater when there was not disposal systems because of evacuation, that people take the medicine, it ends up in the water that way. Also, representing the generics, we have additional concerns that lots of times these programs, because of how the statutes are written, the great majority of the funding falls on the backs of the generic industry, who provides the safe and effective and much more affordable medications to Marylanders. And so for that, in addition to our concerns about an unnecessary, for example, program, we are concerned that without any kind of funding mechanism that bases any kind of promotion or education on the revenue made in the state, the generic industry will actually pay upwards of 80%, and the brand industry around 10%, and over the counter the remaining 10%. We think that all people in the supply chain, if we're going to pay for this, should have a fair and equal share of the responsibility for payment.
Thank you. Are there any questions for this witness? Yes, Delegate Hill.
Just real quick, the expiration dates are partially set by federal and local law, but it's also set by the manufacturers. And it's not true that if with there already being evidence that most prescriptions are actually staple on the shelf for much, much longer, that if manufacturers extended the expiration dates, there would be fewer drugs fewer drugs left to dispose of, and that would also help us.
I mean, that's something that we have to strictly follow. Not only do we have to follow, FDA, we have to be exactly as the brands and have the same labels and everything. We can't be different. I will say, I know that there was a question about donation. There are a lot of donation bills in other states. I cover 26 states for the generic industry, and a lot of states now have the kind of bill that you're speaking to, where there is a process for collection and manufacturers donating and a way for patients to find out how to donate unused medicines to give to populations in our country and abroad that need the medicine and can't afford it.
All right, thank you.
Thank you. Any other questions? Seeing none, thank you very much. Thank you for being with us today. We appreciate it. We have another witness. Is she coming up? That's it? Okay, great. So this actually concludes the bill hearing on House Bill 517. Delegate Solomon, thank you for being with us today. And Delegate Shalega, thank you for your willingness to work with the delegate. So next we have Delegate Johnson, House Bill 813, Maryland Medical Assistance Program Prescription Digital Therapeutics. And if you haven't figured it out, today is Prescription Drug Day in HGO. So while Delegate Johnson comes, will you be so kind, Francis Thorndike? Yes. If you can come up, Dan Martin and Faber Obasiolu. And then we have a virtual witness, and that will be the sponsor panel. Delegate Johnson, will you get started, please?
Thank you, Madam Chairman.
My pleasure.
It's good to be with you and members of the HGO Committee. For the record, Delegate Steve Johnson, I'm here with stakeholders in support of House Bill 813, Maryland Medical Assistance Program, Prescription Digital Therapeutics, and that is a mouthful. Now, some people get up here and say I have a very simple bill, but I want to tell you today that I have a very cool bill. We all have these, right? And we know how much we use these every day for everything. How much technology is in these, and how they're attached to our hips 24/7. We are way more comfortable with technology today that we use through our phone than we were before COVID. And really, that's what this bill is about. Prescription digital therapeutics, PDTs, are the new field of prescribed software-based FDA-cleared products delivering improved health care outcomes for Americans living with serious medical diseases and conditions like substance use disorder, ADHD, insomnia, major depression, diabetes, stroke, among others. A link to a video providing an overview of PDTs can be found on your agenda provided by the committee staff, as well as I emailed you one. It's about a 2-minute video that really visually walks you through this bill, and it's very helpful if you get a chance to watch that. This bill brings a portion of telehealth to a whole new level. These therapeutics are also new. They're also new. However, there is no current category within the Maryland Medical Assistance Program to provide coverage. This legislation would establish that PDT benefit category. I'm also including and introducing a sponsor amendment to conform this bill with the Senate bill, which broadens coverage to all PDTs. PDTs are reimagining how we treat human disease by using cutting-edge software that can be uploaded to a patient's phone or tablet, using a prescription in conjunction with ongoing clinician care management. These new technologies are backed by the FDA for clinical safety and efficacy data and deliver quality care around the clock and HIPAA compliant for data privacy. The rest of my panel will talk about the benefits of these PDTs and coverage for these therapeutics in other states. And for those reasons, I respectfully request a favorable report on House Bill 813.
Thank you. Who will be next?
Whoever wants to go next.
I'll go. Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland. I'm here today also speaking on behalf of Brain Futures, which is a national nonprofit based here in Maryland that works to advance access to proven brain-based interventions. And we are here in strong support of House Bill 813. We've been talking about it all session. Demand for mental health care is at an all-time high. At the same time, we're dealing with a really challenging behavioral health workforce shortage. And digital mental health therapeutics can help. They provide an effective and scalable method for extending the reach of quality mental health care. Research has shown that they're effective for treating PTSD and depression and anxiety with mild, moderate, and severe symptoms. Their efficiency in treating common mental health conditions is comparable to standard face-to-face therapies, and they're shown to be effective across the lifespan, with a growing number of studies indicating effectiveness for children and adolescents as well as for older adults. A recent forum of national and international experts representing healthcare organizations, insurance companies and payers, employers, patients, researchers, policymakers, health economists, and more published a paper calling for an expanded access to and reimbursement for these therapies. And so an increasing demand for mental health care coupled with a really persistent behavioral health workforce shortage calls for new and innovative solutions, and that's why we support House Bill 813 and urge you to do the same. Thank you.
Thank you. Next, please.
Madam Chairwoman, members of the committee, I want to thank you for the opportunity to provide comment on House Bill 813, which I agree is a very cool bill. I am Frances Thorndike. I am a clinician, a clinical psychologist by training, and currently head of medical affairs at Pear Therapeutics. Pear is one of several commercial stage healthcare companies that's pioneering this new class of medicine. Software as medicine, prescription digital therapeutic. There are these new terms that we are rolling around in our mouths, but the idea is not new. So 20 years ago in Bethesda, Maryland, I worked on my first project along these lines. It was right after the 9/11 attack on the Pentagon. And in the field of PTSD, we were saying to ourselves, how are we going to help victims of mass violence? How are we going to get care out there? And technology was one of the things that we wanted to study, that we wanted to look at. So we've come a long way. I cannot tell you how exciting it is to be before you today. But just to give you a little bit of information about where we are today with prescription digital therapeutics. Like pharmaceuticals, we are evaluated by FDA. So we do our clinical development process, we do our research, we spend years doing that work, then we go to the FDA for review. They review the submission. They look at the research, but they also look at what is the prescription digital therapeutic, what are the outcomes, what are the endpoints, are we making a meaningful difference? These are only available. They're not like the health and wellness apps that you have on your phones today. They are only available when a licensed healthcare provider prescribes these for the treatment of some disease or disorder for which they have diagnosed. So in closing, I just want you to imagine that we could add something for a state in crisis, like many of our states, all of our states, right? We have a healthcare crisis. We have the opioid epidemic. Is there something we could do to add a layer of support, a layer of access to treatment, really helping our patients stay engaged in a way that works for providers and also takes healthcare dollars out of the system? Thank you so much for hearing today.
Our pleasure. Next, please. Yeah. Will you let her come closer? Thank you. Thank you. Thank you. You can get started.
Good afternoon, members of the HGO Committee. For the record, my name is Favor Abasielu, and I am with Public Policy Partners. My team and I have several clients who support House Bill 813. These clients are the Maryland Association of the Treatment of Opioid Dependence, the Maryland DC Society of Addiction Medicine, and the Maryland chapter of the National Council on Alcoholism and Drug Dependence. Technology has transcended almost every facet of our daily lives. Digital health has allowed millions of people to still get the treatment that they need from anytime, from anywhere. PDTs have the potential to remove the geographic barriers of traditional medicine. Some of the digital prescription that you've heard about so far is part of treatment plans for people with substance abuse, including opioid abuse disorders. We strongly believe this new technology should be available for everyone in treatment who are enrolled under the Medicaid plan. Furthermore, please see our clients are in support, and we ask for a favorable report on House Bill 813. Thank you.
My pleasure. There's one virtual witness, and then we're going to take questions because that will conclude the sponsor panel. Good afternoon.
Hi, thank you all for having me. Chair and Vice Chair, members of the committee. My name is Andrew Molnar. I'm the CEO of the Digital Therapeutics Alliance, which is the trade organization made up of over 100 different companies that are working on these innovative technologies to change the face of healthcare and how we provide it to patients across the United States and across the world. On behalf of the Digital Therapeutics Alliance, we're pleased to support HB 813, which would define prescription digital therapeutic as a product, a device, an internet application, or any other technology approved by the FDA that has an approved indication for the prevention, management, or treatment of certain medical conditions, primarily uses software to achieve those results and requires a prescription. This bill also requires the Maryland Medical Assistance Program to provide coverage for prescription digital therapeutics for program recipients. The DTA, or the Digital Therapeutics Alliance, was founded in 2017 as a nonprofit trade association of industry leaders and stakeholders engaged in the evidence-driven advancement of digital therapeutics. As the leading international organization on DTX, thought leadership, and education, DTA provides patients, clinicians, payers, and policymakers with the necessary tools to eliminate and utilize DTX products. Digital therapeutics are transforming healthcare by increasing patient access to safe and effective therapies, by extending clinicians' ability to care for patients and offering payers scalable and cost-effective interventions. There are currently 9 FDA-approved digital therapeutics products that are prescribed by your healthcare provider and intended to supplement but not replace visits. And unlike the general health apps you see on your phone, these digital therapeutic products are proven effective by the FDA and protected under HIPAA. Digital therapeutics range in capabilities from calculating insulin doses to delivering cognitive behavioral therapy, treating things like musculoskeletal disorder, and substance use disorder, and PTSD. These platforms can help track and manage symptoms as well as improve medication adherence. These digital therapeutics work, and this bill would help patients access them. For these reasons, we respectfully request your support for HB 813.
Thank you. Are there any questions for the sponsor and his panel? Delegate Bagnall.
Madam Chair, and I apologize if I missed this in your testimony, but are digital prescription therapeutics already covered under private insurance?
Just to answer
They are covered under some private commercial insurers, but not in Maryland.
Any further questions? Seeing none? Thank you. Great work.
Thank you, Madam Chair.
My pleasure. Next, we have a favorable with amendment, Mr. Daniel Shutter.
Thank you, guys.
Good afternoon.
Good afternoon. Good afternoon, Madam Chair, members of the committee. For the record, my name is Dan Shattuck. I'm here today on behalf of the Maryland Psychological Association. I want to thank Delegate Johnson for bringing forward this new bill. This is great, and we are here in support. We do have an amendment we wanted to offer. Currently, prescription digital therapeutics, the way the bill is written, would require a prescription. Psychologists are not prescribers. They can't write prescriptions, but they can often order and recommend the use of devices. The Food and Drug Administration and their guidance on prescription devices, medical devices, allow for the terminology order as well. So this takes into account those healthcare providers that can't prescribe. So our amendment would be to add language to number 4 that would specifically state that on the prescription or order of a therapeutic device per federal regulations, it would be allowed. This, we think, would open the door not just for psychologists, but for other healthcare providers that want to use these therapeutics to be able to do so. So with that, we ask for your favorable report on the bill with our amendment.
Are there any questions for this witness? Seeing none, thank you very much. We have an unfavorable, Deborah Brocado. Deborah Brocado, not here. May we go to the virtual testimony, please? Favorable with amendment. Will you be so kind and let them both in? Thank you. Good afternoon. Will you be so kind and get started, Mr. Berman?
Good afternoon. Thank you very much, Madam Chair. My name is Dr. Paul
You're
Berman.
welcome.
Thank you. I'm a psychologist and in practice in Towson, Maryland, and work part-time for the Maryland Psychological Association. And I'm here on behalf of the Maryland Psychological Association to testify in support of House Bill 813. You heard from Dan Shattuck with regard to the amendment that we've introduced. The amendment is consistent with FDA policy and regulation, which, as Dan said, allows for the ordering of the use of these devices by other licensed healthcare professionals. The reason this is so critical is because the vast majority of digital therapeutics at this point are for mental health conditions. And the majority of the practitioners who treat mental health conditions are psychologists, licensed professional counselors, and social workers. And if we are not allowed to order these devices, then you are limiting access to these innovative treatments for the vast majority of patients. The other comment that I would like to make is that we're starting to see medical cost offsets with the use of these devices. That is, the cost of the device itself is more than offset by savings in treatment. In addition, there are additional savings in the use of these devices beyond the cost of the treatment itself. For these reasons, we encourage you and ask that you favorably report on House Bill 813. We also have a representative from the American Psychological Association joining us, and I look forward to her testimony as well. Thank you very much, Madam Chair, members of the committee.
Thank you for being here. Are there any questions for Mr. Berman? Yes, Delegate Hill.
Thank you, Madam Chair, and thank you for testifying. Just the Department of Health is concerned about a couple of things, and I think your amendment addresses one of them. But the question is, to what extent would they be paying for supplement, if they use these devices, will it be supplementing ongoing treatment so they're, as opposed to replacing it? So will their costs go up because now they're paying for more stuff? Or will there be fewer treatments?
So I appreciate the question, Delegate Hill. These devices are used, and these digital therapeutics are used in conjunction and do supplement treatment by with a clinician. So the Department of Health's concern is that there would be increased costs. But what we find from the research is that the use of the digital therapeutics increases compliance and increases retention, and therefore the outcomes are much more positive than with just the clinician alone. Therefore, what we're finding by looking at the research is that the cost of the additional treatment is more than offset by savings down the line by decreased hospitalizations and decreased additional services. So while I appreciate the concern of the Department of Health, that is not consistent with the research that we're finding that's being done at this time with regard to the savings in costs from digital therapeutics.
Okay. And I didn't ask the question of the sponsor, but I would probably venture to say that an amendment that deals with some reporting to make sure that the cost is what it is, and to report to the committees and to be able to make adjustments in the future will be all right with the advocates, correct?
I can only speak, Madam Chair, for the Maryland Psychological Association, but of course, at your pleasure, that would be, I think, a very helpful addition.
Thank you. Any other questions for this witness? Thank you for your time. Ms. Baker, good afternoon.
Good afternoon. Thank you for allowing me to participate in today's hearing. My name is Deborah Baker. I am the Director for Legal and Regulatory Policy at the American Psychological Association, and on behalf of APA, we support HB 813 with amendment as previously described by Dr. Berman and Mr. Shattuck. Primarily, we'd like to point out that as other witnesses have mentioned, digital therapeutic products are not to be confused with the general health and wellness apps that are easily accessible by consumers through app stores. These are software as medical devices and are available by order or prescription of a qualified healthcare provider. By adding the term order and the language we had included in our written testimony that we've submitted to the committee, by adding the proffered language, it ensures that all qualified healthcare providers can access these devices for their patients. And given that the number of FDA-cleared digital therapeutics involves digital cognitive behavioral therapy interventions, it's only natural that psychologists should be able to access these along with other licensed mental health care providers. It's also important to note that FDA license labeling requirements puts the onus upon the product makers to describe the list, the category of eligible healthcare providers who should be able to access these products. And so this distinguishes that the regulation of digital therapeutics is not identical to the regulation of prescription medications. So including the word order along with prescription ensures or makes clear to all stakeholders that that the device should be available to all eligible healthcare providers and therefore to all recipients of the Maryland Medical Assistance Program to ensure that they have access to all evidence-based services.
Thank you. Thank you. Are there any questions? Delegate Hill.
Is there any reason that we should consider, if this bill passed, putting something like the federal Stark amendment on it, saying that if a provider is prescribing these, they either have to give full disclosure if they have a financial interest, or that they can't prescribe if they have a financial interest?
Who's the best person to answer that? Ms. Baker, would you like to take a shot at that?
I'm not sure that I'm the best person to answer that. I would think that to a certain degree, the Stark laws would already involve that as in terms of healthcare. Even though it's software as a medical device. And so if medical devices are already covered under Stark law, by extension, it would include digital therapeutics.
Thank you.
Thank you. Any other questions? Thank you very much for being with us today. We really appreciate it. You have a wonderful day, okay?
Thank you very much.
Thank you. This actually, for the committee, concludes the bill testimony and the hearing on House Bill 813. And next we have House Bill 539, Delegate Morgan, Pharmacy Benefits Manager, Prohibited Actions. Actually, I was wrong earlier. This is not Pharmaceutical Day. This is Johnson and Kipke Day. I think a dinner may be needed in the future. Delegate Morgan. Absolutely. Thank you. So I have for your sponsor panel, James Doyle, Aliyah Horton, Sarah Price, Brian Hose. Is that correct? And you can get started, Delegate, when you're ready.
You know, I was going to open with a joke and say that I'm happy to present House Bill 539 to you on Pharmacy Day when it is Delegate Kipke and Delegate Johnson Day. But I remember maybe it was 5 or 6 years ago, some of the people who were on the committee might remember this. We had our former Attorney General, it was Attorney General Frost, into our committee to talk about the escalating price of prescription drugs. And I remember asking him a question that day and asked him, why is it now? Why are prescription drug prices rising now? And he answered it because of greed. And I said, well, the problem, Attorney General, is greed's been around for a really, really long time. Why now? And the truth is, under the Affordable Care Act, it just made it really advantageous for some of these bigger corporate mergers to take place. Prior to the ACA, there were 66 PBMs. And now there's basically 3 PBMs with an overwhelming market share. And this bill goes to stop some of the unfair, and I would say predatory practices that PBMs have committed against independent pharmacies. Bill basically has 3 pieces, 4 pieces by the fiscal note, but 3 main pieces. First, this bill eliminates spread pricing. Spread pricing is what the PBM is willing to pay the manufacturer for a drug versus what they're willing to reimburse the independent pharmacists for the drug. Second, it protects pharmacies and consumers by not having mail order pharmacies pushed down on them and not being steered away from possible using independent pharmacists. And third, it standardizes co-pays across all pharmacies. And with that, Mr. Chairman, I'd turn it over to my sponsor panel here, and I would ask the committee for a favorable report, and I look forward to answering your questions.
Next, please identify yourself.
Good afternoon, Mr. Chair and honorable members of the committee. My name is Sarah Price, and I'm here on behalf of the Maryland Association of Chain Drugstores, strongly in support of HB 539. You have our written testimony, so I will be brief. As the sponsor noted, spread pricing is the process by which a pharmacy benefits manager will negotiate a drug price with purchasers and then reimburse pharmacists at a lower rate for the same drug. Oftentimes what you see here is that PBMs are able to negotiate a rebate on drugs from the manufacturers, and then they keep the profits from that rebate. I've heard them refer to this as a keeping what you kill process. Basically, they're negotiating their own commission. And in doing so, they're setting arbitrary reimbursement rates for pharmacies in order to inflate those profits. This is having a highly negative impact on pharmacies as the lack of reimbursement for the services that they're providing makes it very difficult for them to meet their operational costs. So we highly encourage the prohibition of spread pricing. Additionally, prohibiting steering practices and standardizing copays it protects patient choice by allowing any patient to use whatever pharmacy they choose to do so to get their prescription drugs. So with that, we would urge a favorable report. Thank you.
Thank you.
Good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. Our members are pharmacists, student pharmacists, and pharmacy technicians in the state. We are not a trade association. Our members are professionals, and we do hear consistently from our members about the concerns they have regarding PBM practices. And so as we're kicking off this portion of the hearing, I just wanted to highlight that this has been an ongoing conversation that has not been resolved. Currently, the FTC is investigating PBMs. On February 15th, the Senate Commerce Committee held a hearing on PBM practices. Just yesterday, the chair of the House Government Reform Committee, James Comer, announced a formal investigation of PBMs. And in response, the CEO of the PBM Trade Association, PCMA, launched a $7 million ad buy. And so we know that this is serious. And while they're working at the federal level to address these issues, we know how slow, I'll just say it, the federal government is. And Maryland has an opportunity to implement change. And so we continue to pick away at what we can because there are so many issues related to PBMs that impact pharmacy and pharmacy practice. And so we hope that the committee will move forward with a number of the bills that are presented today to provide some relief to our pharmacists in the state. In regards to HB 539, we are in support of it, and at a base level, it allows any pharmacy that's willing to accept a network contract to be a part of a carrier's network. It seeks to level the playing field and further serves to eliminate spread pricing, where PBM savings in that spread are earned on the backs of under-reimbursed pharmacies. And with that, I urge a favorable report.
Thank you. Members of the committee, I'm Brian Hose. I'm here representing my small independent pharmacy in Western Maryland, as well as Epic Pharmacies, a group of independently owned pharmacies within the state. Imagine that whatever business you're in, you have to make a deal with someone who is your direct competitor, and that direct competitor gets to determine all sorts of things that happen to you within your business. That's what I live every day. Our biggest competitor down the block happens to own a PBM. So we are constantly dealing with patients who are steered to other pharmacies from ours, regardless of where they would like to get their prescriptions filled. For us, patient steering, it hurts patients. It hurts Maryland communities by moving these prescriptions out of the patient's local community. And it hurts Maryland because it moves these dollars out of the state. These prescriptions that are filled by these corporations that are housed in other states by mail order facilities that they own, it forces those dollars to go out of Maryland. We we believe that the best healthcare is that occurs at the patient's choice and near where the patient lives. Independent pharmacies have been, a backbone of that care for patients in Maryland forever, and we continue to fight to level the playing field so we can continue to provide those services to them. Spread pricing is something that we've been speaking against for as long as I can remember. Paying a pharmacy down here and charging a carrier up here, keeping the difference. We hear that some contracts with PBMs that the person paying for that contract actually prefers that. I can't imagine why that would be unless they've been told that it's the cheapest way to go, which I believe is what's happening. We speak to get transparency in the marketplace on a lot of these bills today. You'll hear that as a common theme.
Thank you. Mr. Doyle?
Thank you. James Doyle on behalf of the Independent Pharmacies of Maryland. I guess I have the easiest role in testifying because I agree with everything that's been said. But just let me say a couple of other points that I want to make clear, and that is that have led to this bill. Number one, the state of Maryland has already, for the last several years, recognized the predatory nature and the predatory actions that have been undertaken by the PBMs. Attorney General Frosch, in several amicus briefs joined by many states throughout the country, has taken the position on behalf of the state of Maryland that PBMs operate their own mail order and retail pharmacies, and they are doing it in a way that makes them particularly take advantage of their own self-dealing and unfair advantage. That they also lower reimbursement rates to independent pharmacies, that they give advantages to the PBM's own affiliated or owned retail and mail order pharmacies. So that's already been recognized for years by the state of Maryland, the predatory nature of PBMs. And because of that, PBMs have been able to rack up tremendous profits. Just the CVS PBM in the state of, in this country, just the CVS PBM last year had a revenue of over $169 billion. That's not the pharmacies, that's not Aetna Insurance, that's not CVS mail order, that's just the CVS PBM. And meanwhile, we have all of these practices that we're talking about. Spread pricing, unequal co-pays, and that sort of thing that you can read in my testimony that need desperately to be eliminated for independent pharmacies.
Are there questions from the committee for these witnesses? Yes. Delegate Kipke.
Mr. Chairman, Brian, the PCMA lobbyist sent information saying that the pharmacy market in Maryland is stable. Can you help the committee understand the realities of the pharmacy market? Thank you.
So I'll try. We did some digging. We looked into that the data that came out, and it appears to be accurate based on the numbers of pharmacies. What you can't see with the data they presented is where those pharmacies are closing and where they are opening. We've known for some time that pharmacies in underserved areas where the patients do not have the money to support a pharmacy selling them other things. So if you have to take reimbursements below cost and you can sell people, X, Y, Z other items where you can make money, that's still a way that pharmacies can survive. So in affluent communities, we see that pharmacies continue to be able to make money. Where we see pharmacy deserts, as you'll hear, is where communities are not affluent. They aren't able to support pharmacies in that way. And pharmacies are made to rely on reimbursements from Medicaid MCOs, where they are the poorest of reimbursements that we see. Pharmacies cannot continue to survive in environments where they only get Medicaid MCO claims in Maryland, and they can't have other revenue streams. And I think that's what we're seeing. We're seeing a flat line of numbers because there are pockets where it's still profitable, but the deserts are coming in places where we need them the most.
And Delegate, could I also add to that?
No, sorry, just one witness.
Oh, I'm sorry.
responding to each question. Seeing no further questions, we thank you. Well, Delegate Zalega, I think I know what you might ask. Go ahead.
I'm not that clever. I should have thought of that first. In the bill, it says they may not take more than 30 days to renew the application of a pharmacy bill, that section of the bill. So whomever is best able to answer this, how long is this taking? I mean, it seems that 30 days seems very adequate. How long are they taking to make this happen?
So initially, we're seeing some PBMs will fail to credential pharmacists for up to 6 months. We're seeing that some of those applications can take a very long time to get processed through, depending on location, and some of it has to do with what goes on in those locations, as far as whether it's a heat zone for narcotic, all sorts of reasons. But pharmacies are being made to wait, upwards of 6 months in some cases to get contracts and credentialed through PBMs.
Delegate Hill, let's see if I'm batting 500.
Mr. Doyle, I'm so curious. Can you tell me what it was you were trying to say?
Well, I will. And that is that I believe that the argument that the PBMs are making, that somehow the independent pharmacies are stable, is an argument of desperation, and is an argument that is totally irrelevant to what we're here talking about today. It doesn't matter when you're talking about practices that are unfair trade practices or deceptive trade practices or those sorts of things that take advantages of businesses. It doesn't matter one bit in terms of redressing that, whether the industry that's the victim of that is suffering and is less stable or is more stable. The point is the practice itself. Are we dealing with unfair and deceptive trade practices by PBMs? And the answer is clearly that we are. And it doesn't matter one bit whether they can come in and say, well, we've looked at the number and the number is stable, because there could be a number of reasons why that number is stable. The point is, what are the practices that the PBMs are doing, and are they unfair and deceptive?
Delegate Lewis.
Thank you, Mr. Chair. Thank you to the bill sponsor and to all the panelists. Here we are again, still talking about PBMs. My question for you, whoever is best to answer, one of you mentioned the imminent arrival of pharmacy deserts, and I'm just wondering if we are including pharmacies and pharmacists in our statewide Commission on Health Workforce, and if you are able to answer that. Anyone? Because if not, it sounds like it might be important to include pharmacists in our exploration of healthcare workforce statewide. Isn't that so?
I just had, is this the Public Health Commission that you all were? Okay.
But the one we passed, I think, last year, that set up a commission to study the current status of health workforce and project future needs. So, yeah, it sounds like a pharmacy desert sounds like a really bad thing we should try to avoid. Thank you, Mr. Chair.
Okay, that concludes the testimony from this panel of proponents. We'll now hear from a panel of opponents. Matthew Celentano, Jennifer Breenan, Michael Johansson, Camille Fresh, and Kimberly Robinson, and Heather Cascone.
I think I'll just go. Good afternoon, members of the committee. My name is Matt Celentano on behalf of the League of Life and Health Insurers of Maryland, opposed to House Bill 539. We think the main point of this bill is that it's not really a PBM bill, it's a carrier bill.
as they are the purchaser in this legislation. The only entities being impacted here are the health plans and the state health benefit plan. The prohibition on spread pricing is essentially for health plans only, and there are no plans here asking for this bill. Also, the spread has no impact on pharmacist reimbursements. We're not really sure why this is being proposed. In addition, it's been shared with me from members that some plans are actually seeking out spread pricing type arrangements as though they can maximize savings for their particular groups. There's also language 1611B2 we interpret as any willing pharmacy in this bill, which is a concern. That removes the incentives for any pharmacy to join our networks, which carriers are actively looking to expand. These types of measures would also threaten long-discussed network adequacy regulations on network sufficiency that's been developed by the Maryland Insurance Administration. Any willing pharmacy measures have the opposite effect of the intent. In 2015, the Federal Trade Commission letter, in a Federal Trade Commission letter to CMS, the FTC made it clear that, quote, any willing pharmacy provisions threaten the effectiveness of selective contracting with pharmacies as a tool for lowering costs. Requiring prescription drug plans to contract with any willing pharmacy would reduce the ability of plans to obtain price discounts based on the prospect of increased patient volume and thus impair the ability of plans to negotiate the best prices with pharmacies. We respectfully ask for an unfavorable report on House Bill 539.
Good afternoon, Mr. Chair, members of the committee. My name is Jennifer Bremen. I'm the Executive Director of the Maryland MCO Association. The association represents the 9 MCOs that serve Maryland's Medicaid program. We serve the 1.5 million Marylanders covered by MCOs under Maryland Medicaid. That would be roughly 1 in 4 Marylanders that receive their health care coverage through an MCO. You do have our written testimony, so I will be brief. I'd like to thank the bill sponsor for introducing this bill and attempting to identify efficiencies and cost-saving measures within the Medicaid program. The MCOs are committed to that goal as well, but we respectfully disagree that this bill achieves that goal. We would urge the committee to look at some of the measures that were implemented in 2021, including the elimination of spread pricing from the Medicaid program, the creation of the appeals and grievance process, and the funding of the rural pharmacy program before any more measures were to be implemented in the Medicaid program. Before this were to be implemented, Medicaid does have very unique provisions separate from the commercial carriers. We would be happy to work with the bill sponsor, but in the meantime, we would urge an unfavorable report. Thank you.
Will this turn on? Am I okay?
You're fine.
You're on. I'm Mike Johansson on behalf of the Pharmaceutical Care Management Association. We are opposed to this bill. Let me address the any willing pharmacy provision. For 20 years, we've had any willing provider bills, and the General Assembly has not passed that type of legislation. Being admitted into a carrier's network is part of a negotiation. It's part of what the carriers believe is necessary for their network. And it's also governed by network adequacy standards that the MIA regulates. Medicaid also has network adequacy standards. The concept of any willing pharmacy and conversely narrow networks is best exhibited by the current state health plan, which is something that is procured by DBM. They offer a couple different health plans. One is an exclusive provider organization / narrow network, and one is an open network, a PPO, within network and out-of-network providers, but you can go see everybody. There is a 30% monthly cost savings if you're in the narrow network plan. And as an option for state employees, it's a good thing to do. On pharmacy, a narrow network gives an employer and a plan sponsor a way to save money on prescription drugs. We all know prescription drug costs are reaching too high too fast, and it's one of the options that you have to minimize pharmacy spend. Secondly, with respect to the number of pharmacies across the country, independent pharmacy numbers are relatively stable, yes. Some pharmacies close and other pharmacies open. There's actually been a reduction in chain pharmacy stores throughout the country, largely because of a lack of healthcare providers, pharmacists, and pharmacy technicians. But despite the chains going down, the number of independents is staying the same. I think the question you have when you get to stores closing and stores opening could be geographic, as Brian mentioned. We appreciate that. But also the concept that people are opening new independent pharmacies. He acknowledged it. If 10 close, 10 are opening, maybe 11 are opening. If they're opening after sitting in front of you for 10 years and saying it's a horrible business to get into, why are they opening independent pharmacies? They know what they're getting into. If they don't like the business, don't open it. So we oppose the bill.
Kimberly Robinson.
Thank you to the chair and members of the committee. Kimberly Robinson on behalf of the Cigna Group. Here respectfully in opposition to House Bill 539. The bill does have a lot of moving pieces. You've heard some of my colleagues speak to them. I'll just try to touch on some of them very briefly in the time that I have. One, I'm going to start with spread pricing with Mr. Celentano, I think addressed very, very well. I'm not sure where the idea that it has any impact on pharmacy reimbursement came from, but that, although said repeatedly, is completely inaccurate. Spread pricing has no effect on what the pharmacies are ultimately being reimbursed. The reimbursement is in the contract between the PBM and the pharmacy, and it doesn't change depending on what the funding mechanism that the purchaser selected, which is spread pricing, flat fee, or something else. That is only between the PBM and the purchaser. It has no impact whatsoever on reimbursement. And what we know is that when you move from spread pricing to something else, all it means is the purchaser ends up paying more. Purchasers ask for that as a price mechanism, and it's a choice that they choose to make. We don't choose it for them, and it's not going to change reimbursement rates. The bill also talks about mail order. Maryland already prohibits preferred mail order in the commercial market. So except for the fact this bill thinks that it can change that for ERISA plans, I would argue it's plan design, and that's outside of the scope of the state's reach. That's actually already the law in Maryland. I understand that may not be what pharmacies are experiencing, and that is in fact because the ERISA market is not going to be governed by this bill and is not covered by the current law. The bill has any willing provider, which I think you heard Mr. Johansson and Mr. Celentano talk about why we know that's a cost driver in healthcare. And so this bill will ultimately make health coverage in the state more expensive for Marylanders if you were to move to an any willing provider mechanism for how it's being paid. And I'm going to run out of time. There's a few more things the bill does. Ultimately, we believe that the bill is going to raise healthcare costs, and we think that that should be your primary concern because we want to keep drugs affordable for your constituents. Thank you for the opportunity.
Is Camille Fesh here?
We're just doing one, Mr. Chair.
Okay. Any questions for this panel from the members of the committee? Seeing none? Oh, I'm sorry. Delegate Bandari.
Yeah, thank you, Mr. Chair.
I'm looking at you from this angle.
Thank you, Mr. Chair. I know this is the toughest panel to ask the question, but I will try. I was looking MCO's opposition letter to this bill, and the purpose of the bill is to prohibit pharmacy benefit managers from engaging in certain harmful practices that ultimately increase costs for Medicaid participant and taxpayer. It is not simply a matter of codifying existing regulations, but rather an effort to protect vulnerable individuals who rely on Medicaid for their healthcare needs. Don't you agree that?
Can you repeat the question? I'm sorry.
The bill is not simply a matter of codifying existing regulation. That's what your letter says. But it is an effort to protect vulnerable individuals who rely on Medicaid for their healthcare needs. How could you refute that argument?
I mean, we agree that that's our number one goal too, but the bill does codify existing regulations that eliminate spread pricing. But every year, the MCOs renew their contract, and that gives us the ability to change and be nimble with what is needed to protect the members that we serve in the best way possible.
Quickly, briefly.
And the another point you raise is like the MCO's argument that codifying policies such as elimination of spread pricing would take away the flexibility needed by MDH or CMS to adjust the provision of the healthcare program. I believe that is unfounded. Why don't you think this codifying such policy would provide greater clarity, number one, and transparency for all stakeholders, including PBMs, pharmacies, and patients?
Well, I think that right now it exists in regulation, and I think that that gives us the ability every year when we revisit our contracts to be able to adjust accordingly to best serve our members according to where we are with current practices. I think the fact that it exists in regulation and that's the practice that we currently follow is what's needed right now for the program, making this bill unnecessary. It's already 3 years into practice for the MCOs.
Thank you. I'll follow up.
Yep.
No further questions? Oh, I'm sorry, Delegate.
Thank
Delegate
you.
Hill.
Thank you, Mr. Chair. So let me explore this any willing provider thing. In other areas of medicine, practitioners who participate in networks do so for increased referrals but get paid a lower amount. And those who don't participate in a network get paid a higher amount that actually has to be filed with the state, and the cost share to patient goes up. In the pharmacy world, can you explain, do pharmacists who are outside of the network get paid less for the prescriptions they fill than the people in the network? In which case that would be a system that's exactly opposite to what other healthcare providers are dealing with.
Go ahead.
I'm trying to make sure I followed the question, Delegate Hill. So your question was, do pharmacists who are not participating in the pharmacy network get paid more or less for the same prescription? So ironically, not unlike the medical world, one, it depends on how the pharmacy benefit is created. One, about whether or not there's in-network and out-of-network coverage for pharmacy. That's a little different if we're talking about state-regulated plans, because Maryland has already some parameters around how we do pharmacy networks. So pharmacists are going to experience different things depending on the person's contract. And I think it's hard to say because, again, it will depend on what the reimbursement is going to be. I don't know that there's a bright line that you can say it's always they make more if they're out of network or in network. I think the pharmacists desire to be in network, and we appreciate that. We want them in the network. And I think a lot of the frustration right now is because of the requirements of network participation. But what definitely changes, the thing I can speak most to, is what it's going to do for the patient, because the patient's share of that is going to change whether or not they're going in network or out of network, if they have an out-of-network benefit. But I don't know that I have a bright line answer to be able to say, yes, they're always paid more out-of-network versus in. I hear a lot of sound behind me, so I think there's some others who have opinions about the answer that I'm sure they'll share. But that's what I can share with you today.
Yes.
Since it's not really clear that I'm correct that it's a slightly different model, if we use this bill to model the pharmacy reimbursement, since patients have a choice, they're not forced to go, if they have an out-of-network option, they can go wherever and pay a lower price. If we require that pharmacists who aren't participating actually get reimbursed at a higher rate, closer to market rate, that would keep your panels narrow, because the people in the panel would be seeing more referrals and try to make up their costs by more prescriptions, and the ones who aren't allowed in would be getting more per, and that would mirror what we do in other areas of healthcare.
Except that, well, the one thing I would say to that, Delegate Hill, is one, so two things. If a provider's going to make more out-of-network, if they didn't make that their priority, they don't have an incentive to be in-network, and the person who actually pays the most for that is the patient. The patient is going to get less reimbursement covered by a plan, which is what happens in the medical space now. That patient pays a higher out-of-pocket cost, right, when they go out of network. if they have that option. Often, pharmacy networks are exclusive, not exclusive as in you can only stay in network, not as to a particular pharmacy. And that is designed specifically to help manage the cost. If you do that in your networks in their state today, every Marylander who's got a fully insured plan is going to feel that cost shift as their plan ends up paying more money or being less able to manage the costs of the pharmacy, which we know is the biggest single driver of their insurance premium. This matters a lot for the financial experience of your patients and your consumers. We can talk more offline, Delegate Hill. I'm happy to.
Okay, thank you. Do we have any virtual witnesses?
Yes.
One.
Please call that person up, or whatever the right verb is. Okay, yes. Heather Cascone, if I'm pronouncing it correctly, please, it's your 2 minutes.
Thank you, Mr. Chair, members of the committee. Thank you. My name is Heather Cascone, and I represent the PBM industry through its association, the Pharmaceutical Care Management Association. I appreciate the opportunity to raise some potential issues with House Bill 539. 539 prohibits several PBM practices that are ultimately important plan tools that plans use to manage rising drug costs. First, the bill talks about a prohibition on spread pricing. There are two basic approaches employer plan sponsors can use to pay for their services the PBM performs: spread contracting or pass-through contracting, essentially referring to the retention of or passing of prescription drug cost fluctuations. A spread arrangement provides plan sponsors with cost predictability by giving a price certain for prescription drug benefit reimbursements to pharmacies. Employer plan sponsors, as the payer of the prescription drug benefit, have every opportunity to choose the pricing model that best suits their needs, and typically require PBMs to submit bids to request for proposals that address both approaches. Employer plan sponsors choose spread to ensure predictability in knowing what their prescription drug cost will be, and that choice should be theirs to make, since it is the employer plan sponsor who ultimately bears the cost of providing drug benefits. The previous witnesses talked about the any willing provider scenario for pharmacies, which is unprecedented in other aspects of the plan. And third, the provisions proposed in the bill would force employers into essentially a one-size-fits-all plan design that dictates how much cost variability they can bear. It also limits how they can help insulate themselves from those costs by mandating that they include any pharmacy in the network, at the same time removing financial incentives for patients who choose to use preferred networks. We have additional concerns regarding the amount of time and other aspects of the bill, but given the number of these concerns, we must respectfully request an unfavorable report on 539. Thank you.
Thank you. Are there any questions for this witness? Not. We thank you very much. That concludes the hearing on that bill. We're now about to have a triple header. 3 bills by Delegate Kipke. First bill is House Bill 357, Pharmacy Benefit Managers Definition of Carrier, ERISA, and Purchaser.
Thank you, Mr. Chairman. Good afternoon, members of the Health and Government Operations Committee. I think it's important to start with the question, what is a PBM? And I'm not going to go through all the details because you've heard it. But the PBM is basically a negotiator, and they're supposed to serve the interest of the payer. And there are countless examples of why that's a good idea, but things have gotten a little off the tracks, and that's why we have legislation every year. The chairman and I were here in 2007 when a package of 7 bills pushed forward by Dr. Dan Morheim and a group of us to begin the work of regulating through the state PBMs. I believe that happened because it was just prior to that the federal government allowed CVS, a payee, and Caremark, a payor, to merge. And that, in my opinion, created sort of the beginning of a monopoly that started rolling down the hill to where we are today. When you have when CVS is now reimbursing their competitors, it creates an unhealthy balance of power. And as a very proud Republican, Teddy Roosevelt began rolling over in his grave on that day.
If not before.
Back then, there were over 100 PBMs operating, and as it was mentioned by Delegate Morgan, it's virtually just 3. The carrier that we had at the time was punished by the state of Maryland for doing unscrupulous things, and the state put into effect some rules and contracted with something called Catalyst RX, which was a fully transparent middleman, a fully transparent PBM who was unfortunately bought out. All of the bills that we've passed over the years are common sense bills related to how the pharmacy gets reimbursed in a way that's fair, clear, easily understandable. I'll spare you the details for the new members of the committee, but there have been various schemes over the past decade of how a pharmacy would be reimbursed. And let me tell you, these pharmacies really have no leverage in the negotiations. It's take it or leave it. They created a scheme called DIR, GER, MAC pricing, fees that they don't even know that they're going to be hit with. Incentive programs where you have no idea how to hit the incentive. And worst of all, at the end of the year, they claw back money from you, and you have no idea how much, why, how to prevent it. And so there's a series of pharmacists who have been banding together in recent years asking us for help, which is what we've been doing. It's not just about audits. I mean, it's not just about reimbursement. It's also about the way that they're audited as well. So we have passed in a very bipartisan way, either unanimously or nearly unanimously, legislation over the last decade. The bill before you seeks to expand what plans are regulated by the laws that we have already passed, that are already in effect. And let me tell you, the sky is not falling, and admittedly, the laws that we have passed have helped. We need to do more, but we have helped, and we have responded to the small businesses who are seated behind me. The Supreme Court ruled in a very bipartisan way. I know we're not supposed to think of the court as partisan, but you know it is. I think it was Sotomayor and Scalise. I think I'm pretty sure those were the two that wrote the majority opinion and whatever you call somebody that writes an extra opinion. Concurring opinion. And they both basically stood up for the idea that plans are not ERISA exempt as it relates to regulatory aspects that are not related to plan design. So you still can't go after plan design, but if it's about how the audits take place, that there's an 800 number for the pharmacist to call, all those kinds of things that we do that aren't plan design, we're allowed to do it. This legislature asked the Maryland Insurance Administration to look at that and then give us advice on what we can do. And they did. They gave us a report that says, here's what you can do. And we've put before you a bill that does just that. They did notice a couple of things that we have in there that's maybe a little extra, and we might be able to take care of that. But what we have before us is a broad-based protection that I think is extremely important. And before I conclude, I just want to run through a couple of things very briefly. The PBMs and their organization that represents them likes to produce themselves as sort of like this fair arbiter in the middle, trying to fight for their clients and for patients. Well, that's what it should be. But very quickly, if you were to stick in a search on your computer, PBMs, lawsuits, you will see an endless array of lawsuits. October of last year, OptumRx pays Ohio $15 billion for overbilling their Medicaid settlement. November 22nd, Express Scripts pays Massachusetts $3.2 million for cooking the books on their workers' comp medication reimbursements. A MCO settles in Massachusetts for $14 million for overcharging Medicaid. Texas got $166 million from that same company. South Dakota had Express Scripts have to repay millions. Oklahoma had CVS Caremark, again, cooking the books, $4.8 million. I can go on. The U.S. Justice Department got CVS Caremark for $6 million. And it was mentioned earlier, and by the way, they shouldn't be proud of this, right? This needs to be said out loud. We need to know that this is the kind of business practices that we're up against. In Maryland, it was mentioned that spread pricing used to be used, even though we were trying to stop it for years in this legislature, but you know, they know best over there at Medicaid. They did an analysis of spread pricing. It was discovered that in 1 year, the spread that they were pocketing was $72 million, which equates to $6.96 per transaction, per claim, per medicine that somebody filled at the counter. They make more money on all this than anybody else in the food chain, at our expense, taxpayer expense, patient expense. And I do care about the small businesses behind us that serve in our community. But I want to mention that as I conclude. Some of these folks had the bravery, true bravery, to come before the committee, sit here, and basically beg us for help a few years ago as it related to their reimbursements. When they got back to their pharmacy, because they work a lot, I don't know if you've talked to any of these people, they work 6-7 days a week, very long days to try to make ends meet. When they got back to, the ones that testified at this table went back to their pharmacies, and they were faxed notices from the biggest PBMs in America that their contract, in their contract that they signed, could be canceled for any reason at all. Additionally, PCMA last year or the year before took out ads all around the country, including here in Maryland. I'm glad that they wrote a check to Maryland Matters because they need it. But they took out ads in some of the things that we look at and we read around here. And they produced a white old guy in his pharmacy jacket, leaving his pharmacy at 2:30 in the afternoon to go play golf, standing next to his shiny Mercedes-Benz. Let me tell you, my pharmacy, my independent pharmacy, he drives an old Subaru. And he works so that he can pay his employees, and he's just barely making it in a more affluent area, I might mention. In Baltimore City, when there were the Freddie Gray riots in West Baltimore, did CVS stay open? Nope. You know who did? The pharmacist who knew the names of his patients. He got his store open to take care of those people. So, and one last thing that I'll mention, it was mentioned by my good friend, who I'm very fond of, Mike Johansson, about these pharmacy deserts, and they know what they're doing, they're in business, if they can't make money, they shouldn't open. The Maryland Board of Pharmacy, late last year, put out a notice to, and I'll email this to everybody, put out a notice to their membership, people who are licensed by the Board of Pharmacy. And at the beginning of the second paragraph, they stated, a review of pharmacy closings through this year, we have had 23 pharmacy closings, which we are on pace to match the number of closings that occurred in 2022 if the current trend continues, which was a record year of closings. But here's where I think it gets most interesting and really, I think, highlights what's going on here. The news that's not so great is we continue to experience higher numbers of closures in the Baltimore metropolitan area, Baltimore City and Baltimore County, followed closely by Prince George's and Montgomery County. And while Montgomery County has the highest number of closings, the county has equally had the number of openings. But Baltimore City and Baltimore County has 4 or 5 times higher closings than openings. So this isn't a stable environment. It's a cherry-picked environment, and it's all about money. It's not about health care. And if those pharmacies aren't able to be where people need them, the patient suffers. And that's the other part of who we need to care about here. These small businesses, we need them in the community, but nobody's trying to make anybody rich here. We just want it to be healthy. But the patients will suffer in communities that need them the most. And with that, Mr. Chairman, I conclude my testimony.
Are there any questions for the witness, Delegate Lewis?
Thank you, Mr. Chair. Thank you, Delegate, for your well-sourced and impassioned remarks. I really was taken aback when I heard a panelist say, I'm paraphrasing, they signed the contract, they know what they're getting into. I just kind of wondering how it is that if the PBM contracts are so fair, why every year there are pharmacists in their white jackets coming in to ask us to do something. Like, either I'm missing something or what? Can you help clarify?
Well, my opinion of it is they don't have a choice. It's take it or leave it type contracts. They're trying to get better at that. You know, they're trying to band together and get better at that. But when you only have 3 payers, it makes it very hard to have, you know, any kind of leverage there. And we have been, and we went a period of years where we weren't able to pass some laws to help out, but we got better understanding, and we've been working together to try to figure out ways to really help. Bonnie Collison, she's like, I really want to figure out ways to help. And what we're finding is it's every time we help, they figure out a way to make money a different way, and it's like playing whack-a-mole. So we have to just be flexible and continue to work in this space. And I really do hope that Congress figures out a way to level the balance here so that it is a competitive capitalistic system where people have to compete with each other. Unfortunately, they don't right now. And really, the folks that are behind us are not able to survive. I'll also mention that, you know, places like CVS, they say it's a workforce problem, and there are workforce problems. But quite frankly, they have pulled back on their pharmacy presence because it's less profitable than the other aspects of their book of business. So in some ways, they're driving themselves under as well on the pharmacy side.
Delegate Morgan.
Mr. Chair, Delegate Kepke, we often hear about how much money drug manufacturers make. You mentioned in your testimony that the PBMs are extremely profitable. Can you elaborate on that?
Well, if you would like a good play in the stock market, they pay a heck of a dividend, you know, much better than a lot of other entities. But, you know, there's been lawsuits in the country where you know, you'd think wherever they can move to generic, they would because it's cheaper. It's cheaper for the payer. But there are instances in lawsuits that have been successfully played out where they will move to away from, they don't put something on generic, or they'll actually even move away from generic to brand name because they'll get paid a rebate that they don't share with their payer or the patient. So really, it's a very lucrative business, and if they're allowed to get away with it, they will.
Delegate Tavares, and then
Thank
Delegate Bhandari.
Thank you, Mr. Chair. So let me understand, as you can imagine, this is all kind of new. So are these Express Scripts supposed to be saving money for the patients that's being provided through these PBMs?
I think they have a fiduciary duty to whoever's paying the bill. And so they're negotiating for whomever is paying the bill. And that's who they're supposed to be saving money. And I do believe they also have an obligation to protect patient health, you know, so, you know, drug contradictions and things like that, they should be looking for as well.
Delegate Bhandari, followed by the Delegate Hochul.
Thank you, Mr. Chair. You referred to the Supreme Court recognition. In light of Supreme Court's recognition that states may regulate health insurance issuer and the successful implementation of PBM regulation in other states, like they have successfully done that. And there is a concern that this bill may negatively impact ERISA protected plans and result in worse outcome for Marylander for the new committee benefits, the ERISA is the federal law that establishes minimum standard for employees' benefit plans. Do you want to add something?
Well, where did that come from? Was that from PCMA? Or
The Chamber of Commerce.
okay. Well, I would look at the membership of the Chamber of Commerce first before I take it any further. But the laws that we've passed to date seeks to ensure that there's a healthy pharmacy market in Maryland with access, and the concerns raised by the Chamber have not bared out because of the laws that we've passed. As I think we've acknowledged, we've helped some ensure, I mean, there was a stark closing of pharmacies in Maryland around 2014, 2015, 2016, in that time frame. It was kind of scary. You looked at the data, it was wild. And we started to begin to take action. It had been about 10 years where we hadn't taken action. And I think we've sort of turned things around in a way that they're not closing as rapidly, but they are closing rapidly in certain areas. And so the legislation before you just puts in protections. You know, there are situations where these pharmacists will get reimbursed less than they can get the product from the wholesaler, and they have to dispense it. This is a pretty common thing within the pharmacy. And so we've put in bills that have tried to protect them from that, break even, you know, not lose money. And we would be, by passing this bill, it extends those protections to other plans. It creates a floor, a basic protection for the pharmacists.
Delegate Chisholm.
Thank you, Mr. Chair. And I'm glad you just mentioned that was part of my question, and I appreciate all the work you've done for this industry. One of the things I remember over the last 5 years was the clawback. Always talking about the clawback, and I know it's a little bit different than them having to dispense a drug at a loss. Are we still experiencing clawbacks with a lot of these smaller pharmacies, and will this bill address that?
I'm so glad you asked, because I forgot to talk about this. Pharmacists tell us that they're still having these problems. And part of the problem is we don't have this bill passed to extend the protections against things like clawbacks and the fees and all that, because there's so many plans that we don't regulate. So if we expand the protections, yes, there'll be many fewer of those types of, in my opinion, unscrupulous type behaviors, and create, you know, a little bit more of a solid base, a solid foundation for these pharmacists with their community pharmacies to stand on. And I also have asked them, have you filed complaints? And yes, they have filed complaints with the MIA, but they feel like it's futile, because if you file a complaint and then you find out a month later that it was for an ERISA exam, you know, so then they stop filing complaints. They just sort of take it. But this will help put some more teeth into our law for basic protections. It doesn't tip things in the favor of the pharmacists at all. It just gives them a slightly better fighting chance. So I hope that answers your question.
If I heard you correctly, you testified that after a pharmacist testified at a hearing down here several years ago, the pharmacist received a call threatening his livelihood.
I recall 3, and it was only those 3 that testified, received a fax that was sitting there waiting for them in their fax machine. I don't know if they're here today to remind everybody about it, but they did testify. They sent us a copy of it, as a matter of fact.
Do you know if that's a violation of the law to try to intimidate somebody who testifies before the General Assembly?
I don't know, but maybe we could look into it.
It could be, yeah. Okay. Thank you.
Thank you.
There are proponents for the bill who are here. I'd like them to come up. Stephen Weiner, Brian Hose, James Doyle, Aaliyah Horton.
Aaliyah Horton, Maryland Pharmacists Association. The Maryland Pharmacists Association urges a favorable report for House Bill 357. That, following Delegate Kipke, that's a tough act to follow. any point that I thought you may have missed, you got to, so I will leave it at that. I urge members of the committee, especially those are new, to really talk to Delegate Kipke and some of the other members, because this has been an ongoing conversation that hasn't been resolved. And I do think these provisions will help when our pharmacists do want to file a complaint, that they are actually complaining against something that the state can take a stance on and can do something about and not find out later. And I think Delegate Kipke mentioned that at the end of his testimony. So thank you. We urge a favorable report.
Mr. Weiner?
Can I have the latest time? No, that's
Sure.
my name is Steve Weiner. I own Mount Vernon Pharmacy in Baltimore City, and I would urge a favorable report. I'm also representing Epic. So Brian and smarter people, attorneys, will tell you why the Supreme Court says this is appropriate. But really, you know, if you read this section of the insurance article, it is muddy with lots of terms. The crux of it is these passing pharmacy bills don't happen in one session. We've all been here. They take 3, 4, 5 years. And quite frankly, we're sick of paying for the same real estate twice. These bills have been passed. We've compromised. They've been watered down so much. I mean, it's, you know, we have an ACE 2, 3, 4, and 6, and we're happy to have those cards. And this ERISA bill, for heaven's sake, we've argued the bills. Do you have PCMA in your office off-season telling you they can't conduct business in the state because of any bill you've passed over the last 20 years? I had hair before we started talking about pharmacy bills. So, again, that's the crux of it. The fiscal note, very briefly, talks about the part of pharmacy law that's affected. I can't seem to find it. One of its audits, we'll talk about that in a minute. But I would challenge you to tell me what part of those laws have deprived PBMs from doing their business and for the payers. Thank you. I urge a favorable report.
Mr. Hose?
Thank you, committee members again. Just quickly to touch on one question that Delegate Kipke asked. PBMs have in no way a fiduciary responsibility to anyone. They've fought very hard to make that the way it is. We've brought up fiduciary responsibility a couple times in bills over the years, and it has been vehemently opposed. So they really serve no one but their own interests. I want to be clear about that. One of the things that we've heard over decades now has been, well, the 80% of the plans are protected by ERISA, so you're just wasting your time because you're only going to be able to deal with 20% of them. You heard a little bit about that from this chair today already when one of the other discussions came up. I'm tired of it. The Supreme Court decision that came down was broad. It was very clear that all of this stuff can be regulated. We're just ready to bring the regulations forward on the parts of the stuff that we were always told, hey, you're wasting your time because this 80% can't be touched because of ERISA. That's definitely not the case. As we said all along, it finally got proven out. We're ready to bring those in as well, just so that it's not confusing as we talked about. Pharmacists don't know whether a plan is an ERISA plan or a fully funded plan. It's impossible for many of them to know that from the way that these cards are produced. So being able to have all of them in one bucket means that we know what to expect, we know when to complain, and we would truly appreciate the work that the committee has done over the years to be applied to all of these.
Thank you. Mr. Doyle?
Jim Doyle on behalf of the Independent Pharmacies of Maryland. Here's why we have this bill. Up until December of 2020, the states believed that they had no authority to regulate ERISA PBMs. And that was changed in December 2020 with the Rutledge decision, where the court said you have broad authority to regulate ERISA PBMs. Up to that point, the Maryland Insurance Code, the statute, only regulated the commercial insurance PBMs, which is about 20%. So after Rutledge, the states had the authority to regulate all of the plans, commercial, ERISA, whatever. And that's what this bill is intended to do, and that's what states are doing. And that is what this bill will do. We'll put all PBMs under the same rules in the insurance code and under the Maryland Insurance Administration. And I would just point out one thing in the fiscal note and analysis on page 3, small business effect. Small business pharmacies benefit from having state law protections in additional areas of the self-funded market and increased uniformity in the regulatory framework for PBMs. That says it all. That says this statute should be passed because it will put all PBMs under the same rules and under the same jurisdiction of the Insurance Administration and the Insurance Code. Thank you.
Are there questions for this panel? Delegate Bhandari.
Thank you, Mr. Chair. I'm wondering what are the potential benefits of expanding state regulation to include these additional entities that like provide prescription drug or coverage or benefits, and how might this promote greater transparency and accountability in the pharmaceutical supply chain?
Well, I can answer, again, I'd go back to the fiscal and policy note, which sets out on page 2 the various provisions that ERISA PBMs are now exempt from in the law because of the current status of the law, because they have not been included when they could be in the insurance code. And it talks exactly about those things that could apply to them, but don't apply to them under the current law. So, for example, information on and sale of prescription drugs. Under the current law, non-ERISA PBMs cannot have a gag clause applied to them. But ERISA PBMs can still use a gag clause where they say to the pharmacy, you can't tell a customer about a cheaper drug that he might be able to buy outside of the plan. And if you look at page 2, there's about 8 different sections of the current law that will apply to the non-ERISA plans under the current law that don't apply to ERISA plans. And what we're saying is, under Rutledge says you can apply all of these provisions to all PBM plans, including ERISA plans. They all ought to live under these same rules and have to do these same things that right now only the 20% PBMs have to do, if that answers your question.
Thank you. We thank this panel. Sarah Price. The final favorable witness.
Thank you, Mr. Chair. I am still Sarah Price here on behalf of the Maryland the Maryland Association of Chain Drugstores, which is managed by the Retailers Association. On that note, we typically do not discuss our membership on the record. It is not something that we share publicly, but I would like to clarify for the committee that we do not have CVS as a member. I know that they are causing a lot of problems in this space, and we do not work with them on any of these issues. Other than that, after the sponsor in the previous panel, I think the only thing I can say is me too. I have nothing else to add. Thank you.
We thank you. Delegate Kipke.
A lot of the talk here is related to independent small business owners that own pharmacies.
Yes.
But there have been some retail chain-style pharmacies close. I think ShopRite closed all of theirs.
Mm-hmm.
Can you expand on that? What can you share some names, or maybe you're not allowed to, but whatever you can share to put a different face on it. This isn't just these smaller individual pharmacists, right?
Right, yes, you're correct. I cannot share names of members, but I can say that the pharmacies that we work with, the community pharmacies, whether they are, a traditional chain that you would see standing alone on the corner or that are located within a grocery store, they are experiencing the same issues with PBMs that the independents are. They are just as unequally reimbursed as independent pharmacists. They largely the reasons that they may be better able to keep their doors open are because of the surrounding retail space that you walk through before you get to the pharmacy. The retail setting there is able to subsidize the operating costs of the pharmacy section itself. But when we are dealing with the predatory practices that we see from the PBMs, like they are impacting all of these pharmacies in the same way. We suffer from steering, we suffer from from low dispensing fees, from not being reimbursed for services. All of these things still impact our pharmacies in the same way. Thank you.
Thank you very much.
Thanks.
Panel of opponents. Matthew Celentano, Mike Johansson, Camille Fesh, Kimberly Robinson, Heather Cascone.
Good afternoon, Mr. Chair, members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Assurers of Maryland and AHIP in opposition to House Bill 357. For decades, state laws relating to health benefit plans, including prescription drug benefits, have only been applied to fully insured health plans subject to regulation by the MIA, and not plans exempted from the federal ERISA law. We understand the Rutledge decision has changed the landscape, but it does not change the fact that the proponents are now trying to mandate changes to plan design. By extending the provisions of prior PBM law structure to self-insured plans, these proposals will restrict the opportunity for health plans to reduce pharmaceutical costs in this space. They also come as a shock to some of these businesses that most likely have no idea these discussions are even happening, and will see an extreme drug sticker shock if this bill moves forward in their subsequent years of plan design. To distill, I think the intent of the bill misses where the financial burden lands, and that is on the businesses that are trying to design plan structures to cover their employees, and will bear the burden of the price increases with this legislation. And because of those reasons, we respectfully ask for an unfavorable report on House Bill 357. Thank you.
Whoever wants to go next.
Mr. Chairman, Mike Johansson on behalf of PCMA. When the General Assembly passed the first step into this ERISA field, it was unprecedented, had never been applied to that market. Never. This is now the second step. Then there was a host of bills that would carry it even further. The sponsor's correct. The items in this bill aren't earth-shattering, but all the other bills coming down the line would seek this same step and cause a significant problem for plan sponsors. This healthcare is big business. The top 10 companies in the Fortune 500 include Walmart, a retail pharmacy chain, Amazon, which has started a mail-order pharmacy, Apple, CVS Health, United Health, Exxon, Berkshire Hathaway, Google, and then 9 and 10 are McKesson and AmerisourceBergen. What do? They are pharmaceutical drug wholesalers. Who do they sell to? Pharmacies. Are they charging too much? When the pharmacies can't buy at a price that they are reimbursed for, is it the bad guys at the bottom part? Or is it the PBM? They enter into a contract for reimbursement. You know who negotiates their contracts? PSAOs, Pharmacy Services Administrative Organizations. Do we know who runs many of the PSAOs in the country? McKesson and AmerisourceBergen and other drug wholesalers. I agree, it's difficult to be an independent business in a business of big people. But that's where we are. And there's nothing in any one of these bills that would actually save healthcare costs. It's all going to go this way for this bill and every other bill that you hear about today. Thank you.
Good afternoon again to the chair and to members of the committee, Kimberly Robinson on behalf of the Cigna Group. Respectfully in opposition to House Bill 357. As you've heard, this is a sea change that's happening in the country because of the decision. I think that there's continues to be some disagreement about the full scope of the Rutledge decision and exactly what it permits and what it doesn't permit. I think part of the challenge is a lot of terms are being thrown around that are sort of inconsistent. Rutledge isn't about plans. PBMs are not plans. Plans are the purchasers. Plans are the carriers. And plans themselves are actually still fully exempt from state regulation under ERISA. Part of what is the challenge is determining what is plan design and what is not plan design. I know the MIA has given some opinion about that. I think the industry continues to disagree with that, and I think there are other state legislatures who actually disagree and would disagree with the reading that the MIA has given. There are state regulators in other states who disagree directly with what the MIA has given in terms of their perspective, and I think that there is drafting concerns with the way the bill is put together that have an impact about whether or not its reach is effective or would in fact be subject to an ERISA challenge. At the end of the day, I think Mr. Celentano said one of the most important things is the businesses who are going to be affected by this are not typically paying attention to what's happening in this room because historically, nothing that the General Assembly did affected their business. And I think what you are starting to see, starting with the letter from the Chamber of Commerce, however that was characterized previously, is that as businesses are starting to pay attention, they are having concerns with what you're doing about their business. And I think it's important that you start to hear from them and understand what the long-term and the larger consequence of making some of these changes will be. The goal is not to pit pharmacists against the businesses who are paying for those products for their members and their employees, but to make sure that it all works together, and I think that's a voice you should take into consideration. We respectfully request an unfavorable report.
I'm sorry, thank you for your testimony. I actually, if you see me get up, I'm having meetings, important meetings in the back. I thought we were gonna be done by now. And I'm just kidding. I'm like, okay, hopefully they're done. Just kidding. Let's see, so Kimberly.
The full panel at the table has testified.
But there's one virtually, so let
Yes.
me do the virtual one. Ms. Heather Cascone, good afternoon.
Good afternoon. Thank you, Madam Chair. Members of the committee, Heather Cascone again on behalf of PCMA. 357 seeks to redefine the term purchaser as discussed in statute in what seems to be a response to the Rutledge Supreme Court PCMA decision. It's our concern that this bill attempts to expand removal of the self-insured ERISA plan exemption currently in the definition of purchaser and appearing at various parts of the statute governing PBMs, thus broadening it beyond the Supreme Court's finding, and in doing so, affects a group of employer plan sponsors negatively. And while this case did affirm a state's authority to regulate certain rates and only those rates, it's also recognized that the potential for increased plan sponsor costs in doing so. In fact, the court specifically stated that it said that the law would raise costs for ERISA plan sponsors. Maryland already has extensive regulation of PBMs, such as benefit design or terms of drug delivery, as well as transparency into the relationships with plan sponsors. And it is those plan sponsors, other small businesses, other employers, unions, the Maryland Association of Counties, boards of education, local governments, who would all be ultimately affected and are concerned by increasing costs. We at PCMA have no opposition to this or any other state applying the Rutledge decision as it pertains to ERISA plans and MAC reimbursement laws narrowly on rate regulation, as this case was focused on this issue narrowly. But as drafted, the current bill 357 goes beyond the court's interpretation and without benefit to Maryland's plan sponsor employers. I appreciate your time. Happy to take any questions.
Thank you for being with us. I do have a question from my vice chair who's watching from home, and she wants to know the following. Can you draw a bright line between plan design and PBM financial responsibility for the carriers?
I think I could. I don't know that everybody would agree with my line. I think that is part of the discussion that has to happen. I do think that there is some court guidance around that, that we would probably need to take a look at and see how that may align with what's in the bill and what's not. So there may be legal guidance out there based on the law.
Okay. And I'm going to ask the same of the next person.
Well, I think examples of plan design are mail order, incentivizing mail order, allowing mail order, generic effective rate, reimbursement methodology, arguably may or may not be. But, the point is, just because you can regulate some of the administrative procedures of an ERISA plan, the question is, what benefit or value do you get out of it? I mean, are there, for the plans that are regulated today, are there complaints at MIA that have been found to be upheld? Right? I mean, we haven't heard any of that testimony.
Mr. Chantilano, the same question for you.
Madam Chair, I don't think the plans are a concern, and my two colleagues here have given you the answer I probably would have given.
Yeah, the plans are concerned with the law.
Oh, well, I think the plans, sorry, Madam Chair, the plans would be concerned with the law as introduced, as in the law that is intact right now. If you extend to the self-insured plans, they're going to see a price increase that I'm not sure they were prepared for.
Okay. Any other questions on Delegate Rosenberg?
Since the Rutledge decision was handed down, and I looked it up, it's December 2020, have other states enacted legislation in response to the decision?
Yes, many of them look like what Maryland did previously, not necessarily what this bill does. And I think that's part of the distinction, because I think, as Ms. Cascone said, there's a part of this that we do agree that the state does have the right under Rutledge to do. I think this bill goes into spaces where we have a debate about whether or not it falls within the scope or not within the scope of the bill, or the court decision, rather.
By that, Madam Chair?
Yes.
You mean whether it is permitted under the Rutledge decision?
Correct.
That's the
Correct.
difference.
Correct.
Thank you. Any other questions? Delegate Kipke? No? Okay. Delegate Bandari?
Yeah, Mr. Jones, what can our state can learn from the successful PBM regulation implemented in New York and Ohio that have led to increased transparency and accountability, resulting in lower drug costs for patients and improved healthcare outcomes?
I'm not familiar with New York.
I'm not either. I'd have to consult with my colleague who covers New York to give you an answer.
If you could do that offline, that would be great. Thank you for the consideration. Are there any other questions? Seeing none, thank you so much. We really appreciate it. Kathleen Lauren, will you sign up to testify for this bill? If you can come up.
This is now 374, correct?
No, we're in 357. So you want 354? Okay.
But thank you.
All right, thank you very much. So we have now, actually, we are done with House Bill 357. Delegate Kipke? You owe us dinner, Delegate Kipke. Okay, big time, they're saying, big time. So we are now going to House Bill 357. No, 380, 274. Thank you for straightening me out. That's what I get for leaving. Okay, House Bill 374, Delegate Kipke, Health Insurance Pharmacy Benefit Managers, Audits of Pharmacies and Pharmacists.
Thank you, Madam Chairman. You missed it, but I talked a lot on the previous bill to build the context for the reason why these things are important. But I'd like to have in my place one of these two gentlemen do the testimony for the bill.
All
Thank
right,
you.
that sounds good. So who would it be?
I'm happy to start.
Okay.
Brian Hose, representing my small pharmacy in Western Maryland and Epic Pharmacies. Pharmacy audits are definitely something that's a necessity. We know that that auditing pharmacists and other healthcare providers helps curb fraud. What we found, though, when we deal with these audits is that it has been taken far too far. Much of what they're requesting is strictly on drugs where they can claw back large dollar sums. drugs where they know that pharmacies tend to make mathematical errors when it comes to day supplies, things that are easy pickings for dollars to be recouped. Very little of what we see. I have never heard of a pharmacy that was audited for fraud or was closed because of fraudulent claims. We know that does happen, but it is very rare. What we see with pharmacy audits is a way for PBMs to come into pharmacies, gather a bunch of data, and hopefully find some dollars that they can claw back from the stores. Two areas that I'd like to key in on specifically, one of them relatively new. Actually, I would say both of them are relatively new to audits that we've seen. The first is a requirement that CVS Caremark put into place where you have to be able to show that you purchased a drug within 30 days of the dispensing of that prescription. So we'll set up a timeline. Say I buy a bottle of medication that has 100 tablets or capsules in it on the first of the month. I would have to dispense that product if I'm going to dispense it for a CVS Caremark patient by the end of that month. If I happen to have some of that left over next month, say I've only one patient from CVS Caremark on that drug and I dispense it to them on the first of the month, next month I can't dispense it to them again because my invoice is from over 30 days ago and I have 60 tablets or 70 tablets still left in that bottle that I can't dispense to them even though those tablets are probably in date for 3 years. So this is one of the overreaches that we've seen with one-sided contracts. We get notices for changes to this provider manual, I would say, on a weekly basis. And this is one of those that just came along and all of a sudden, hey, you got to buy stuff within 30 days. So this is one of the things that this audit bill would eliminate the need. They would allow us to use invoice data that makes sense to back up that we truly aren't committing fraud, which is what these audits should be about. The second piece that I'd like to talk about that we see a good bit now is where PBMs will ask to see banking information from pharmacies to prove that banking information, credit card receipts, and deposit statements to show that you're actually collecting copays from customers. I would love to get to open the books over at CVS Caremark and take a look at, where the money's going, how they're getting, how their deposits are going in, all of those things are proprietary business pieces that tell them whether I'm a healthy pharmacy, whether they should put a pharmacy up across the street because he's bringing in a lot of credit card deposits and all of these things are things that I would consider unscrupulous for a PBM to want to look at in my business. What we find is that when the PBM is auditing themselves, strictly a patient signing out a prescription and having a registered transaction that says it was paid for is enough to say that the prescription went to the patient. For me, I have to collect a signature. I have to attach it to the record for the patient. There's all sorts of extra requirements. The banking information is one that is just, I think, a step way too far. So I'm going to let Steve talk about some of the other portions of the bill, but those two are some of the most egregious that we've seen in audits, and this bill would eliminate those for us.
Thank you. My name's Steve Weiner from Mount Vernon Pharmacy, requesting a favorable opinion on this bill for my pharmacy for Epic. Brian's talked about a few of the more recent issues. Other things this bill does is it ties MCOs into the current audit language. Mr. Johansson mentioned, boy, we don't see many complaints at the MIA. It's because there's about 3 Care First plans in the state that are affected. MCOs are exempt, ERISA's exempt, Part D's exempt, almost everything's exempt. And that's why, we send complaints to the MIA, they don't open them. They send them back, say, it's a line of business we don't deal with, sorry about that. Other parts of audit issues, a lot of it's common sense. I just had an audit where with Optum, and they requested like 130 prescriptions and signatures, and they said you can print it all out and ship it to us. You can babysit a fax machine for an hour and a half and hope that a page doesn't get destroyed, and that's it. So I sent it to them through secure email. I got a confirmation. 5 times, and they don't have it. They respond to me with their own Cisco server. We can't find it. I attach the audit documentation to their secure HIPAA-approved private email, and they don't get it. And the auditor says, well, I think what you need to do is you need to cut the documentation down by like 20% and just send it multiple times. And my suggestion would be, if your servers can't handle the documentation load you're asking, perhaps you're asking for too much. So part of the request is, hey, if you're asking for documentation, provide a secure way that we can get it to you that's reasonable. There's a request that we can get a person within 72 hours on the phone. That's not unreasonable. There is Maryland Physicians Care, who's administered by Express Scripts. If I dispense a bottle of insulin or an inhaler and the days of supply of that product is 80 days, their computers will only take 30 days. They won't take 80. I can't cut the insulin in half with a knife and throw it at a patient. So I have to put in 30 days. And then isn't artificial intelligence wonderful? They say you couldn't submit 80 days, which I tried, which is accurate. And we see that you tried 80 and changed it to 30. So our computers, that's highlighter. We're going to come and torment you over that prescription in a year and a half, and we're going to audit it. This, lastly, and I'm done, 2008 House Bill 257 was spearheaded by Delegate Moorheim. It was the innovative audit bill in the country, started in Maryland. It was also sponsored by Delegate Kipke and Delegate Penemelnik. In 2011, it was audited, and it was, again, Dr. Moorheim spearheaded it. It was sponsored by Delegate Kipke, Dr. Penemelnik, and Dr. Cullison, Delegate Cullison. And I would urge all of you to support this common sense amendment to our audit laws again. Thank you.
Okay. Thank you so much. So are there any questions for the sponsor and his panel? Delegate Johnson.
Thank you, Madam Chair.
My pleasure.
Thank you for the bill. This is my first time getting a chance to look at the physical note. Can you comment on the physical note at all?
Yeah, so the fiscal note on this bill, it says it might cost money. We think it'll cost money. We can't quantify what it'll cost, but it should cost money. Really weird, and it's really weird because the ERISA bill, which would encompass this, the fiscal note writer said we can't determine. But on this bill, they said, yeah, it'll cost more. We don't know how much. The fiscal note on the next bill about NADAC plus 1049 is far more interesting, and I hope when we get to that bill, someone asks me about that. Thank you.
I'm glad I wasn't the only one confused by that. Thank you, Madam.
Thank you for the clarification. Are there any questions? All right, seeing none, we have now Aaliyah Horton and Sarah Price. You can get started.
Sorry, that one wasn't on.
And thank you for not touching the light. Go ahead.
Aaliyah Horton, Executive Director of the Maryland Pharmacists Association, here in support of House Bill 374 related to pharmacy audits. Again, this is another issue that we hear from our members, that it's always a concern about the predatory nature of the audits from the PBMs. And we're supportive of this bill because it does set up it sets up where the audit agent will be registered with the state, which would provide an opportunity for oversight and compliance in a way that pharmacists have a mechanism to complain about the issues that they have. It also puts guardrails on some of the punitive nature of the PBM audit practices, and both Brian and Steve, who are MPHA members, explained some of those. Because our pharmacists do spend unnecessary time and resources trying to address these audits, that as they mentioned, that they are a challenge in getting the information to the actual auditors, and sometimes it's unnecessary. And I will say, as Delegate Kipke mentioned, where in previous hearings, pharmacists got the notices about not speaking out, they also got new audits when they came back from testifying in these hearings. So there is a punitive nature that's kind of overhanging. And as I was thinking about this bill, and the impact, I have an 11-year-old, and as he would say, it's looking a little sus. It's a little suspect, you know? And so we think this bill will set some reasonable expectations for the audit so that pharmacists can respond appropriately, and to the extent that they don't unnecessarily negatively impact patient support and business operations. So with that, we urge a favorable report.
Thank you. Next, please.
Good afternoon, Madam Chair and honorable committee members. For the record, I am still Sarah Price here on behalf of the Maryland Association of Chain Drugstores. You have a written testimony. It's pretty much all been said. I will be very brief. We think it is very important to pass this legislation. Expanding the audit procedural framework and providing protections for pharmacies is critical to ensuring smooth workflow and ensuring that patients' access to care is not impeded. So we would urge a favorable report. Thank you.
Thank you. Are there any questions for these two witnesses? Thank you very much. We have the unfavorable panel. If you will be so kind and come up in the order I call you. We have Matt Santillano, Michael Johansson, Camille Fish, Kathleen Lauren, Kimberly Robinson, and will you please bring up Heather Cascone? Thank you. You can get started.
Thank you, Madam Chair.
And to the extent you can say me too, that would be great, okay?
Madam Chair, Matt Celentano here today on behalf of the League of Life and Health Insurers and AHIP in opposition to House Bill 374 as written. Carriers do not pay for audits in any capacity now and don't think it's appropriate to enable a new audit payment structure. This would be an unprecedented move. The MIA has authority to financially penalize anyone already that doesn't comply with the law, and they do so. If the MIA needs to audit a carrier, we are not provided compensation. It's quite the opposite. We actually have to compensate them, and we do not believe the compensation in House Bill 374 is appropriate. We understand that there are actually potential amendments and feedback from the MIA that address some of the concerns we have, and if this is the case, we are absolutely happy to talk through this bill and continue the work in subcommittee. But as written and introduced, we are unfavorable on House Bill 374. Thank you.
Next, please.
Mike Johansson from PCMA. We also oppose the bill. We've talked today that health plan sponsors, such as school systems or school boards, are the ones that drive our relationship, also with pharmacies. For example, a large county in Maryland issued an RFP where there were four selection criteria in addition to price. The number one selection criteria was fraud, waste, and abuse detection and prevention programs. Then it was clinical management, such as prior authorization step therapy. We'll probably talk about that later. Prospective, concurrent, and retrospective drug review, and mail order and specialty pharmacy services. PBMs do what plan sponsors ask them to do, and audits are a large part of that. In fact, most of those plan sponsors hire consultants to help design those RFPs and those requirements, such as audit, and those consultants audit the PBMs to ensure that PBMs are doing the audits they promise to do. Everyone gets audited in healthcare. The U.S. Department of Justice has banned 3,900 pharmacies from participating in any federal program due to fraud concerns. I do have a list. We talked about, cases against PBMs. Yeah, there's cases. But I have, 4, 5, 6 pages of fraud cases against pharmacies for actions that they shouldn't be doing. And sometimes these are caught in one of these audits. So we oppose the bill, would oppose any limitations.
Next, please.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson for the Cigna Group, respectfully here in opposition to House Bill I've lost my bill number, 374. I won't repeat what Mr. Celentano and what Mr. Johansson has said. I will me too to their comments. The one thing I will add is that we understand audits are uncomfortable for everyone. No one enjoys being audited. I can say that as a company who is audited frequently because our regulators have the right to do that to us and our clients do it as well. I do think that there are some provisions in this bill that do not cause me consternation. I will say there are some that cause great consternation and look forward to talking to the sponsor and the subcommittee about those things. But as introduced, we would urge an unfavorable report.
Next, please.
Thank you. Good afternoon, Madam Chair, committee members. Thank you for the opportunity today. Kathleen Loughran with WellPoint, formerly known as AmeriGroup. We are an MCO operating statewide in the state of Maryland, and our objections to this bill are primarily due to the fact that it would have the MIA regulate MCOs who contract with the state of Maryland through MDH. And I want to emphasize, we have a contractual relationship with the state of Maryland and a contractual obligation to ensure that state and federal dollars are being spent appropriately. We are happy to have the conversation with the sponsor and with others regarding whether or not there need to be changes in the Medicaid statute or Medicaid regulations vis-a-vis audits. But unlike the commercial market, we are contractors with the state of Maryland. We are not just a private entity coming in to conduct business. And these costs do have an impact to the Medicaid program, whether it's the cost of doing the audit or it's the cost of not having an audit and money inadvertently misappropriated or intentionally fraud is committed. So I therefore urge an unfavorable report on the bill as it is submitted to you today. Thank you.
Heather?
Thank you. Madam Chair, Heather Cascone for PCMA again. The National Healthcare Anti-Fraud Association estimates billions of dollars in annual losses due to healthcare fraud, and every dollar lost comes from the pocket of a consumer. And while most pharmacies are responsible stewards, not every pharmacy does the right thing. And finding them is like looking for a needle in a haystack. Pharmacy audits are a crucial tool in combating fraud, waste, and abuse for patients and plan sponsors. Audits have exposed unwanted auto refills, shipping of medications, claim submissions for medications not dispensed or prescribed, claims for medications not requested by patients, and intentional billing of one product while dispensing something else. PDMs are responsible for monitoring this data from pharmacies and comparing patterns to neighborhood pharmacies. Audits are often triggered when dispensing patterns or claims submitted look substantially different from one another. These discrepancies raise concerns and trigger audits intended to determine the cause. And while most cases there is a specific reason to do an on-site audit of a pharmacy, sometimes it's completely random or part of a plan sponsor's contractual agreement with the PBM. Ultimately, many claims need to be reviewed in context to identify anomalies or patterns. And unfortunately, in its current form, 374 places limits on how that can occur. Plans must retain the ability to preserve these investigative protections, but we do look forward to working on this bill to reach an amenable compromise. Thank you for the time.
Thank you. Are there any questions for this panel? Seeing none, I do want to, since this is the final witnesses for this bill, before I end the hearing, I will, and I spoke to my Vice Chair Collison, who's the chairman of the subcommittee on insurance, that this year I want something done. We have been here many years, many years with these bills, and we have not done much regarding this issue and the issues that we have discussed over the years that affect these pharmacies. I want something done. I'd like you to work with the chairman of the committee and come up with some compromise that we can get something passed that can give some relief. Wherever the truth lies, somewhere, obviously something's not working. So I really need to let you know that I expect something to be done this session, okay? We need to put this to rest for a little while. And I want you to work with the sponsor of the bill, with the chairman of the subcommittee, who I know I spoke with. I know she's been meeting with you, and she meets with you every Monday, and she works very hard, and I trust her. I trust her judgment to get something done this session, okay? Thank you so much. This actually ends the hearing on House Bill 374. Next, we have Delegate Kipke, House Bill 382, Pharmacy Benefits Administration, Maryland Medical Assistant Program, and Pharmacy Benefits Manager.
Thank you, Madam Chairman. Again, I spoke a lot while you were in your meeting, and I'd like to turn it over to my panel.
Thank you. Who's next?
I'll start. 382, correct?
Yes.
Yes.
Okay, so this bill mandates that a floor be set on pharmacy reimbursement. The floor is the same amount that the Medicaid fee-for-service pays for prescription drugs. The prescription pricing system in this country is sick and broken. 90% of prescriptions are paid for by a PBM, and 3 PBMs control 80% of the industry. Mr. Johansson was, I'm glad he brought it up, for 2023 on Fortune's list of top 100 companies. CVS Health was number 4. United Health Group was number 5, and Cigna Express Scripts was number 12. Berkshire Hathaway and Exxon were not as valuable as CVS Health and United Health Group. And then the question becomes, what do PBMs do? What is their purpose? And quite frankly, and I think they'll agree with me, their purpose is to save money for their clients. And I don't think, and I think your constituents don't think they're really doing that. They're self-serving. So let me just explain how contracts and pricing work. A PBM tells a pharmacy, we're going to pay you the cost of the drug, and we're going to use a formula for the cost, and that formula is our own proprietary list, and we're going to call it a MAC list. It's an alphabet soup of expressions that don't mean a lot. It just means, hey, we're going to pay you for generics at cost or under cost. They then take a contract to a payer, and they say, your contract, the cost, is going to be based on something called AWP, average wholesale price. And that cost formula is up here. Same drug, same claim. MAC, cost below cost, AWP, inflated, ridiculous metric. So the payer is paying up here. Now, if you're paying up here and I'm charged with saving you money, I can say, I can give you a 70% discount of an inflated price. Aren't I doing great? Why are people using GoodRx? And why, your constituents, does anyone in this room know someone who doesn't have insurance that's using GoodRx or that's using Mark Cuban's Cost Plus? Now, these are insured people. State of Maryland, you got thousands and thousands of bodies. And the person charged with looking after the fiscal money of the state is supposed to use that buying power. And then Brian Hose, who's one individual, can get a better price than what the PBM has negotiated? Cost is ridiculous. There's too many different definitions. There is a back to the bill, NADAC is what CMS developed because years ago in the Medicaid program, they said, we're sick of different definitions of costs. We don't trust you, pharmacist, so we are going to get invoices from every pharmacy in the country, and we're going to figure out what the real cost is. NADAC, by the way, is a pharmacy survey. They survey pharmacies all across the country. Guess which pharmacies have an outside influence on average? CVS Caremark, Walgreens, Rite Aid. More pharmacies, higher average. So the notion that NADAC can be gamed by independent pharmacies, it doesn't match the laws of mathematics and averages. Lastly, there's a fiscal note on this bill, and I don't know, last year the fiscal note on the same bill was $80 million. This year, the fiscal note on this bill is $20 million. Same bill. And the reason they can't determine the cost is there's two different prices. There's multiple prices, no one knows. Lastly, and the Medicaid Department of Health, they're the ones who can tell you what this will cost. If they looked at MCO claims in 2021 and 2022, they know how much the MCOs paid for drugs. They can total it and say, okay, these 2 years, over every pharmacy in Maryland, we paid $3 billion. And then just instead do NADAC plus 1049, and you have your fiscal note that makes sense, that will show that what we're saying will not cost the payers money. It'll save people money because you don't have contracts based on AWP up here and nothing down here. Thank you.
Next.
Brian Hose, I'm still representing Epic Pharmacies and my own independent pharmacy. Steve touched on NADAC. NADAC is the best representation of costs that the marketplace has right now. It is continuously surveyed. The other piece of pharmacy dispensing is the dispensing fee. Medicaid also knows that they need to find out what that is, and they do a survey. They have done 2 of them at this point to survey what the actual cost to dispense the drug is. That's the dispense cost if I put air in a vial and sent it home with you and counseled you on how to breathe and how to use it and what it might interact with. All of the things that go into dispensing a prescription without the drug itself go into that dispensing study. And the state has found that that cost is right around $10.50. So the numbers that this bill sets for the floor pricing are our cost for the medication and our cost to dispense you a bottle of air. So when we talk about how NADAC plus 1049 is a huge moneymaker, it's going to, you're giving pharmacies all of this revenue that they don't deserve. We're literally asking for what the medication costs and what it costs to dispense the vessel that goes with it and the counseling that's required for it. Just 2 examples in my testimony that you can see. One of the things that we see with networks where patients are steered to PBM-owned pharmacies, especially in the specialty network, you see discrepancies like this pop up, where we have a cancer drug that the average insurance reimbursed cost is around $300. I can't dispense that because it's considered a specialty medication, even though I can order it. The NADAC price for that prescription will be $17.90. Final cost, if you use NADAC plus 1049 for whatever PBM sends that to their own pharmacy, would be $28.39 instead of $300. Another good example is a multiple sclerosis drug. Again, average insurance reimbursement around $340. NADAC price would be $120. If you use that to calculate the final cost of the fair dispensing fee, you're looking at $130 instead of $340. These are just 2 examples of some of the drugs that are reimbursed at higher rates than what they should be, because again, I don't get to dispense those. So if you're going to put a lot of money in your own pocket and you want to do it through your own pharmacy, you do it through drugs that no one else can dispense. That is one of the playing field things that we're trying to level here with this type of legislation. So I'm not going to hold you guys here any longer. I'm sure you're tired of hearing my voice. I still have some hair left, thank God. But just to say that, again, this is our cost we're asking for. Thank you.
Thank you.
Jim Doyle, on behalf of the Independent Pharmacies of Maryland. Again, I'll be very brief. So if I buy a drug and the dispensing fee for that doing the correct calculations is in the order of $10.50. And apparently, talking to the pharmacists, I'm getting paid through managed care, which is managed through the PBMs, of say 35 cents as a dispensing fee. $10.50 versus 35 cents. It would seem to me I'm guaranteed that I'm going to lose money on those prescriptions. I don't see how anything else can occur. So if I am going to lose money on that, and I'm a PBM, or I'm Chamber of Commerce, or some other entity that likes to have members have someone else subsidize their true costs, I guess I'm going to love that kind of system of paying me that kind of dispensing fee versus what the actual dispensing fee is. So I think, just as a matter of public policy, this is something that has to be changed to reflect actual dispensing costs by the independent pharmacies.
Thank you. Are there any questions for the sponsor and his panel? Seeing none, thank you so much for your testimony. We have next Aaliyah Horton, Sarah Price,
Aaliyah Horton, Maryland Pharmacist
Shireen
Association.
Joseph. Go ahead.
Aaliyah Horton, Executive Director of the Maryland Pharmacists Association, in support of House Bill 382. This is a fundamental bill of what we've been fighting for years, is pay pharmacists for the medications they dispense and for the act of dispensing it, for the cost of doing it. It's that simple. The data is there. It's peer-reviewed, if you want to call it that. It's transparent. Pay for what's being dispensed. Reimburse the pharmacists for the work that they're doing. Simple. We urge a favorable report. Thank you.
Thank you. Next, please.
Madam Chair and members of the committee, my name is Sharon Joseph, and I'm here representing my small pharmacy in Baltimore and also the Independent Pharmacists of Maryland. I would like to thank Delegate Kipke for this sponsoring this bill and the committee for your continued support. I'm testifying in favor of House Bill 382. I'm sure we are starting to sound like a broken record, repeating the same story year after year, and we are running out of words to say our story, but unfortunately our situation is the same. While the PBM reps are here trying to get their out-of-state CEOs probably their second or third vacation home, our fight is for the constituents of Maryland for the right to provide them with best health care service, which is becoming impossible as we are losing money on many of the prescriptions we fill, especially brand names, including life-saving insulins. While the PBMs are fighting to preserve their stock value for their stockholders, our fight is to preserve the future of the small businesses, which is the backbone of any community. While the PBMs are trying to hide their staggering profits with spread pricing, non-transparent contracts, and other gimmicks, all we are asking for is the CMS proposed NADAC plus the dispensing fee, which is the bare minimum needed for any independent pharmacy to survive. While nobody in any field of service, including those representing the PBMs, would be willing to give away their knowledge and expertise for free, we as healthcare professionals are being forced to do so with a mocking 10 cents to 35 cents dispensing fee. Change needs to happen, and it needs to happen soon before more independents, like my friend Deepak, who's going to be testifying soon, who went out of business last year. So please vote favorable on House Bill 382 and help us stay in business and help your constituents. Thank you.
Thank you for everyone that is here in the white coat. Thank you for taking time out of work. I know that it's a big sacrifice, and everyone else as well, okay? Next.
Thank you, Madam Chair. I'm Sarah Price, here on behalf of the Maryland Association of Chain Drugstores. Me too. I'll keep it short.
Wonderful. That's lovely. Are there any questions for this panel? Seeing none, thank you so much. I'd like to call Jennifer Bremen, Michael Johansson, Camille Fish, Kathleen Logren. And then can you bring up Heather Casconi? Will you be so kind and come up? And as soon as you sit, if you can get started.
Madam Chair, I don't need to testify on this bill. Thank you.
Oh, that is great. Thank you. Go ahead. Who's next?
Good afternoon, Madam Chair, committee members. Again, Kathleen Lochran with WellPoint, also Legislative Chair of the Managed Care Organization. The MCO Association is opposed to this bill. We have testified on this bill for several years now, I think since the inception in 2019. As you can see, the purchaser, the state Medicaid program, has submitted a rather large fiscal note based on what they feel would be the impact. What we don't know is if that is a worthy impact based on what would be gained for the program and for the enrollees. I would also submit to you that this bill is drafted in such a way that it would place that under the regulation of the MIA, which again is not the appropriate entity. We contract with the state of Maryland, the Maryland Medicaid program. MDH designs the program in accordance with state and federal Medicaid laws. And in fact, MDH has been regulating PBMs who contract with MCOs. In recent years, they have prohibited spread pricing. They prohibit mail order as a sole option for an enrollee. And in fact, the bill that was before you earlier, introduced by Delegates Morgan and Kipke, all practices in that bill are currently prohibited in the Medicaid program. So I respectfully suggest that the oversight needs to remain with MDH, and MDH, as the purchaser for the state program, needs to have the flexibility to make decisions about what is best for the program, its members, and its taxpayers. Thank you for your time.
Thank you. Next, please.
Madam Chair, members of the committee, I'm Jennifer Bremen, Executive Director of the MCO Association, representing the 9 MCOs that serve 1.5 million Marylanders that are members of Maryland Medicaid. I respectfully urge you to not pass House Bill 382. I echo everything that my colleague has said, and again, urge a unfavorable report on the bill. Me too. Thank
Wonderful.
you.
Next, please.
Madam Chair, Mike Johansson on behalf of PCMA. Each of the 9 MCOs currently uses a PBM to provide their pharmacy benefit management services. Let's just look at the fiscal note. So, Madam Chair, this is actually the answer to the question you posed. How can we help? Well, this bill is $90 million a year of additional revenue to pharmacies. The state only has to pay half, so that's good. It's only going to cost $40 to $45 million in general funds, and the feds will pay the rest. But where does the money go? The department's report from 2018 looked at where dispensing occurred in Medicaid. 70% of the dispensing in Medicaid went to chain pharmacies and supermarket pharmacies, and 30% or less went to independents. So if a bill like this were to pass, $63 million in extra money goes to the large chains, and the department and the fiscal note acknowledges it's legally you probably can't reimburse differently to a chain pharmacy and an independent based on their status. But this is the type of bill that puts the state of Maryland in the decision-making seat. You are the plan sponsor for Medicaid. You can do something like this. The state of Maryland did it for fee-for-service pharmacy, and they bit the bullet and are paying the extra cost. But when you, and this committee, I know, is so carefully looking at other ways to expand access to health care, behavioral health, is it time to spend $45 million in general funds on pharmacy reimbursement when the Walmarts and the other chains voluntarily enter into contracts with PBMs to get customers in their store? And yet this bill would provide them with a significant windfall, most of the money that's in this fiscal note. So the decision is yours, Madam Chair, and the General Assembly's.
Are there any questions? Let me address that. So this is one bill, right? House Bill 374 that we have in front of us. We know the decision is ours. I asked you on the bill that dealt with audit to find a solution. So you have the wrong entity and pronoun It's not the state. It is we all have to do something. And the PBMs, they get a lot of money. You make a lot of profit, okay? So bottom line is that in other states, the PBMs are getting sued left and right, all right, for the practices. So you can put it on us, and we know what we need to do. We're here. It is actually 5 o'clock in the afternoon working on these bills, right? And we still have a lot more here, more testimony to go through. We work, as you know, because you're always invited here and treated with respect, that we do our work in subcommittee and that we're thoughtful. And that if there's a solution this committee can do, these 23 members will find it. But we work in partnership. So we are asking you to try to find some solutions this year because, as Ms. Kathleen stated, since 2019, we have seen many of these bills in some form or another. So the time has come for us to try to do something. What that something is, I don't know, which is why we listen today and we invite you to subcommittee to try to find some solutions, okay?
We will be there, particularly on the audit bill.
Thank you very much, all right? We appreciate it. Yes, Delegate Bandari.
Thank you, Madam Chair. MMCOA, this question. How can MMCOA justify its opposition to a universal reimbursement rate for PBMs when the current market is already highly concentrated with limited competition, and such a rate could actually promote more competition and potentially lead to lower costs for Medicaid program and beneficiaries? So how do you justify your opposition to universal reimbursement rate?
So my opposition to this is that my company, which is a national company in the Medicaid space in many states, has not found this to be a particularly useful tool in managing cost and reimbursement for pharmacists. And I believe, as I said earlier, this bill came in 2019. Since that time, the department has adopted a prohibition against spread pricing. They have adopted an appeals and grievance process, and they have increased rates to certain rural pharmacies. No one has looked at the impact. There's been no independent look at the impact of any of those provisions since they were adopted. Yet year after year, this bill continues to come in. And so what I would suggest to you is that the conversation needs to not only be with MCOs, but really with the Maryland Department of Health, and to whether they believe there's value, and have they looked at the NADAC pricing to determine whether or not there's value to the program. Keeping in mind that as an MCO, I have a fiduciary obligation to the state vis-a-vis the cost to the taxpayers. And more importantly, I have an obligation to make sure that the members that I am serving have access to the pharmacist that they need to see in their communities. And it's a balancing act, it's an important one, and it's one that MDH really needs to sort of take the lead with you in partnership to determine what is happening today and whether or not this bill actually makes that any better, and did the things that were implemented during this time period maybe change the landscape to a degree that this is no longer necessary, and we shouldn't be talking about this anymore.
Any other questions for this panel? Thank you so much for your time. We really appreciate you, and we'll see you. Please make yourself available for subcommittee for all the bills,
Yes.
okay?
Thank you.
Thank you. Next, we have Ms., I apologize, Deepak Kinney.
Thank you, Madam Chair. I'm in favor of this bill, and thank you for the opportunity that you've provided despite what happened. Thank you to Delegate Kipke for sponsoring this bill, and like you have said, this bill is going to keep coming back again and again until it passed, because there's no way to hide this. The PBMs do a very good job of hiding the real cost, and this is the only bill that actually has a transparent cost and a dispensing fee, a fair reimbursement. We may not, as a pharmacy, benefit from it because we had to close last year. We closed our retail pharmacy last year simply because the reimbursements were getting worse. DIR fees went from $76,000 in 2021 to nearly 60,000 in just 6 months of 2022. We had no option. What we do, why do we get into pharmacy knowing that there is such bad reimbursement issues? Because I work for chains, and it's very hard to work for these exploitative market stores. So people like me take risk and open pharmacies, and that's why you see the numbers increase, not because there is better reimbursement or anything like that. And I've suffered the consequences. I'm closing my store. What we do that PBMs do not value. I hired 3 Spanish-speaking people in my pharmacy because I'm located in a pharmacy in an area where Spanish is predominant. Do the chains do that? No. I work with charities in the area so that I could help patients who could not pay for their meds. Do the chains do? No. Do the CVSs do? No. I go to patients' homes to check if they are taking their meds. Do the chains do? No. They don't put a value to what we really do as pharmacies. That's why they can justify lower reimbursements year after year. I urge you to please consider this bill. This is the only solution that is transparent. Thank you for your support, and I urge a favorable report.
Any questions for this witness? Seeing none, thank you very much, and thank you for sharing your story. We appreciate it.
Thank you.
This actually concludes the bill hearing on House Bill 382. Next, we have House Bill 650. Delegate Johnson, Health Insurance Reimbursement and Use of Specific Pharmacies and Dispensaries Prohibition. Will you be so kind, Delegate Johnson, and bring up your panel, which is actually Kathleen McDonough, Allison Rollins, Daniel Shudock, Angus Worthen. Will you come up? And for everyone that is waiting and left, thank you for being patient with us as we listen to these bills. And we appreciate it, each and every one of you, regardless of where you are on the issue. So, Delegate Johnson, will you be so kind and get started?
Thank you, Madam Chair and members of the HGO Committee. For the record, I'm Delegate Johnson. I'm here with the stakeholders in support of House Bill 650, Health Insurance Reimbursement, Use of Specific Pharmacies and Dispensaries, Prohibitions. In 2019, the General Assembly passed legislation establishing protections for Maryland patients from steering practices by pharmacy benefit managers, PBMs, and we've heard a lot about that, as we've said in these committee today. This law prohibits PBMs from steering patients to their affiliated pharmacies over a patient's objection. Unfortunately, that law includes a huge exemption that means those protections don't apply to most vulnerable populations, patients with chronic and specialty conditions. And we've heard about a little bit about that in some of the previous testimony as well. HB 650 seeks to extend these protections to be inclusive to all patients, while maintaining certain parameters to mitigate impact on health care costs and ensure adequate specialty care across dispensing providers. Under the bill, carriers would still have the access to a variety of tools to first recommend preferred providers, set reimbursement rates and control costs, set network parameters, implement care coordination programs, set performance standards and dispensing providers, and utilize robust mail order programs when appropriate and convenient for the patients. Not for the PBMs, but for the patients. However, House Bill 650 also carves out a role for patients to choose where and how they obtain their medication when they are experiencing issues with the standard specialty or mail order protocols. Triggering issues may include delays in receiving medication, frequent changes in types of medication or dosage, coordination of oral medication with interactive infusion treatments, language or technology barriers or otherwise issues that keep them from accessing care coordination from their carriers, or waste from mail order outdated prescriptions. Our goal with this bill is not to completely overhaul the current specialty system, but to open up some avenues where patients can have a say in their pharmacy care, especially when they have a serious condition and there are real-life negative impacts on their care and health outcomes. HB 650 is supported by a comprehensive coalition of specialty patients and providers who are experiencing these issues and actively seeking a solution. I'll turn it over to my panel of coalition members to explain their experiences and solutions we hope to get through in this bill.
Thank you.
Good evening, Madam Chair and members of the committee. Caitlin McDonough here on behalf of Maryland Oncology and Hematology in support of House Bill 650. Thank you to Delegate Johnson for sponsoring the bill. And as he described, the goal of this legislation is simply to open up options for patients where the standardized specialty and mail-order drug programs imposed by PBMs are having an impact on their care and health outcomes, whether it be the delays, the waste and confusion associated with frequent medication and dosage changes, or other problems with accessing their medication. These concerns are particularly prevalent among patients with life-threatening and chronic conditions, which is why you will see that we're joined by a broad coalition of 22 other member organizations in support, representing both specialty patient and provider community. There's a couple clarifications I want to make just to ensure that the committee understands the barriers that patients and physicians and other providers experience due to steering policies that are currently incentivized under Maryland's law. One suggestion we've had as a solution is for physician dispensers to simply apply to join a carrier specialty network. That's not something that physician dispensing entities can do due to their own Practice Act, due to the state's anti-self-referral provisions, and just the limiting parameters that the state has chosen to put on physician dispensing. We're not pharmacies, so we can't be specialty pharmacies, and we can't be in a specialty pharmacy network for those reasons, even though we may look like one to the outside eye. Secondly, I think the issue that you'll hear mostly raised is around costs. So what we've attempted to do in this bill is set those rate parameters, allow the carriers to have that rate setting provision in place so they can avoid those costs. That being said, we are open to working with the sponsor, with the committee, with the MIA, and with the stakeholders to craft a narrower bill that, again, gives patients these options to choose their carrier when it's appropriate and when they're experiencing these medical problems, similar to what we see with other carrier tools like step therapy, prior authorization. And with that, I urge a favorable report, and you'll hear from the rest of the panel. Thank you.
Thank you. Next, please.
Hi, my name is Allison Rollins. I'm Senior Government Relations Manager at the U.S. Oncology Network. I serve as state health policy support for our client, the Maryland Oncology Hematology, which is the largest physician-owned community oncology practice in Maryland. So on behalf of MOH and the network, I want to say thank you for the opportunity to speak in support of HB 650. Today, you will likely hear from opponents of this bill that the passage would blow up their specialty care coordination programs, and that is not an intent that we have. This bill will not impact patients who are enrolled in these programs, as these patients have already opted into steering. They've already consented to steering. This will not blow up their ability to be in those programs. What this bill will do is prevent those policies from becoming mandatory. It will prevent policies that can only be ethically implemented through robust care coordination from applying to patients who have not elected to join care coordination programs. So care coordination services can only safely be done if the coordinators have access to the patient's full medical history. This would mean that any form of steering policies meant to improve individual patient outcomes must be informed by protected health information, or PHI. Due to the limitations of the HIPAA privacy rule, this critical patient history cannot be shared with a specialty care coordination program through their business affiliation with a health plan or a PBM, even if the program is owned by a PBM. The only way for a program to access that PHI is if they can get the patient to have written informed consent to share this information. And that is the only way to clinically justify steering these patients towards a specific pharmacy or towards a specific site of service. This makes these programs completely voluntary by nature of federal rule. And yet Maryland's current law allows carriers to persist in imposing mandatory steering policies with no clinical justification, and they're harming a large swath of patients who did not consent to this service.
Okay.
Thanks, Madam Chair. I'm Angus Worthing. I'm a rheumatologist at Arthritis and Rheumatism Associates. My colleagues and I take care of over 30,000 people a year, mostly in Maryland. We strongly support this bill because it helps prevent some of the most heartbreaking things that we see in clinic, which is the barriers people have to getting their medications.
Patients have told me about many different deleterious effects of mail-order pharmacies for their specialty drugs. The time it takes playing phone tag and being on the phone with pharmacies. The instances of mail-order packages of expensive cold chain syringes of medication being left on insecure doorsteps at inappropriate temperatures. And one patient recently told me that she could only avoid mail-order pharmacy delivery by going to her local chain pharmacy, which I think was understaffed, and she had to wait too long after a long day of work, so she couldn't do that to get her medications. She missed doses, and her inflammatory disease flared, requiring medication, steroid medication that can cause numerous side effects. Patients with rheumatoid arthritis and autoimmune diseases pay for delays with their pain. And after finally receiving mail-order medications for their first doses, there is additional delay as they wait to schedule educational sessions to be taught how to do a self-injection. So this bill would help us help our patients streamlining their care by being able to dispense medications in the physician's office, while at the same time giving people proper instructions on self-injection and disposing needles. And we can authorize and dispense new doses when disease flares at the point of care. It's only the life-changing specialty drugs that Maryland allows PBMs and insurance companies to force people to obtain at certain pharmacies. I ask you to close this important loophole in the law. Thanks for your time.
Thank you for your time today. Next, please.
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of Arthritis and Rheumatism Associates. I want to just echo the thank you to Delegate Johnson for bringing this important bill forward. I just want to focus on a couple key things. This bill really, in my mind, embodies the physician-patient relationship. They're coming together to build a care plan, care coordination that's going to work to address the disease state that they're in at that given time. And if the patient is allowed to choose where and when they get their pharmaceuticals, their prescriptions, then that's only going to add value to that care plan. When patients are steered, as Dr. Worthing was sharing, to other pharmacies, or they have to do a mail order, or they have to get it sent to another pharmacy, and then there's time constraints, they're losing that interaction at the point of care when this could be done and easily taken care of. And I want to echo again what's been said, that this is not going to disrupt the current state of affairs with the insurers. This is not intended to undo specialty pharmacies as we know it and as the PBMs and the carriers know it. As already said, again, physicians can't become specialty pharmacies, but they can dispense these important drugs. So what we want this bill to do is really cement and affirm the patient-provider choice, the patient-provider relationship. And again, we're happy to work with other parties to focus on the bill and get something workable that will address this problem that's been longstanding. So thank you.
Thank you. Are there any questions for the sponsor of the bill and his panel? Delegate Kipke.
Just a quick question, but I think it's important to the doc. You know, a big concern that's raised by the opposition is that this will increase costs. Can you help people who don't live in your world, us, understand very simply why that's not so?
Appreciate that. Yeah, you might hear that from the other side, but I am happy to be here to tell you the truth, which is that this legislation was modified last year to allow the payers to set reimbursement rates. And so I expect that if I become a dispensing physician, I'll receive the same payment that the specialty pharmacy is receiving. We're confident we can do it. We have the capacity to do it. We have actually been dispensing medication, pill form, and cold chain syringe samples to patients for years. We provide vaccines and thousands of infusions and injections as well, so we have the capacity to do that safely. I'll just add that while I have your attention, we have people's medical record updated at the point of care. We're able to check the medications that they're taking. We're able to check other diseases that they have in order to prevent medication errors, drug-drug interactions, drug-disease interactions, so we can do that as safely as possible. Appreciate the question. Thanks.
Any other questions? Seeing none, thank you very much. We have next Louis Tarp, followed by Alita Horton, Sarah Price, and Stephen. And as soon as you sit, will you be so kind and just start your testimony? Thank you very much.
Aaliyah Horton, Maryland Pharmacists Association, and we are in favor of this bill. It's come up several years, and we think there's an opportunity for some type of resolution, but I do want to just defer to Steve Weiner, who's a member of MPHA, and I know that he has a story to tell about his experience with specialty pharmacy. So I will leave it at that. Again, Maryland Pharmacists Association, favorable report, please.
Okay, Steve.
Well, I don't have much of a story, believe it or not, and I'm going to try and be brief, believe it or not. Epic supports this bill, and I think after a number of years, it's not inappropriate that we sort of revisit this sort of niche market. There was an initial promise when this legislator decided to give monopoly power over or carve out specialty drugs for certain pharmacies, and why not? I'll say it. In Maryland, it's CVS. I'll have an audit on my desk when I get back, but it is what it is. So we gave CVS a monopoly, and the promise was we've got super duper pharmacists that can do so much good things that no one else can do, and they can care coordinate, and that's going to save money, and it's going to be better for the patient. And I think it's worth revisiting how has that worked out. Have we saved money? To my knowledge, prices are escalating, and from everything I've been told, it's not from the cheap stuff I'm dispensing. It's from specialty drugs going through the roof. Any ad where you hear an IM or a MAB or something, CVS specialty monopoly in Maryland. So, talked about price, now let's talk about service. And the previous doctor talked about that. We were never told there'd be a hub and spoke mechanism where you speak with someone on the phone at home base and they ship out prescriptions to CVS's all over the state of Maryland. If you're the patient, you don't know that this CVS is just normal and the person you spoke on the phone is super duper. All you know is this one network has a monopoly and I can't get it anywhere else. Oh, and by the way, if you needed that medicine in the last 2 years, you waited 20 to 40 minutes so that pharmacy, that retail pharmacy, could make more money doing vaccinations instead of what we went to school for. So thank you. We urge a favorable report. We should revisit this.
Next, please.
Good afternoon, Madam Chairman, committee members. I want to begin by telling you that this system works.
Can you give us your name?
Louis Tharp,
Thank you.
Executive Director, Co-founder, Global Healthy Living Foundation.
Thank you.
So I want to start by saying this system works, just not for patients. We represent chronically ill patients in Maryland, and I want to thank you for allowing me to comment today in support of House Bill 650. The bill empowers patients like me. I've been steered by CVS Caremark. It prohibits PBM and insurer monopolistic practices designed to increase profits at the expense of expedient and appropriate patient care. We've been here before. Representative Johnson mentioned the 2017 bill that wound up having a loophole in it. I want to go back further. Maryland car insurance companies used to force customers into contracted repair shops after an accident. Then in 1994, Article 10-503 of the Maryland Insurance Code prohibited this. Consumers could choose their body shop. The monopoly was eliminated. Pharmacy benefit managers in Maryland are doing exactly what car insurance companies used to do: steer people into high-profit monopolies. When steering is prohibited, patients get their medication from pharmacies they know and trust. not from pharmacies that deliver the highest profits for PBMs and insurance companies. The days of Marylanders being railroaded into contracted pharmacies that only serve to enrich insurers and their PBM partners will be over when this bill is passed.
You can, you finish?
I have one more sentence.
Go ahead, go for it.
Thank you, Madam Chairman. A vote in favor of HB 650 is a vote for the balance of power in the healthcare system shifting back towards the individual. He and she are the ones who are paying the bills.
Thank you. Next, please.
Thank you.
You're welcome.
Good evening, Madam Chair and honorable members of the committee. My name is Sarah Price, and I'm here on behalf of the Maryland Association of Chain Drugstores. That does not include CVS. We are in favor of this legislation. 90% of Americans live within 5 miles of a pharmacy. People depend on their community pharmacies. They have relationships with their pharmacist. They know where they can go to get health services and their medications. You've heard examples of the negative impacts that patients with chronic care issues have suffered due to the steering practices from PBMs and the issues with mail order pharmacies. If a community pharmacy is willing to comply with and meet the requirements that are set by Maryland law, and if they are capable of dispensing specialty drugs, and if that is where a patient would like to get their medication, then that patient should not be precluded from doing so. Passing this legislation would enhance patient access to health care, and it would protect patient choice for where they would like to get their medications. So we would urge a favorable report. Thank you.
Thank you for your testimony. Are there any questions for this panel? Seeing none, thank you very much for being here. Next, we have Matthew Centellano, Michael Johansson, Camille Pesci, Kimberly Robinson, Allison Taylor, Deb Ripken, and will you be so kind and bring up the virtual one, please? Thank you. Good afternoon again.
Thank you, Madam Chair. Matt Celentano, still here on behalf of the League of Life and Health Insurers and AHIP in opposition to House Bill 650. We're actually having a hard time figuring out why we even need this bill in the first place. It seems to create more problems and it would result in definitely higher costs for consumers. The bill contains any willing pharmacy language. Maryland has rejected that any willing provider language repeatedly over the last 20 years for very clear policy reasons. It's well documented to be anti-competitive, and it drives up healthcare costs, having no clear benefit for consumers when adequacy rules are in place to ensure access to all pharmacy services. The bill also effectively dismantles specialty. One of the proponents actually has a specialty pharmacy on their site. We're unclear why the new distinction is needed, and by removing specialty designation, we're opening a complete new can of worms. It's unclear if the physicians would be able to have all the specialty drugs in stock. Would they require special handling? Would they have the right training for these drugs, et cetera? And would they only prescribe the drugs that they had in stock? Would they have the full formulary for each patient with their different healthcare or health insurance coverage? These are all questions we have no answers to. Specialty pharmacies improve healthcare affordability while protecting patient safety. Specialty pharmacies also prevent hospitals and physicians from charging exorbitant fees to buy and store the specialty medicines themselves. Secure, direct delivery that the vast majority of patients got very used to during the pandemic is more efficient and effective, and it also reduces costs. Based on CMS data on payments in Medicare and Medicaid, the average physician office markup when they are allowed to dispense in the United States is over $1,000 a cancer drug. It's over $4,000 on the MS drug Ocrevus. In the hospital space, the markups are even exponentially more. And these are just a few examples. Carriers are working every day and are struggling to manage skyrocketing prescription drug costs, and this bill just makes that challenge more difficult. So we urge an unfavorable report. Thank you very much.
You're welcome. Who's next?
I'll go next. Good afternoon again, Madam Chair, members of the committee, Kimberly Robinson for the Cigna Group. And just to be clear, although I've been speaking about PBM issues from a PBM lens, I'm speaking to you from a carrier lens. We are also a health carrier, and this particular bill really is focused on carriers. So much of the conversation has been all day today a misnomer in saying that PBMs do, PBMs choose. Purchasers choose, carriers choose, the people who are hiring PBMs to make their benefit plan what they ask for it to be are the ones who choose. And in this case, it's what carriers are asking for as they're deciding whether or not to have an exclusive specialty program, whether or not to have a medical management program. And every purchaser who picks a PBM to do the work for them does not necessarily choose that in how they design their benefits. But when they do find that it is most effective when you are coupling a specialty pharmacy in conjunction with the medical management. And so when we talk about what the cost saving is, when we look at it from a carrier perspective, what we know is that with our particular PBM, that those who take the most advantage of our specialty coupled with medical management save, on average, $110 per member per year, and that's in largely medical savings. It's not about the drugs per se, but it is what the comprehensive system built together does to help make sure that that patient is adhering, that that patient is getting good medical outcomes, and we do see the savings and why that is important. What we also know is that in the world before we did that, and for the clients and for those employers who don't choose to do that they do not experience that savings, that when they want to pick and put it together, which is their option because they make that choice about what they design, they do not experience those savings. And so this committee in the past has protected the ability to do exclusive specialty because of this outcome, and we urge you to continue to do so and give the bill an unfavorable report.
Next.
Thank you, Madam Chair, members of the committee. I'm Debbie Rivkin, Vice President of Government Affairs for Care First Blue Cross Blue Shield. Opposing House Bill 650. As you know, this is the only bill I came before you today to oppose, and that's really because over the years, every year, we come in as a carrier, not as a PBM, saying how important exclusive specialty pharmacy is to Care First. And this bill, in my opinion, having read it multiple times, will dismantle the ability for us to have an exclusive specialty pharmacy. The reason why this is so important, and I mentioned this when we had the briefing in the beginning of the session, I told you that for Care First, our drug spend is over 30% of the entire spend that we have. It's going up year after year. And what's really startling to me that you can understand about specialty drugs is that in 2021, we spent over $2.8 billion on drugs. Now, 3.8% of our members were taking a specialty drug. That's small. But that 3.8% accounted for more than 54% of the total drug spend. So we are focusing on that population to try to get them in the right programs so that we have better outcomes and lower costs. But it's not just about the cost, it's about getting them healthier. And what the exclusive specialty pharmacy arrangement does for us is we design programs around that specialty pharmacy so that members have support systems, care management programs, and we have actually seen better adherence for our members, better engagement for our members when they have their drugs from a specialty pharmacy versus when they go to a retail pharmacy, because not all of our members have contracts where they can use our specialty pharmacy. And it's very important for us to continue this program, and we would ask for this bill to have an unfavorable report. Thank you.
You're welcome. Who's next?
Madam Chair, I'm Mike Johansson on behalf of PCMA. We oppose this bill. This bill is actually a compilation of two independent bills. It's the in-office dispensing bill that this committee has seen for several years, and it's also the any willing specialty pharmacy bill. Again, specialty pharmacy is the result typically of the health plan sponsor and their hired consultant who doesn't work for the PBM. In fact, a lot of these consultants are very, tough on PBMs and how the RFPs are played out, and they always consider specialty pharmacy options. and they look at whether they're narrowly tailored, they look at how broad the specialty drug list is, but there's always a specialty pharmacy option so that they can try and save money, not only for the employer, such as your school board, local government, Maryland Chamber of Commerce representatives, but also for the members. You know, typically in a local government situation, 80% of the cost is borne by the county and 20% is borne by the enrollees. And specialty pharmacy is a way to save money. So we would oppose the bill. I would also mention in the in-office dispensing fee, it was suggested that they would accept the drug ingredient cost rate that the specialty pharmacy can buy the drug for, or the same reimbursement. I think we heard all day that in a lot of settings, they can't buy the drugs for the price that they're being reimbursed. So if a large specialty pharmacy can acquire a drug for $20,000 and a doctor's office acquires it for $25,000, do any of us think that they're not going to be back suggesting that they should be reimbursed at least the cost of the drug, if not more? So I found that a little bit telling. Thank you.
Are there any questions for this panel? Nick, sorry, 1 second. Delegate Kipke.
Thank you, Madam Chair. Just a quick question for Care First. I'm told that New York has something similar to this law. I know you don't do business there, but I think you might be able to talk to somebody perhaps at Care First there. Sure. Could you look into that and let me know what impact? It's been a couple years, and I'm curious, are they, is Care First still able to operate care coordination programs there? How's it?
Sure, I'll ask.
Thank you.
Delegate Bandari.
Yeah, thank you, Madam Chair. This is for Johnson. I was looking at very fancy, the research and the study you guys have uploaded everywhere. It says the number of independent pharmacies remains stable. And I looked at some of the data in headline. One of the it says drug makers alone set the price of drugs. But when I did further research on it, my professor told me that when you see the fancy data, always check the validity, internal validity, external validity, construct. I don't want to be very much technical here, but would you mind connecting me with the person who did this report? The only reason why I did bring this is they said drug makers alone said the price of drug. When I do the research, PBMs use variety of tactics to negotiate lower prices, including leveraging their formulary design or utilization management tools to steer patients towards lower costs. So either whatever the fact is wrong or your data is wrong.
Yeah. So the price of drugs is set by the manufacturer, the wholesaler who distributes it, and then eventually the person who dispenses it. The PBM only determines how much they're going to reimburse the ultimate dispenser. Let's assume it's a pharmacist. They set how much they'll reimburse for that drug and that service. They never set the price of the drug, which is set by the manufacturer, the person who delivers it to the independent pharmacy, and what the pharmacy then would like to charge.
Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for bringing us your side of the story. It was stated from this panel that you weren't sure that other dispensers would be able to dispense the specialty drugs, store the specialty drugs. Well, who was dispensing the specialty drugs before the specialty pharmacies? I don't know. Mr. Chillen.
I don't know the answer to that question, Delegate Johnson, but I will tell you that specialty pharmacies do more than just dispense drugs, right? And that's sort of what's going on here. And it is a sort of coordinated package of services to make sure that the patient is getting all the care they need. Ms. Rifkin sort of alluded to it, but if you are in a situation in which you need specialty drugs for Care First, you are assigned a care coordinator, a case manager immediately, which sort of helps navigate all the services that come along with specialty. I'll give you an example. Well, sure.
You made the statement that you weren't sure that other dispensers would be able to dispense or store correctly specialty drugs.
Correct.
So
Dispensers.
Yeah, pharmacies, not dispensers. Right. Ca-
All right,
But-
thank you. I
But
think he
can I-
just wanted that question answered. Can you talk to him offline?
Sure.
Okay, thank you. Delegate White, followed by Delegate Hill. And
Thank you,
just
Madam.
to remind, we still have one more bill left.
Thank you, Madam Chair. Please help me understand this. The way in which that I, understand the reading of this bill and the testimony that I've heard, that this wouldn't necessarily restrict people from choosing specialty pharmacies, but it would simply give them the option. Is that correct? They could very well still choose who they may currently use and also give them the option to identify maybe another pharmacy? It's really about choice and options. Is that fair to say? Is that correct?
Thank you for the question, Delegate White. So when the purchaser, the employer, the carrier chooses to do the specialty pharmacy program with a PBM, they are making a very specific choice, and part of what makes that effective for them is the participation in the program. So to shift that model and say that I'm going to invest in this because I'm trying to focus on this specific population of my patients or my employees, right, who have this particular condition, and now they're going to be able to, in this very piecemeal way, opt in and opt out of the program, really dismantles the program. The program really does depend on the volume. It depends on the participation. And so I think the uncertainty that comes with being able to say you can be in the program for this part, you can be in the program for the pharmacy part, ultimately, that's not what we're asked to do for purchasers. It's not how purchasers are asking their programs to be designed, and I don't know that I think that they would be supportive or continue those programs in that shift of the design.
Delegate Hill.
Thank you, and I'm going to follow up on that. So, Mr. Celentano, you said that it's not just the pharmacy, meaning the physical aspects of the thing. There are these other programmatic things, and Ms. Robinson, you sort of just spoke to that. So, and Deb, you also spoke. So what is a specialty pharmacy if it's not the pharmacy? What specifically are the wraparound services that go with it, so that we can all be clear, because I'm not clear why if it's wraparound, it can't wrap around Delegate White as well as it can wrap around me.
So the types of services that, first of all, to meet the criteria to be a specialty pharmacy, it's a higher level of criteria than to be a general pharmacy in the state, a retail pharmacy. There are additional multiple accreditations that are not done. It's not just from the state of Maryland accrediting you or giving you a license. It's URAC accreditation, and there's several others. I don't recall the name at the moment. They have one-on-one supports for specific condition. We have registered nurses that look specifically at that condition. There's 24/7 access to specialty nurses or pharmacists. They do drug and condition-specific education and counseling on medications. And the thing that's most important is the outcomes that we're seeing. I have to impress upon you that what we see year after year is that when we compare the adherence and the engagement of our members who are going to using these specialty pharmacies, we are seeing increased adherence and increased engagement in comparing them to members who are purchasing their same drugs at a retail pharmacy. Adherence is so important because when you can increase the adherence of someone staying on the drugs, they stay out of the hospital and they don't get readmitted and they're healthier. And that's the goal. And we have the evidence to show it's working. And so, yes, we could allow people to go anywhere to get their meds, but the adherence is going to go down and the engagement with the care coordination goes down.
You can follow up.
But I'm not clear on is you described all this stuff and the importance of hearing. You haven't described what the pharmacy is doing to get that experience. You described the nurse, the follow-up, and all, because that pharmacist, they're not the 24-hour support, right? So what is the pharmacist doing that these other pharmacists can't do? And what is this higher level that they're being credentialed at that these other pharmacists don't meet?
I will get you more information on that if I'm not being clear, but they have additional, all these support services that I just described with the 24/7 nurse for specific conditions are part of the specialty pharmacy. And I also want to note that the law today allows pharmacies to choose to come into the specialty pharmacy network. It's in the law today, and we in fact have 5 specialty pharmacies that have come in, that we have said come in to the network at Care First. It's not one, but we have more. So they can apply, and if they can meet the additional criteria and standards and accreditation, they can become an exclusive specialty pharmacy as part of our network and work with us to try to increase the adherence and goals that we have for our members.
You're welcome. Any other questions? Thank you very much.
Thank you.
We do have Ms. Gascon. Will you please get started?
Thank you. I'll try to be brief. Madam Chair, members of the committee, Heather Cascone for PCMA. Specialty medicines were recognized by the legislature years ago as being complex, treat highly complicated conditions, or extremely expensive. They represent just 2% of prescriptions, but amount to 51% of the total plan cost. So given these pressures, plan sponsors are really trying to use every single tool available to ensure the affordable access. When a plan decides to contract with a PBM, they still retain authority over the plan's benefit design, including who they choose to build networks of pharmacies with, and they often choose specialty pharmacies exclusively to assure high quality. Likewise, drug manufacturers often choose specialty pharmacies to be the exclusive provider of their drug. Specialty pharmacies acquire specialty accreditation as a baseline for inclusion that ensures higher levels of clinical and logistical support, as the last panelists were talking about. Specialty pharmacies were really established in response for a need to better procure, store, and dispense these drugs. We're talking about oral medications, but also injectable medications, inhalers, infused drugs. And while doctors have dispensed some of these products in the past, the industry has sort of evolved away from a much more costly physician buy and bill system where there were no cost control mechanisms like there are in the pharmacy benefit. This bill is our concern because it would revert the system evolution backward. The effect of the bill would not be a rush of willing dispensers offering new price discounts to compete with the existing pharmacies, but rather the undermining of price concessions from specialty pharmacies that offer these economies of scale and high-touch patient care. I appreciate your time, and thank you for the time to offer our concerns.
Any question for this witness? Seeing none, thank you very much for being with us today. I'm going to call once again Allison Taylor and Camille. All right. Thank you very much. Seeing that they're not here, this concludes the bill hearing on House Bill 650. Next, we have House Bill 785, Delegate Johnson and White, Health Insurance Step Therapy or Fall First Protocol Revisions.
There's a physician on the line to testify for that previous bill.
Excuse me?
Dr. Ferozvi was on the line to testify for that previous bill.
What is the name? There's someone there on the line? No?
I'm sorry, I thought he was on the line.
Yeah. I don't see anyone for this bill on the line. Do you see anyone there? No, they're for the next bill, okay?
Thank you.
It's okay. It's good to ask. Not a problem. So we concluded that the bill 650, and we're now on the last bill, House Bill 785. Delegate Johnson.
Madam Chairman, members of the HGO Committee, I'm here to wrap this party up for today.
May I stop you right there?
Yes, ma'am.
Next week, I'd like you to pick a day with Delegate Kipke, and I'd like you to treat us to dinner. I need either a lunch, okay?
Can we all chip in?
No, you, Johnson and Kipke. It was Johnson and Kipke Day. Oh, different dates.
Hey. All of our bills were on the same day.
It's been decided.
Okay, all right.
Thank you. See, that makes it, that makes the next hour doable. Go ahead.
I see that. For the record, Delegate Steve Johnson, I'm here with the stakeholders in support of House Bill 785, Health Insurance Step Therapy or Fail First Protocol revisions. It's hard to believe in our modern day of medical science and healthcare that we have something called Fail First Protocol. House Bill 785 is a continuation of the work that began in 2014 to amend policies used by the insurance companies and pharmacy benefit managers that require patients to fail first on a drug prior to using a medication most often recommended by their treatment provider. They're educated, they're experienced, and they're trained treatment provider. In 2014, Maryland enacted legislation that allows patients to stay on a drug and circumvent the step therapy protocol when a patient has been on a drug for 180 days and based on a professional judgment of the prescriber, the drug is effective in treating the patient's disease or medical condition. This exemption, however, fails to acknowledge those circumstances where the step therapy protocol in itself may be harmful or not in the best interest of the patient. Therefore, House Bill 785 requires a health insurance carrier to implement an exemption process under several circumstances, including when the step therapy drug is contraindicated. That's a long word at this time of the day.
You did well.
Maryland has fallen behind in protecting its patients. More than 24 states have enacted similar procedures, except for additional provision related to mental health. House Bill 785 is drafted based on laws in Virginia, Delaware, and West Virginia. Virginia has had its law on the books since 2020, Delaware since 2021, and West Virginia since 2022. I'm also having an amendment drafted that will align the timeframes for the carriers to respond to step therapy exemption requests to Maryland's current timeframes, as well as clarifying that any appeals that may result from a denial will be subject to Maryland's current appeals and grievance provisions. Our patients deserve the same protections afforded to patients in other states. And I have a really quick personal story for you that a friend of mine found out he had this rare illness and he had to get infusions every week. This was an expensive drug. His doctor prescribed one drug, but because of step therapy, he had to go to this other drug. 3 months into this other drug, he was so ill, but they weren't quite sure whether it was the disease or the medication. And as they went on, they realized it was the medication. The last 2 weeks, the doctor said, you know, you will do better without it. Stop taking that, throw it in the trash. So that drug, for the 6-month period that he was on it and failed, was $52,000. Now, then the insurance company let him go on the drug the doctor had prescribed originally, and 6 months later, he's doing great. But now this is one instance, but being a pharmacy owner, I have seen where the step therapy, they've gone through 2, 3, 4 medications before they will allow the prescriber, the patient to be on the medication the doctor has prescribed. So for those reasons, I say let the doctors and their education and their experience do their job. And let's let the insurance companies stop prescribing medications. So for those reasons, I would ask for a favorable report on House Bill 785 and turn it over to my panel.
All right. Who would like to go first?
Thank you very much, Madam Chair, members of the committee. My name is Dana Kaufman. I'm here on behalf of MedChi and a variety of other healthcare organizations. Delegate Johnson did a great job in laying out the bill, and I'm just going to point out a couple things. So again, this bill, and with the amendments that have been drafted, which were shared with the carriers on Monday, there was additional concerns raised, and they've been actually changed, which I'm going to talk about. It tracks Virginia, West Virginia, and Delaware almost word for word. as our bill drafting allows us to, except for one provision is in this bill regarding mental disorders. As Delegate Johnson says, those laws have been on the books now for years, and I have not heard of any unfavorable outcome by the carriers for those laws, which means that patients can go across state lines and have better protections afforded to them than they can in this state, and that's not right. This bill doesn't get rid of these policies. Actually, it just allows another exemption process where the physicians and the patients are going to have to go back to the insurance companies and ask again for permission to use the drug that they had wanted to use in the beginning. As far as the amendments, and I just also wanted to point out, the exemptions that are in current law right now, carriers might have their own exemptions, but the exemptions that are in current law or the exemption policies, it only applies to formularies and when either a drug has been removed or has been changed tiers or it's not on their formulary, which is why we need a process to make this bill across carriers. As far as the amendments, there were concerns raised about the time frame. So basically what I did was if you submit it electronically, the time frame is what's in current law, and I'm tired of listening to the electronic prior authorization. I have not found a doctor who doesn't use it for prescriptions, but if there is one, then the amendments will say, and if you use it non-electronically, you follow this current standard. So with those amendments, honestly, we're tracking other states' laws and we're conforming it to our current requirements. I'm not really sure what else I can do, so I would ask you for a favorable report.
Thank you. Next, please.
Madam Chair, members of the committee, Dan Shattuck here today in support of House Bill 785 on behalf of the Maryland Dermatologic Society. We do have a physician who's going to testify virtually and provide some real-world examples, as Delegate Johnson did, about these challenges. Dana laid out the bill really well. I just want to echo that the key, again, I think, is the patient-provider relationship. This bill will put some meaning back in the physician's prescription. It's not a suggestion. It's what the physician thinks is best for the patient. And as we heard the carriers say in the last bill hearing about the importance of adherence to the pharmaceutical regimen, that it pays dividends, it keeps the patient healthy, keeps them out of the hospital, then we need to find ways to stop putting barriers in that adherence. If the physician and the patient identify the drug that's going to work best, and if that patient is willing to do what it takes to get better and adhere to that drug, then that's great. But they shouldn't have to detour and try something else and fail first. So this bill is going to put some exceptions in. It's going to rest primarily on the judgment of the physician, which again I think is the key. They're the medical provider, they're the care coordinator. So we want to put that back in the hands of the physician. Again, we're happy to work, to make changes if we need to beyond what we've already put forward. Otherwise, I agree with Dana. This is a straightforward bill. It tracks what the other states are doing, and we ask for your favorable report.
Thank you. You could tell I was ready.
Yes.
Dana, thank you for this. Can you address the fiscal note, especially the part about the very end of it where it says it will reduce the savings of $34 million?
Sure. Thank you very much for pointing that out. So I think I'd like to say three things about that. One, I have great respect for our fiscal note writers, but there is no analysis for how that $34 million was derived. I also find it very interesting that when I looked at House Bill 305, which is the prior authorization bill, there was a sentence put into that same section that said, and I quote, "At this time, DBM cannot estimate the impact on prescription drug costs." So it took that fiscal note and made it comparable to medical expenses. This bill is only about prescription drug costs. So if DBM couldn't estimate it prescription drug cost on that bill, I don't understand how it could have estimated it on this bill with certainty. And then my last point I will make is, and this is the problem that is always the issue, is there is no offset for the additional costs that were raised, like Delegate Johnson said for the story that he pointed out. If a person or a patient has to fail first on 1 or 2 drugs, what is the cost to the system for them having to take that drug? And what is the cost to the overall system for their worsening conditions, especially if it ends them back up in the hospital or with additional health conditions that will need to be treated? So there are very many sides of this equation. And I have not heard of this breaking the banks again in the other states that have implemented it.
Thank you, Delegate Hill.
Anna, since we don't have the amendments in front of us and you say they comply with all this, I just want to be clear, because it sounds like what you're saying is the amendments will simply give providers another way of asking for an appeal, and the insurer will still be in a position of saying, no, we still want you to fail these other things, and sometimes actually take people off a drug they've been on to make them go backwards and do something else. So am I understanding that right, that it's just giving more paperwork for providers and patients to go through and not really giving what the intention of the bill was? That's what the compromise has come up to?
Yes, so basically what this bill is doing is if a treating prescriber believes that under those 4 circumstances which are currently in the bill, it would allow that prescriber and patient to basically request that because the patient falls under one of those 4 situations, that they can use the drug that is recommended and not the drug that is on the fail first protocol. And then if that insurer still says use that drug, then they can start the appeals process. But yes, they will have to submit the form, do all that additional paperwork. With regards to staying on the drug, these exceptions also do raise the issue because Maryland's current law only applies if you've been on a drug for 180 days and you're switching, you can stay. But we have found out that that's inadequate and doesn't protect patients who may, be on a plan and develop a condition, and their condition has it falls under one of those circumstances in the bill.
Delegate Bandari.
Thank you, Madam Chair. Dana, I do remember this bill was in front of our committee last year too. So based on your testimony, so can you verify, or we can be sure now that how the opponents, critics say about this bill, that a step therapy can lead to delayed treatment, increase medical cost in the long run? So we don't have to face that challenges, correct? Like the opponents of the bill say that if this bill is enacted into a law, there will be the delayed treatment and increased medical cost in the long run and can interfere with doctor-patient relationship. So that is not true, correct?
No, we don't believe it is true. We think that this is actually also costing. Again, the fiscal note is difficult to truly understand. But again, I think that the bottom line is we have patients who are having worsening conditions, and all we want is a consistent policy across all carriers where they can ask to please stay on or use another drug.
Sure.
Yeah, follow-up. So this bill will help a patient like with a mental health condition. He or she might require a talk therapy before being allowed to try medication. Does this bill help?
Yes.
Thank you.
It'll help the the patient be able to take that drug that's recommended.
Talk therapy,
Any other questions? Thank you very much for
Thank
your
you.
testimony and for your work. We now have Lori Doyle, Louis Tarp, Josh Howell.
Good afternoon, Madam Chair. My name is Josh Howe. I'm with Compass Advocacy here on behalf of the National Alliance on Mental Illness, Maryland. I'll keep my remarks brief as we've also submitted written testimony. NAMI believes that all people with mental health conditions deserve access to effective medication and treatment options. NAMI supports public policies and laws that reform step therapy in order for patients to receive the best medications on the quickest timeline, and NAMI especially supports the mental health disorder or condition exemption from step therapy or fail first outlined on page 3 of the bill. Mental health medications affect people in different ways, and individuals need to be able to access the medication that works best for them and their individual health needs. It's important that the medication decisions are carefully considered with a healthcare provider who has both extensive knowledge of the individual and available medication options. As we've heard from the sponsor panel, step therapy can also be dangerous in certain instances, and NAMI believes that the cost to individuals, families, and communities when a person must fail on a medication before getting what they need is too high. And for those reasons, we respectfully urge a favorable report.
Thank you. Next, please.
Good evening, Madam Chairwoman, committee members. My name is Louis Tharp, Executive Director, Co-founder, Global Healthy Living Foundation. I'm commenting on behalf of chronically ill patients in Maryland. Thank you for allowing me to be here to support House Bill 785. I spoke February 16 in favor of House Bill 305, the prior auth bill. House Bill 785 puts the patient first by regulating an often damaging utilization review practice regularly used by pharmacy benefit managers and health insurers to control their costs. It's called fail first. We prefer that patients succeed first. The patients GHLF represents are among the millions who are subjected to unnecessary barriers by insurance companies in their quest to increase profits, not, as insurers often say, to lower drug costs. The patient does not experience a lower cost when they fail first. In addition, oftentimes patients have to fail up to 5 times before they're finally given the prescription their doctor prescribed. The duration of this protocol is left up to the insurance company and the PBM. Using fail first, insurance companies can delay or even override a treatment plan created by a doctor and the patient to the point where permanent, irreversible damage can occur. HB 785 is about patient protection. It guarantees that healthcare protocols are implemented in the patient's interest, not the profit motives of private companies with opaque operations. When you vote, please consider that under the current system, people living with chronic illness face undue suffering, while insurers and PBMs enjoy additional profits.
Okay. Thank you. Are there any questions for this panel? Okay. Seeing none, thank you so much for being here. We appreciate it. Next, we have, if you can come as I called you, please. Matthew Chantilano, Michael Johansson, Camille Fesh, Kimberly Robinson, Allison Taylor.
Good evening, Madam Chair. I'm sure you all missed me, so I'm back. Matt Celentano.
Matt Celentano.
I am still Matt Celentano on behalf of the League of Life and Health Insurers in opposition to House Bill 785 as introduced. But we are absolutely willing to work on this bill, and I know that we're going to, as Ms. Kaufman said that she had sent along amendments that I think get us in the direction of where we need to go, and we promise to be working on this bill as we progress through session. So I'm not going to belabor the point too much, but I'll say we still have a few issues with the bill as introduced. And first and foremost, we wanted to point out that the current Maryland law requires the carriers respond to emergency drug requests within 24 hours and respond to urgent requests within 72 hours. There's also a provision in the bill that talks about real time, which we're uncomfortable with, which assumes that providers are going through the process with electronic systems. And we all know from the discussions we've had through this session that not all of them have electronic systems. And to incorporate real-time language into the step therapy bill is problematic. We're also concerned about the language that deems approval if the carrier doesn't respond in 1 day. That is more problematic, even more so than what I just talked about. If they don't have electronic systems, are we going to have a paper back and forth with one day? And if we don't get it back to us in paper or by fax in one day, that's automatically deemed approval? These are the kinds of things we're concerned with. So we are unfavorable on the bill as introduced, but like I said before, we are certainly happy to continue to have discussions on this bill, and I promise this is the last time you're going to see me today. Thank you.
Go ahead.
Good evening. I believe for the last time, Madam Chair, members of the committee, Kimberly Robinson on behalf of the Cigna Group. Mr. Celentano is right. We testified in the Senate that we are opposed to the bill as introduced. However, we have an exceptions policy for our step therapy protocol. We do not call it a fail-force protocol. That's not a name that the industry has ever adopted for this. But we do have an exceptions policy for our step therapy protocol. And we are not opposed to legislation that codifies that. Maryland is a state that doesn't happen to have it in their law. We are largely comfortable with the language from the other states, and we appreciate that Ms. Kaufman has put together amendments to move the language in this bill in that direction. Mr. Celentano highlighted a few provisions that are in this bill that are unique to this bill. That's why they're more likely to be what has caused us concern as opposed to the parts that are largely consistent. I think the amendments move in the right direction, and we look forward to finishing that work along with the proponents. So opposed as introduced, but certainly pleased to work to move the bill forward.
Thank you. Yes.
Thank you, Madam Chair. Mike Johansson on behalf of PCMA. I think, even Delegate Kerr's bill and utilization review, there's been a lot of work. People are in the room. This topic comes up in that conversation in various pieces as well. So I appreciate that, Madam Chair, we will be kind of hopefully working something out. Just again, as a reminder, when plan sponsors kind of consider what kind of pharmacy benefit they want to have, they can make determinations on how much drugs are covered and where they fit in tiers. And they often, with their consultants, are the ones who require that PBMs come up with concurrent review, step therapy, and other types of clinical management programs. So, we certainly understand the process. Maybe it could be, more uniform, but we expect these programs to be necessary to provide what our plan sponsors are asking us to do.
Thank you. And I appreciate those comments. They make the decisions, but then, sometimes you think about a policy or a decision that you make, but you don't necessarily know how it's going to work. Mm-hmm. And then you come back and you revisit it and make adjustments. So this is where we sort of are, right? To try to make sure that it works well. So thank you for being willing to work with, regarding all these bills, to come to the table and see what we can do. Delegate Hill, will you be so kind and wait? We have a couple more. Actually, why don't we open it up for questions for them? Are there any questions for this panel?
Actually raised an interesting question to me. The main issue that many of us have with step therapy, just like pre-authorization, is the insurer or the designer of the plan or the payer of the plan, the company is putting themselves between the patient and the trained medical professional who's making the recommendation. If it's not the insurer doing it, and it's the designer of the plan, the business, why is that still okay? Why is it not that the provider who knows the patient and knows the history and knows the drugs and knows the choices writes a doctor's order, and as was said, not a doctor's suggestion, and that's followed? Why is it okay that it's the payer doing it?
Yep. It's a great question. Thank you, Delegate, and we appreciate your understanding of this, more than many of us in the room. If you write a prescription for a patient, the pharmacy can fill it. The question where we come in is whether or not we will reimburse the pharmacy because it is either a covered benefit and what amount. And if our coverage plan, the benefit plan, suggests that we won't reimburse the pharmacy for that prescription, it could be something that, you believe the patient needs, the patient believes they need it, and the patient can buy it and the pharmacy can dispense it. We aren't getting in that medical decision. We are saying to get access to it under coverage, you have to start here first.
Thank you.
Seeing no other questions, thank you very much.
Thank
Really
you.
appreciate you, and thank you for working. Ms. Gascon.
Heather Cascone for PCMA. Thank you again, committee members. I'll only briefly add to my colleagues' comments. Many drugs have harmful side effects or interact adversely with other medications. STEP therapy encourages trying safer alternative therapies first. Every plan has established exceptions process that you heard about. These processes serve as a safeguard against the use of STEP therapy being too restrictive. Clearly, this is a balance, and one we are actively working to reach a compromise on with the proponents. I thank you for all of your time this evening, and I will conclude.
Thank you very much, and thank you for being willing to work with the sponsors of these bills and to try to find some type of compromise, okay? Are there any questions for this witness? Delegate Johnson.
Thank you, Madam Chair. Heather, you just said that some drugs have severe side effects or adverse effects. Who would be better than the physician to make the call on what drug that patient should have?
Surely the physician is, in a very well-suited position to make that call. Pharmacy benefit companies use groups of pharmacy and therapeutics committees comprised of physicians, specialists in the drugs that they are responsible for reviewing, to make recommendations about how drugs should be covered and under what circumstances. Certainly that's a conversation that needs to be open and have communication between the plan and the physician. And we're trying to tweak that process so it works the best way for everyone, patients foremost.
Thank you, Madam Chair.
My pleasure. Heather, there are no other questions for you. Thank you for being with us, and for everyone else, thank you for your patience, okay? We're gonna go through this. I'm going to call on Ms. Long. Will you be so kind and get us started, followed by Ms. Wood? Go ahead.
Good evening.
Good evening, and thank
My
you
name
for your
is Sharon.
patience.
I'm sorry. Oh, yes. And I'm glad that I've sat through everything today. My name is Sharon Long, and I live in Fort Washington, Maryland. I have multiple sclerosis, and it's a chronic disease of the brain, the optic nerves, and the spinal cord. And it has significantly impacted my ability to walk and stand. I am here to share my story in support of HB 785. I was officially diagnosed the day before Thanksgiving, 2018. So my family and I have been maneuvering and thinking outside the box on a daily basis how I'm going to maneuver this. But yet, I still continue to be a contributing member to society. I pay my bills, I work full-time, I pay my taxes, I volunteer, and I go to church. And I am here for everybody that is in the MS community, especially those that cannot speak for themselves. Come into the doctor's office with me for the moment. My doctor and I are talking, finishing up. He's writing a prescription for me, and in walks somebody from the insurance company, taking a prescription away that I know works for me, and my doctor and I have discussed. How dare you, first of all, do that? My doctor knows me, you don't. I'm a data point to you. That's all I am to you. And I get sicker and sicker because I am required to take an alternative drug. You got paid because of the drug that I was on that was working for me. You get paid by the alternative drug that I have to take, and then you get paid because I get side effects from the alternative drug that you forced me to be on. You made me into a guinea pig. How dare you? I am asking that we be treated like human beings because that's what we are. Please vote favorably for our bill. Thanks.
Thank you for sharing your story tonight. We really appreciate you, okay?
Thank you and good night. And I love you, Dr. Delegate Hill.
Delegate Hill, you got some loving. I love it. Loving, you deserve it. You got it. We take anything we can get. Ms. Wood.
Thank you, Madam Chair. I'm Shannon Wood, Director of Advocacy and Policy with the National Multiple Sclerosis Society. I too will be brief and just echo what Sharon Long had said. We as a society have heard from people affected by MS, by MS providers and care, hearing about the harm that step therapy poses for people affected by MS. I have further comments on the record, but happy to answer any questions, and we urge a favorable report. Thank you.
That was really good, because I tell you, you could not follow that. Are there any questions for Ms. Wood? Seeing none, and thank you for the work you do, okay, in the state of Maryland. Thank you. How about Mr. Saif Syed?
Hi. How are you? Can you all hear me?
Yes, we could hear you. How are you?
Great. My name is Dr. Saif Syed. I'm a dermatologist in practice for 19 years in Lutherville. I'm talking about the hoops like step therapy today, which in addition to many of the other tools that insurance companies and PBMs have used against patients, basically block therapy of all types. I really want to just talk about one patient. He's started in our practice 2 years ago. He was 11 years old. He is now 13 years old. We have been trying to get him approved for a biologic drug that is safe for him to use. And it has been 2 years and he has not gotten it. And he has had multiple rejections due to prior authorizations. The most recent rejection was step therapy recommendation, which recommended a liver toxic drug, methotrexate, and cyclosporin, which is a kidney toxic drug. These drugs were really developed for tumors, cancers. They're kind of antiquated. Nobody really uses them. Who would want their young son or daughter to be given these drugs as a first line? So we just prescribed for him today this drug, and we're going to be monitoring closely for anemia. We're going to monitor him for, liver failure. He could have gotten a very, very safe drug, Enbrel, which has been around for a very long time, is not an expensive biologic. Basically, we see a lot of bait and switch with insurance companies. I have 2 staff members that only deal with medication authorizations for a staff of 6 physicians. It has gotten out of control. I honestly think I'm in favor of all the bills today and against the bills. If the insurance companies had their advocates, their nurses, where are they? Why aren't they here? Why are all the pharmacists, the doctors, why are they only hearing the patients? Thank you.
Thank you for being here tonight and for speaking on behalf of your patient. And we have Ms. Van Meter. You are, I believe, our last witness, but you know what? The most important one. You're going to close us up.
Thank you.
Go ahead.
Thank you. I've been here all day too. I testified earlier. I'm with the Association for Accessible Medicines, the generic and biosimilar industry. We've been working on some of the amendments and we'll continue to work. We're very positive about some of the changes that we've seen. In particular, we just wanted to deal with one of the exemptions. You see the exemptions for AB rated generics and also interchangeable biologics. Leaving biosimilars out will leave a lot of money on the table and a lot of treatment options on the table. Unfortunately, there's been a lot of misinformation, claims that interchangeable biosimilars are somehow better and therefore are included for that reason. An interchangeable biological product satisfies the same requirements for biosimilarity as a regular biosimilar, along with regulatory requirements to show that the risk of a pharmacist switching a patient between an interchangeable and a brand product without physician approval is not greater than the risk of using the brand product without switching. The FDA has made it clear multiple times that the interchangeable designation is a product attribute, not an indication of superior quality. The FDA undertakes rigorous and thorough evaluations to ensure that all products, including biosimilar and interchangeable products, meet the agency's high standards for approval. The interchangeable products are the ones that are substituted at the pharmacy. So the interchangeables that are included in the exemptions don't have to go back to the physician and ask what they think of it. They can be immediately substituted. The ones that we would like to be included in the exemptions are the biosimilars that are given in a healthcare setting by physician or healthcare staff. We just feel that including biosimilars will increase savings and patient options. I'll give an example. This year, one of the best-selling drugs in the country will now have 7 different biosimilars. Without this exemption, Marylanders would not have the option of 7 additional biosimilars. I thank you for your time.
Thank you for being with us today and for being very patient. So, any questions? Seeing none, thank you very much for your testimony and for working on finding a compromise, okay? We really appreciate it. And for all of you that are waiting, please, on all these bills, work with the subcommittees to try to find some compromise. They're here for a reason. So let's try to get some of these done this year, all right? And the committee thanks you, and thank you for your patience, okay? You have a blessed day. For the committee, can you just hold on a minute until we're done? Yes. This actually concludes the bill hearing on House Bill 785. Thank you. We're done? 20 seconds? Okay. We're done? Okay.